Уважаемые коллеги и дорогие друзья, сегодня четвертый день 36-го Международного конгресса. Конгресс называется «Новые технологии в диагностике и лечении гинекологических заболеваний». Сегодня мы будем работать в таком режиме. С утра у нас конкурс молодых ученых. Дальше будет лекция профессора Кёхлера. Дальше профессора Степанян из Америки и все остальное по программе. Очень важная часть нашего конгресса – это всегда отбор наиболее, я бы сказала, ярких, самых молодых коллег, которые из всей нашей страны показали правильные результаты. Критерии отбора на лучшие баллы по конкурсу. Молодые, до 33 лет, мы выбирали до 30. Название доклада должно быть соответствовать новому, новой технологии или в диагностике, или в лечении. Третье. Личный вклад каждого автора. Личный вклад в клинике, в разработке операции или в анализе крупнейших международных баз данных, которые имеют действительно важное государственное значение. Для демонстрации сегодня отобраны 6 коллег. Я представляю их сегодня. Мы изучили полностью досье этих коллег. Мы посмотрели суть работы. Председатель конкурсной комиссии, я конкретно, потому что ответственность на мне очень большая. И мы сегодня представляем 6 докладов. Просьба к докладчикам. 5 минут максимум. 1 минута – вопросы и ответы. Я начинаю с Сухаревой Татьяны Анатольевны. Пожалуйста. Руководитель Сухаревой Татьяны Анатольевны Мартынов Сергей Александрович. Название темы – совершенствование диагностики и хирургического лечения пациенток с дефектами рубца на матке после операции кесарево сечения. Остальную информацию я не буду вам раскрывать. Татьяна Анатольевна Сухарева. Вам 5 минут максимум.
Доброе утро, уважаемая Лоя Владимировна, уважаемые коллеги. Позвольте представить вашему вниманию доклад на заявленную тему. Учитывая сложности диагностики дефектов рубца на матке после кесарево сечения, связанные с отсутствием общепризнанного метода исследований, а также относительно высокую частоту неудовлетворительных результатов метропластики, целью данного исследования явилось повышение качества диагностики и эффективности хирургического лечения пациенток с дефектами рубца на матке после кесарево сечения. Это трехлетнее сравнительное перспективное исследование, оценивающее различные неинвазивные и малоинвазивные методы исследования, а также 2 метода лапароскопической метропластики. В исследование включено 113 пациенток. На слайде представлены критерии включения и исключения, а также методы статистической обработки и анализа данных. Данное исследование включало 3 этапа. На первом этапе проводилась диагностика, сбор жалоб и анамнеза, расчет диагностического коэффициента дисплазии соединительной ткани. 7 пациенткам было выполнено УЗИ органов малого таза, 65 пациенткам магниторезонансная томография, 45 пациенткам эхогистросальпингография. Все исследования проводились 2 независимыми специалистами с различным опытом работы для последующей оценки воспроизводимости методов. Этот показатель говорит о разности измерений у одной и той же пациентки, полученные 2 различными исследователями. На втором этапе проводилось хирургическое лечение. В первой группе была выполнена метропластика без укорочения круглых связок матки. В второй группе была выполнена метропластика с укорочением круглых связок матки. И на третьем этапе проводился контроль результатов лечения, через 6 месяцев сбор жалоб и УЗИ органов малого таза, а также определение отдаленных результатов исследования – это наступление беременности. При анализе жалоб и анамнеза пациентки были сопоставимы между собой. Важно отметить, что частота недифференцированной дисплазии соединительной ткани у пациенток с дефектами рубца составила 50,4%, а положение матки составило 75,5% в положении ретрофлексиум. При сравнительном анализе данных нами были выявлены значимые различия в измерении основных параметров рубца между всеми методами исследования. Таблицы представлены на слайде. Так, наименьшая толщина рубца отмечалась по данным эхо-ГСГ, на втором месте МРТ и наибольшее значение при УЗИ. При оценке параметров ниши наибольшие значения были получены при эхо-ГСГ. Данное расхождение важно учитывать при определении показаний к хирургическому лечению. Далее была проведена оценка воспроизводимости методов, и, как мы видим на графиках, измерения, выполненные с помощью эхо-ГСГ и МРТ, обладают большей воспроизводимостью в сравнении с УЗИ. При этом эхо-ГСГ обладает самой высокой воспроизводимостью из этих методов. Еще одним преимуществом эхо-ГСГ является наполнение полости матки контрастным раствором, позволяющим выявлять сложные и сквозные дефекты. За период наблюдения было выявлено 4 случая сквозных дефектов, в то время как по данным УЗИ и МРТ эта серьезная патология не была выявлена. Таким образом, эхо-ГСГ можно рассматривать в качестве метода выбора оценки состояния рубца на матке после операции кесарево сечения. Второй этап заключался в проведении хирургического лечения. В первой группе 61 пациентки была выполнена метропластика без укорочения круглых связок. Методика заключается в иссечении рубцовой измененной ткани, наложении швов в 2 ряда и перитонизации. Учитывая высокую частоту недифференцированной дисплазии соединительной ткани, а также положение матки в ретрофлексе у пациенток с дефектами рубца, 52 пациенткам была выполнена метропластика с укорочением круглых связок для уменьшения натяжения ткани в зоне формирующегося аденового рубца и создания более благоприятных условий течения репаративного процесса. При анализе данных повторного анкетирования после операции было отмечено значимое уменьшение жалоб в обеих группах. При выполнении контрольного УЗИ было выявлено, что во второй группе была несколько больше толщина рубца, чем в первой группе, а прирост величины толщины рубца по сравнению с дооперационными показателями во второй группе был статистически значимо больше, чем в первой. Процент неудовлетворительных исходов в первой группе составил 9,8%, во второй группе их не было. При оценке факторов риска неудовлетворительных результатов метропластики были выявлены 2 показателя, достоверно влияющих на результат операции. Это диагностический коэффициент недифференцированной дисплазии соединительной ткани более 12 и 3 боли кесаревых сечения в анамнезе. Морфологическая структура иссеченного рубца преимущественно была представлена фиброзно-мышечной тканью. При дальнейшем исследовании было выявлено, что рубцовая ткань у пациенток с дефектом рубца на матке имеет ряд структурных отличий, с недифференцированной дисплазией соединительной ткани имеет ряд структурных отличий, проявившихся хаотичным расположением волокон и снижением количества коллагена, что говорит об измененном течении репаративного процесса у пациенток с дисплазией соединительной ткани. На основании проведенного исследования можно сделать следующие выводы. УЗИ является скрининговым методом диагностики дефектов рубца. Для принятия решения о проведении хирургического лечения необходимо выполнение или эхо-ГСГ, или МРТ. При этом эхо-ГСГ обладает бесспорными преимуществами. Более 50% пациенток с дефектами рубца на матке после кесарево сечения имеют дисплазию соединительной ткани, что является причиной неадекватной репарации, вторичного ретрофлексию матки и неудовлетворительных исходов метропластики. Таким образом, при выявлении факторов риска методом выбора является лапароскопическая метропластика с укорочением круглых связок. Спасибо за внимание.
Спасибо большое, Татьяна Анатольевна, вы уложились во времени. 1 минута, ваш вклад в эту работу.
Участие в определении научной темы работы, участие в постановке целей данной работы, обследование пациенток, участие в проведении УЗИ, МРТ, эхогистросальпингографии, также участие в проведении хирургического лечения в качестве ассистента и выполнение отдельных этапов хирургического лечения, лечение и послеоперационное ведение пациенток, анализ данных и статистическая обработка, а также представление данных в статьях, научных конференциях и оформлении патента.
Спасибо большое. Переходим к следующему претенденту. Пивазян Лаура Горовна, 24 года. Руководитель работы я, Адамян Лилия Владимировна. Работа поисковая, она была выполнена еще в студенчестве и в первом году ординатуры. В связи с важностью этого момента это метаанализ клинических исследований. Современные технологии предимплантационного генетического тестирования ПГТА у женщин с бесплодием. Кому и когда? Не более 5 минут. Прошу вас.
Здравствуйте, глубоко уважаемая Лилия Владимировна, глубоко уважаемые коллеги. Разрешите представить доклад на заявленную тему. На данный момент существует множество противоречивых работ касательно целесообразности применения тех или иных дополнительных процедур в программах ВРТ. Итак, целью нашей работы являлось проанализировать все опубликованные клинические исследования для оценки преимуществ биопсии бластоцисты с использованием ПГТА и представить обновленные данные о ее эффективности в клинических исходах в программах ВРТ. Наша работа была перспективно зарегистрирована в Международном реестре систематических обзоров и метаанализов Проспера. Критериями включения являлись женщины репродуктивного возраста, проходящие лечение в клиниках ВРТ. Согласно клиническим рекомендациям ЭШРа, использовали секвенирование НГС, рандомизированные и нерандомизированные клинические исследования, а также в качестве вмешательства и сравнения было применение ПГТА и отсутствие биопсии эмбриона в программах ВРТ. Конечными точками являлись клиническая беременность и живорождение, а также неудача имплантации и невынашивание беременности. Было обнаружено 844 исследования, 19 из которых вошли в качественный синтез. Это 6 рандомизированных и 13 нерандомизированных клинических исследований. Оценка риска предвзятости оценивалась по шкалам, предложенным обществом Кохрейн, и после статистической обработки данных было получено 14 метаанализа. Согласно нашим метаанализам, клиническая беременность была выше в группе ПГТА только у женщин старше 35 лет. Живорождение было выше в группе ПГТА у всех возрастов. И не было выявлено статистически значимой разницы в двух группах касательно показателей имплантации и невынашивания. Для снижения гетерогенности мы решили провести анализ подгрупп пациенток с заведомо хорошим и плохим прогнозом. Это привычное невынашивание беременности или неудачные попытки ЭКО в анамнезе, связанные с имплантацией. Итак, ПГТА было эффективно и статистически значимо только в когорте с плохим прогнозом. Однако оценка результатов на перенос исключает пациентов, которые от него отказались, и это главное ограничение всех исследований. Тем не менее, нам удалось найти данные для включения в метаанализ, которые оценивали эффективность на пациента. Клиническая беременность была выше после ПГТА только у женщин старше 35 лет. И также сравнение невынашивания беременности в двух группах не было статистически значимо, что подтверждает, что лечение бесплодия должно иметь комплексный подход и оценивать состояние гамет, эмбрионов, эндометрия, а также как и здоровье пациентки в целом. ПГТА повысила эффективность ВРТ, увеличив клиническую беременность и коэффициент живорождения, особенно у женщин позднего репродуктивного возраста и у женщин с плохим прогнозом. И не было выявлено преимуществ при применении у молодых женщин с хорошим прогнозом, согласно нашим результатам. Однако нам необходимо больше исследований хорошего качества для более доказательных, убедительных ответов на все вопросы. Но должны учитываться вопросы этики. Итак, ПГТА. Быть или не быть. Особое внимание должно быть уделено междисциплинарному подходу в лечении бесплодия, сопутствующие заболевания, гинекологическая патология и другие факторы. У пациентов с повторными неудачными имплантациями ПГТ должно быть проведено вовремя, не дожидаясь осложнений. Однако иногда ПГТ приводит к сомнениям со стороны пациента и отказывает в проведении переноса эмбриона. Пациенты должны быть проинформированы о всех возможных рисках. Также важно не игнорировать мозаичные эмбрионы, так как есть данные, что перенос мозаичных эмбрионов приводит к рождению здорового ребенка. Итак, результаты данной работы, обзор литературы, принят к публикации в журнале «Проблемы репродукции», и метаанализ проходит рецензирование в журнале Американского общества репродуктивной медицины. Тезис работы был представлен в качестве устного доклада на Конгрессе в марте этого года в Венеции в Италии. И в заключение. Клиническая беременность и живорождение были выше в группе пациенток с ПГТА у женщин старшего репродуктивного возраста с плохим прогнозом. Согласно нашему метаанализу, ПГТА не имела влияния на клинические исходы ВРТ у молодых пациенток в сравнении с отсутствием вмешательства. Лечение бесплодия должно иметь комплексный подход и оценивать состояние гамет, эмбрионов, эндометрия, так же, как и здоровье пациентки в целом. Пациенты должны быть проинформированы о всех возможных рисках. Итак, любая дополнительная процедура ВРТ должна иметь строгие показания, обсуждена с пациентами и выбрана ими, так как иногда ВРТ может ограничивать возможности достижения спонтанной беременности. Хотелось бы завершить свою презентацию словами академика РАН Адамяны Владимировны. Сегодня наши пациенты — это не только женщина и плод, но и эмбрион, ооцит и сперматозоид. Мы должны нести ответственность за каждый шаг. Спасибо за внимание.
Ваш личный вклад в эту работу?
Мой личный вклад — это разработка и проведение метаанализа, сбор и анализ, статистический анализ материала, поиск литературы, перспективная регистрация протокола, написание статей как на русском, так и на английском языке, подача в журналы, подготовка материала к конференциям на английском языке и конкурс молодых ученых.
Спасибо большое. Переходим к еще докладчику. Шумейкина Анастасия Олеговна. Новосибирск, 23 года. Клиника морфологическое обоснование, лечение рецидива рака шейки матки. Прошу вас.
Добрый день, глубоко уважаемая Лейла Владимировна, уважаемые участники. Я студентка 6-го курса Новосибирского государственного университета. Рак шейки матки сегодня остается актуальной проблемой. Заболеваемость и смертность как в Российской Федерации, так и в мире остается на высоком уровне. Основные методы – это хирургическое лечение, лучевая терапия и лекарственная терапия. Но, к сожалению, до 70% возникают рецидивы. Целью нашего исследования было изучить эффективность и переносимость стереотоксической лучевой терапии у больных с рецидивами рака шейки матки. Мы поставили следующие задачи: оценить на основании ретроспективного анализа эффективность лечения рецидивов рака шейки матки и отдаленные результаты лечения больных, оценить частоту и выраженность лучевых реакций, изучить ангиогенез в опухоли шейки матки, изучить PDL-1 статус пациентов и разработать математическую модель прогнозирования каждого из типов рецидивов и летальности. Был проведен ретроспективный анализ за 2011 и 2022 годы на базе центра имени Мишалкина. Исследование PDL-1 статуса и ангиогенеза – это перспективный набор. Всего было набрано 100 пациентов, они были разделены на 4 группы в зависимости от локализации рецидива. Критерии включения и исключения представлены на слайде, группы были сопоставимы. Диагностика осуществлялась клинически, приведен пример местного рецидива, пример метастазов в надключичные паховые лимфоузлы и с помощью данных компьютерной томографии интраоперационных данных. Это местный рецидив после трафилэктомии. Также ультразвуковые данные. Были выбраны 4 основных группы методик. Это стереотоксическая лучевая терапия, химиолучевая терапия, лекарственная терапия, хирургическое лечение. Наиболее часто, по нашим данным, встречались локорегионарные рецидивы в 29% случаев. Также мы проанализировали их в зависимости от стадии и выявили, что с увеличением стадии заболеваний уменьшается количество местных рецидивов, но увеличивается количество локорегионарных и отдаленных. Также после трансплантации яичников достоверно больше было местных рецидивов, и после операции Вертгейма, так же как после хирургического метода, увеличивается количество местных рецидивов. После применения химиолучевой терапии, напротив, уменьшается количество местных рецидивов, но увеличивается количество локорегионарных рецидивов. Мы оценили непосредственную эффективность лечения через 3 месяца, и стереотоксическая лучевая терапия показала достоверно более высокую эффективность по сравнению с группой лекарственной терапии и группой хирургического лечения. Оценка производилась на основании шкалы RECIST. Представлены примеры применения стереотоксической лучевой терапии. Это крылья подвздошной кости, очаг, параортальные лимфатические узлы и рецидив в культе влагалища. Мы отследили отдаленные результаты. Одногодичная летальность для всей группы составила 9%, для 5-летней выживаемость составила 52%. В зависимости от локализации рецидива наиболее прогностически неблагоприятны оказались группы местных и множественных рецидивов 12%. 5-летняя выживаемость была отмечена наименьше, также в группе множественных, это 47%. И в зависимости от метода лечения рецидива также проанализировали. Здесь стереотоксическая лучевая терапия показала достоверно более низкую одногодичную летальность, всего 6% по сравнению с другими группами. Пятилетняя выживаемость также 62%, что выше, чем в общей группе. Лекарственная терапия составила 34%, что объясняется тем, что применяется в тех случаях, когда невозможно применение других методов. У всех пациенток была проведена стереотоксическая лучевая терапия в запланированном объеме, осложнения и реакции соответствовали первой и второй степени тяжести. И мы выявили предикторы для каждой группы рецидивов. Для местных это маточно-параметральный вариант роста опухоли, первая стадия заболевания. Для группы локорегионарных рецидивов эндофитная форма роста опухоли, химиолучевая терапия в качестве первичного метода лечения, параметральный вариант роста опухоли. Для группы отдаленных это влагалищно-параметральный вариант роста опухоли. Гистотип аденокарцинома является неблагоприятным фактором. Для группы множественных это гистотип аденокарцинома, эндофитная форма роста опухоли, третья стадия заболевания. И мы выявили предикторы летальности в группе у пациенток с рецидивами, то есть факторы, которые достоверно увеличивают риск наступления летальности. Сердечно-сосудистая патология сопутствующая практически в 7,5 раз, уретрогидронефроз в 3 раза выше риск, химиолучевая терапия за счет стадии, на которой применялась в 2,5 раза, и эндофитная форма роста опухоли. Также проводилась иммуногистохимическая оценка с помощью маркера CD34, исследование ангиогенеза, в дальнейшем для назначения антиангиогенных препаратов. И мы видим уменьшение площади кровеносных сосудов в опухоли, что говорит об эффективности применения неадъювантной химиотерапии. Перспективный набор – это также исследование PDL-1 статуса для назначения иммунотерапии. Мы выявили, что необходимо исследовать PDL-1 статус, сразу же не дожидаясь возникновения рецидива, для того, чтобы в дальнейшем возможно было сразу назначение иммунотерапии. Выводы представлены на слайде, то есть мы оценили эффективность через 3 месяца, оценили отдаленные результаты, исследовали ангиогенез и иммунный статус больных. Данные были опубликованы в следующих журналах. И следующий доклад. Большое спасибо за внимание.
Анастасия Олеговна, ваша работа архиважная. Скажите, пожалуйста, ваш личный вклад, вам 23 года, правда, предыдущий был 24, еще в студенчестве, ваш личный вклад максимум минута.
Мой личный вклад – это участие в операциях, участие в консультативных приемах, это набор материала, создание электронной базы данных с пациентами, анализ медицинской документации, интерпретация патоморфологических данных, статистическая обработка данных, написание статей и публикация их, и выступления на конгрессах, в том числе и международных.
Спасибо большое. Уважаемые коллеги, слово представляется Лукьяновой Ксении Дмитриевне, Екатеринбург, 30 лет. Генетические предикторы развития дисфункции тазового дна у женщин после родов. Как видите, я выбираю только те работы, которые имеют прямое значение для нашей медицины и хирургии в гинекологии. Прошу вас, максимум 5 минут.
Здравствуйте, глубоко уважаемая Лейла Владимировна. Здравствуйте, уважаемые коллеги. Разрешите представить доклад на заявленную тему. По данным Росстата, в 2020 году численность женского населения репродуктивного возраста составила 38,3% от общего количества жителей Российской Федерации. По данным ВОЗ, в мире происходит около 140 миллионов родов в год. Во время беременности происходят анатомические, физиологические изменения тазового дна, реорганизация соединительной ткани, которые носят адаптационно-приспособительный характер, и их прогрессирование возможно в послеродовом периоде. Дисфункция тазового дна представляет собой мультифакторное заболевание, включающее в себя пролапс тазовых органов, недержание мочи, анальную инконтиненцию, сексуальную дисфункцию и тазовую боль. На начальных этапах нарушение тазового дна протекает практически бессимптомно, начинается в репродуктивном возрасте, чаще это случается после родов, диагностика их затруднена, и как следствие лечение становится отложенным. Неоспоримый вклад в развитие тазовой дисфункции вносит процесс родов и сам факт беременности, оказывая значительное влияние на ослабление тазового дна. Но в настоящее время ведется активный поиск генетических маркеров развития дисфункции тазового дна. Описано около 32 генетических детерминант, полиморфизм которых обуславливают функциональные нарушения тазовых органов при пролапсе гениталий. В качестве генов кандидатов были рассмотрены 3 гена. Это ген коллагена первого типа альфа-1, ген альфа-рецептора эстрогена, ген рецептора витамина D. Цель исследования было оценить влияние полиморфизма генов коллагена первого типа, рецепторов эстрогена и витамина D на раннее формирование дисфункции тазового дна у женщин после родоразрешения. Было проведено перспективное когортное исследование с участием 120 женщин после родоразрешения. В основную группу вошли 81 женщина через 6 месяцев после родов с развитием дисфункции тазового дна, во вторую контрольную группу вошли 39 женщин через полгода после родов без дисфункции тазового дна. В структуре дисфункции тазового дна среди женщин основной группы преобладали изъяния половой щели, и у 60% женщин развился пролапс тазовых органов. Была определена статистическая значимость при оценке возраста женщин и развития дисфункции тазового дна. Средний возраст пациенток основной группы составил 30 лет. При изучении антропометрических показателей межгрупповых достоверных различий не было выявлено. При оценке родоразрешения статистически значим был паритет родов. 55% женщин с дисфункцией тазового дна были повторно родящими. Достоверных различий по способу родоразрешения и акушерского травматизма среди исследуемых групп получено не было. Статистически значимых различий по весоростовым показателям новорожденных и патологии беременности также получено не было. Чаще у женщин встречался гестационный сахарный диабет, анемия. Достоверных различий между группами по наличию экстрагенитальных заболеваний получено не было. Чаще встречалась варикозная болезнь как одно из проявлений дисплазии соединительной ткани и патология желудочно-кишечного тракта. В ходе данного исследования проведено типирование полиморфизма генов, кодирующих белки, участвующие в формировании соединительной ткани коллаген первого типа, генов рецепторов к эстрогену и витамина D. Статистически значимых различий в частоте аллелей и генотипов по полиморфным маркерам исследований генов коллагена первого типа и рецептора витамина D в обеих группах получено не было. Распределение частот по полиморфным локусам исследуемых генов показало статистически значимые различия в частоте полиморфного аллеля 351 и аллеля 397 эстрогенового рецептора. Вариант гена эстрогеновых рецепторов 351 GG регистрировался значимо чаще у пациенток с дисфункцией тазового дна после родов. Использование мультипликативной генетической модели позволило установить, что среди пациенток с дисфункцией тазового дна через полгода после родов носительство минорного аллеля G полиморфного маркера эстрогенового рецептора 351 встречается чаще, чем среди здоровых женщин. Наличие аллеля G увеличивает шанс для развития дисфункции тазового дна. При анализе рецессивной модели наследования показано, что генотипы 351 AG и АА гена эстрогенового рецептора в совокупности имеют протективный эффект в отношении развития дисфункции тазового дна. Генотип 351 GG эстрогенового рецептора можно расценивать как генотип риска развития тазовых дисфункций после родов, так как его носительство увеличивает риск развития данного заболевания. При анализе доминантной модели наследования показано, что присутствие в генотипе вариантных аллеля 397C гена эстрогенового рецептора и аллеля 351G гена эстрогенового рецептора в гомо- или гетерозиготном состоянии повышает риск развития дисфункции тазового дна. Были сделаны выводы, что у 67% женщин через полгода после родоразрешения развивается дисфункция тазового дна, установлено влияние полиморфных локусов гена эстрогенового рецептора альфа, определяющий повышенный риск развития раннего развития дисфункции тазового дна у женщин после родоразрешения. У пациенток более старшего возраста статистически значимо выше риск развития дисфункции тазового дна в сравнении с более молодыми женщинами, и пациентки после повторных родов подвержены более высокому риску развития дисфункции тазового дна в сравнении с первородящими женщинами. Благодарю за внимание.
Ксения Дмитриевна, это часть вашей научной работы, кандидатской?
Да. Все верно.
А на каком этапе завершения она?
Впереди предзащита. В
То есть
ближайшее
это
время уже.
оформленная ваша работа, да. Мы стараемся принимать работы, которые не являются непосредственно темой диссертации. Спасибо. Ваш личный вклад в эту работу?
Мой личный вклад – это разработка структуры исследования, поиск научной, отечественной и зарубежной литературы по данной теме, отбор, обследование, динамическое наблюдение пациенток, анализ и статистическая обработка полученных результатов, представление результатов на научных конгрессах.
Не надо смотреть на бумаги, пожалуйста. Вы говорите прямо в кадр. Вы уже готовитесь к защите, это неправильно. Еще что?
Публикации по данной теме, подача патентов тоже по результатам нашего исследования.
Хорошо, спасибо.
Благодарю.
Слово представляется Ирен Эдуардовне, 26 лет. репродуктивное здоровье и зависимость к психоактивным веществам. Современные технологии в диагностике. Эта работа, можно сказать, заказная, потому что от нас, потому что роль сегодня в демографическом таком кризисе относится и к эпигенетике. Поэтому есть много факторов, которые влияют на репродуктивное здоровье. Сегодня идет проект «Пилотное репродуктивное здоровье», и мы просили разработать эту тему на основании международных опубликованных данных. Особым вниманием на влияние репродуктивного здоровья, вернее, вот психогенных факторов, репродуктивное здоровье и выявление тестов. Я это объявляю потому, чтобы было понятно, что в этой работе очень важная часть выявления тестов и предикции. Пожалуйста, Ирина Эдуардовна, вам слово.
Здравствуйте, уважаемая Элла Владимировна, здравствуйте, дорогие коллеги. Разрешите представить свой доклад на заявленную тему. Хочется отметить, что мы в последние годы видим, как активно внедряются программы, нацпрограммы здравоохранения и репродукция. И при реализации данных нацпрограмм, конечно же, в первую очередь идет вопрос об укреплении общественного здоровья, о повышении демографических показателей, снижении негативных факторов на репродукцию женщин страны. И, конечно, учитывая, что применение психоактивных веществ в основном в большей степени оказывается на населении, которые еще не реализовали свою репродуктивную функцию, необходимо идентифицировать факторы риска, которые оказывают психоактивные вещества на репродукцию. Таким образом, целью нашего исследования явилось определение влияния употребления психоактивных веществ девочками и подростками на репродуктивное здоровье и оценить роль современных технологий в диагностике зависимости к психоактивным веществам у девочек-подростков и женщин репродуктивного возраста. Для достижения данной цели были поставлены задачи, представленные на слайде. Также хочется отметить, что применение психоактивных веществ в раннем возрасте напрямую влияет на развитие и установку менструального цикла, на уменьшение авариального резерва. У девочек, применяющих психоактивные вещества в раннем возрасте, показатель АМГ снижается на 25% быстрее, чем у женщин, которые не употребляют психоактивные вещества. Конечно же, влияние оказывается и на нарушение и задержку полового развития, но при этом же меняются и репродуктивные установки, так как в этой когорте пациенток чаще встречается раннее начало половой жизни, повышенное количество половых партнеров, развитие нежелательных беременностей, и рост числа абортов и развитие инфекций, передающихся половым путем с сопутствующими гинекологическими заболеваниями. Уже доказана роль применения психоактивных веществ на созревании фолликулов, что приводит в юношеском возрасте к формированию синдрома поликистозных яичников с дальнейшими нарушениями и развития других гинекологических заболеваний. Также хочется отметить, что применение этанола негативно влияет и подавляет ген-супрессор опухоли роста BRCA1, и в репродуктивном возрасте у таких девушек чаще встречается рак молочной железы. Конечно же, применение психоактивных веществ во время беременности – это самая такая глобальная проблема, потому что на разных триместрах применение различных психоактивных веществ по-разному сказывается, действует принцип «все или ничего», то есть либо беременность пролонгируется, либо она прекращается, встречаются различные пороки развития, абстинентный синдром. В третьем триместре это чаще встречается синдром задержки роста развития плода, преждевременные роды. И нами были проанализированы национальные программы стран. Всего было включено 10 нацпроектов, которые помогают предотвращать зависимость психоактивным веществам среди молодежи, также современные лабораторные методы диагностики, и нами был внедрен рискоориентированный подход. При анализе мы бы хотели акцентировать внимание на 3 страны, скажем, лидеры антирейтинга психоактивных веществ, которые применяют именно в молодежном возрасте. И мы отмечаем, что спустя 5 лет наблюдений среди слушателей просветительских лекций встречается положительная динамика, изменяется формат общения, изменяется формат обучения и, конечно же, употребление психоактивных веществ и в целом показатели репродукции. Если говорить о современных лабораторных технологиях в диагностике в зависимости к психоактивным веществам, то на данный момент лабораторная диагностика способна не просто определить наличие или отсутствие каких-то компонентов психоактивных веществ в данном моменте в биоматериалах, но и определить как хроническое употребление различных психоактивных веществ, так и генов, которые приводят к развитию данной зависимости. И такой подход, который на данном моменте, к сожалению, находится только на стадии доклинических исследований, поможет нам в будущем проявлять какие-то более детальные, персонализированные подходы к лечению и фармакотерапии, и также введение эпигенетических стандартов по лечению данной зависимости. Нами был внедрен рискоориентированный подход согласно модели фарма, благодаря которому мы могли идентифицировать организационные, клинические, управленческие и социальные риски. На слайде представлена карта рисков. Риски разделены по вероятности наступления событий и по серьезности последствий. И также классифицированы как чрезвычайно высокие риски, значительные риски, средние риски и низкие риски. Данная карта нужна для того, чтобы именно комплексно подойти к проблеме профилактики применения психоактивных веществ, особенно среди девочек-подростков и, конечно же, в том числе среди женщин репродуктивного возраста. К сожалению, большой проблемой также остается выявление данной зависимости на акушерском приеме и гинекологическом, особенно если это речь идет о пациентках детского и подросткового возраста. Нами была разработана анкета-опросник для выявления основных зависимостей к психоактивным веществам, благодаря которой врач на приеме сможет оценить и предотвратить данный фактор риска. На слайде представлены выводы, разрешите на них не останавливаться. Благодарю за внимание.
Скажите, пожалуйста, Ирина Эдуардовна, личный ваш вклад, понятно, что это огромный массив данных. Что вы сделали в этой работе, кроме того, что проанализировали огромное количество и материалов, литературы, мега разных проектов? Ваш вклад еще практически.
Практический вклад заключается как раз-таки в суммировании этих данных, выставлении всех рисков, систематизация этих рисков и создание же на основе этих данных анкеты, благодаря которым мы можем на гинекологическом приеме выявлять эти риски и с самых начал, уже с детского и подросткового возраста, проявлять политику по минимизации данных рисков и сохранить репродуктивное здоровье.
То есть вы помимо анализа разработали анкету? Правильно я понимаю?
Да.
Хорошо. Уважаемые коллеги, слово представляется Иванову Олегу Александровичу. 25 лет, акушер-гинеколог, руководитель Беженарь. Современный шовный материал и влияние на него энергии для коагуляции. Прошу вас, не более 5 минут. Мы отстаем от программы.
Доброе утро, глубоко уважаемые коллеги, уважаемые жюри. Меня зовут Иванов Олег Александрович. Для меня сегодня огромная честь выступить перед вами с результатами нашего исследования, а именно касается влияния энергии для коагуляции на шовный материал. Попрошу, пожалуйста, модераторов включить презентацию. Наблюдая за ходом различных операций, я заметил, как многие достаточно именитые врачи, не жалея, используют энергию для коагуляции в зоне шовного материала для достижения гемостаза, будь то монополярная коагуляция при кесаревом сечении или биполярная энергия коагуляции при лапароскопических миомэктомиях. И, соответственно, возник вопрос, а как эта энергия влияет на свойства шовного материала? Как это может вообще сказаться на качестве формируемого рубца на матке? И первое физическое свойство нити, которое было интересно для изучения, которое подвергается наибольшим изменениям, это прочность. Для эксперимента мы взяли 20 различных по составу, свойствам и толщине нитей. Каждая нить разделена на отрезок на 4 отрезка по 10 сантиметров. Первый отрезок – это контроль. Второй, третий, четвертый подвергался воздействию монополярной, биполярной и аргоноплазменной коагуляции соответственно. После чего каждый отрезок нити разорвали на динамометре растяжения. Точность исследования достигла 1 грамма. Результат вы можете видеть на таблице. Есть нити, которые утратили свою прочность, что закономерно. Есть нити, которые полностью потеряли структурную целостность. А есть нити, которые, наоборот, стали прочнее. Например, итибонд или шелк, мерсилк. То есть во время пикси я буду уверенно коагулировать и знать, что конструкция не развалится, используя итибонд. И наоборот, с некоторыми нитями я откажусь от коагулятора и прибегну к другим известным методам достижения гемостаза. Второе физическое свойство, которое заинтересовало нас, это рассасывается нить или нет. То есть меняется ли ее запрограммированное время биодеструкции. Для эксперимента были взяты только две нити – викрил 2.0 и монокрил 2.0, наиболее часто используемые, и 40 лабораторных мышей. Мы их поделили на две группы, по 20 мышей для каждой нити соответственно. Мыши со стороны спины вводилась в группу разгибателей спины слева и справа нити. Правая группа обрабатывалась энергией аргоноплазменной коагуляции. Можно следующий слайд, пожалуйста? Для викрила скорость рассасывания – это 56-70 дней, для монокрила – 90-120 дней. Соответственно, мы взяли время для окончания эксперимента – это 70% от времени полного рассасывания, то есть 39 дней для викрила и 63 дня для монокрила. Контрольные образцы найдены у всех особей эксперимента. Викрил был найден только у 16 особей опытных и монокрил у 13. Наглядные результаты вы можете видеть на слайде морфологического анализа. Каким выводом мы пришли? Что нити не теряют свойства рассасывания, что они рассасываются гораздо быстрее. То есть если викрил, контрольная группа, представлена целой ниткой, окруженной соединительной капсулой без воспаления, то нитка, подвергнутая воздействию аргоноплазменной коагуляции, представлена разрозненными волокнами, между которыми располагаются коллагеновые волокна соединительной ткани. И аналогично для монокрила. Если контрольная группа – это монолитная нить, окруженная соединительной тканной капсулой, то монокрил, подвергнутый воздействию аргоноплазменной коагуляции, это разрозненное скопление нити, то есть нитью этого назвать уже тяжело. Соответственно, они не теряют способность рассасываться, и нить рассасывается быстрее. Возникает следующий вопрос. А влияет ли скорость рассасывания на качество формирования рубца? Лучше ли, если нить рассасывается дольше? Или наоборот, нужно подбирать сроки для того, чтобы рубец был лучше? Забегая вперед, хочу сказать, что работы на эту тему сейчас ведутся, и надеюсь, когда-нибудь смогу предоставить вам результаты этой работы. Благодарю всех за внимание. Спасибо большое.
Скажите, пожалуйста, понятно, что вряд ли вы полностью делали эту работу. Ваш вклад 20 секунд, вы и так задержали время. Пожалуйста.
Прошу прощения. Это идея, реализация и сбор анализа данных, предоставления этой информации.
Это планерка.
Это engaged.
Коллеги, я хотела бы сказать, что просмотрено огромное количество работ. Из них мы выбрали, абсолютно проанализировав...
Дай мне бутылочку воды одну.
А когда красная, это работаем или нет?
Значимость в гинекологической такой науке, в хирургии, а также значимость в науке в целом фундаментальной. Я считаю, что
Я выключусь на всякий случай.
означены как премиальные, лучшие всех сотрудников, всех этих коллег, лауреатами международного конкурса, нашего конгресса и конкурса. И на сегодняшний день и по значимости работы, и по манере представления, по тому, какую это они имеют роль и либо в хирургии, либо в науке, либо в организации здравоохранения, мы решили сделать так, что мы возьмем все 6 работ и продублируем первую, вторую и третью премию. На сегодняшний день это будет значимость хирургическая, значимость научная или в рамках здравоохранения. На первое место выдвигаются Сухарева и Ирен Эдуардовна. Сухарева Мартынов, руководитель, Ирен – это я. И проект «Репродуктивное здоровье». На второе место Лукьянова, Екатеринбург, руководитель Михельсон. И Лаура Горовна, руководитель Смольникова. И на третье место Шумейкина, Новосибирск, Красильникова, руководитель. И Санкт-Петербург, руководитель Беженарь. Готовьтесь, уважаемые коллеги, и в качестве бонуса, поощрения или чего-то я обязательно доложу руководителю, нашему руководителю Конгресса, академику Сухих Геннадию Тихоновичу, Постараюсь, я уверена, что он нас слушает, я точно не знаю. У него огромная государственная сейчас миссия. Я благодарна Геннадию за то, что он весь Конгресс от и до прослушал. И, может быть, мы предложим вам публикации в наших ведущих журналах акушерства, гинекологии и проблем репродукции, выступления на форуме основном, который будет осенью, и предложим какое-то выступление за рубежом. Я вас поздравляю все 6. Вы меня не удивили. Мы так и ожидали вашей работы. Спасибо вам за великое служение в вашем очень молодом возрасте. 24, 23, 25, 26 и 2 30-летних. Спасибо. Удачи, зеленой вам дороги на этом пути. Спасибо. Я предоставляю слово профессору Стархарду Кёхлеру. Спасибо большое, что вы сегодня...
I give the floor to Professor Köchler, and thank you very much for being with us today. So, Professor Köchler, microphone is yours. You're welcome. You have time we assigned for.
Good morning, Leila. Here's Christian Köhler speaking. Can you hear me, please? Hello? Can you
Я
hear me?
вас вижу, слышу.
I can see you, I can hear you. I'm eagerly waiting for you. The whole Congress is waiting for you, and we're extremely grateful for your mission, for connection, for your friendship and loyalty, that you are super surgeons, super oncologists, and we are so grateful that you are helping our patients and teaching our professors. Thank you. Microphone is yours.
Thank you so much. Dear Leila and dear colleagues, I'm very, very happy and glad that I can attend your meeting, and I'm really sorry and apologize for all the trouble I made to you due to the program schedule. Sorry, this was only due to a huge workload in the surgery. Today, I want to discuss a little bit the problem of best fertility-sparing therapy in women with cervical cancer larger than 2 centimeters, which is sometimes a huge challenge. Please allow me to start with some preliminary remarks. We have been more than happy when Professor Dargent, at the end of the last century, introduced the radical trachelectomy and combined it with a pelvic lymph node dissection done by laparoscopy. But very soon we had to recognize that this is a procedure with the same oncologic safety compared to radical hysterectomy only in patients with tumors less than 2 centimeters, with tumor-free lymph nodes, and with usual histologic types of cancer. It is now a very standardized technique. You can do it by a radical vaginal trachelectomy according to the original description by Professor Dargent. You can do it as an abdominal trachelectomy, probably with a wider parameter resection and a little bit more radical surgery, because this is associated with the resection of the uterine vessels. But the abdominal radical trachelectomy is also described in the literature to be done in larger tumor sizes. And you can do it by robotic surgery, as done in many countries, especially in Europe, in the Scandinavian countries. But again, we have here to raise the question, is this a feasible procedure according to SELECT trial? Because as you can see, you open the vagina, and if there's a residual tumor, this is questionable following the data of SELECT trial. On the other side, we have the tendency to more and more moving to less radical surgery. This means simple trachelectomy or repeated conization. And the question is, which is the best procedure, and what is it one of the procedures suitable also for patients with tumors larger than 2 centimeters? Also, we have to consider and to recognize that no randomized trial exists for any fertility-sparing surgery. And we have always to have in mind the oncologic aspect as well as the fertility rate and the fetal outcome. The problem for these young women with a diagnosis of a cervical cancer of 2 to 4 centimeters is These patients are often highly educated, they are social economic established and have the Partners for Family Foundation. And then comes a cancer diagnosis that really dramatically changes their life and all their wishes and expectations for the next years. And all the centers do perform any fertility sparing surgery are faced with women. They insist to have the chance to get pregnant despite larger tumors and despite the fact that we have to consider that this experimental is still this approach is still an experimental approach. Please look only to the red button. This is the actual NCCN guidelines, and as you can see in selected 1B2 cases, there's also an option for radical trachelectomy. And if you go to the end node of the sites, you find for stage 1B2 lesions from 2 to 4 centimeter, the abdominal approach is favored. And this is a little bit surprising, and I will demonstrate you why I'm not totally agree with this. Again, what kind of option do we have to treat patients with invasive cancer of 2 to 4 centimeters? And again, we have to consider, we have to preserve the fertility and the ovarian function, the oncologic outcome, and the obstetrical outcome. There are 2 management options and 2 treatment options described in the literature for these patients. The first one is the upfront radical, mostly done as an abdominal trachelectomy. And the second principle is the neoadjuvant chemotherapy followed by fertility-sparing surgery. The upfront radical trachelectomy is more spread in the Asian Pacific region, and that's why it doesn't wonder that the most data come from China in a series by Professor Li from the Fundan Shanghai University. In a series of 333 abdominal radical trachelectomies, he had treated also 132 patients with lesion from 2 to 4 centimeter. It is a very encouraging recurrence rate of 3.3%, and 5 patients died of the cancer. And the only risk factor for him was the adenosquamous histology. But if you look into data, due to unfavorable pathologic findings, more than 50, in fact, 61% received any adjuvant treatment. Half of the majority of them adjuvant chemo, and there's really unquestionable discussion if adjuvant chemo is an adequate therapy, because the standard treatment in high-risk situation is adjuvant chemoradiation. And moreover, 5.3% also underwent adjuvant radiation therapy. Of course, this adjuvant therapy has a huge impact on fertility, an impact on ovarian function, and an impact on quality of life. And if you look to data from abdominal trachelectomy, less than 2 centimeters and more centimeters, the abdominal trachelectomy is itself associated with obstetric complications. As you can see by the Japanese group, the infertility treatment was necessary in a considerable number of patients, and the preterm delivery. Sorry, can I continue?
Yes, please proceed. Please proceed. Please proceed. We are listening to you. Please proceed.
I had an interference with the translator. Sorry. And again, the preterm premature rupture of the membrane was frequently observed. Another one, Japanese showed a 60% complication rate that after abdominal trachelectomy that affected fertility, including cervical stenosis, ovarian insufficiency, and a relevant number of Asherman syndromes, difficult to treat sometimes. Again, if you summarize this a little bit, the upfront radical abdominal trachelectomy has a good radicality, good oncologic outcome, but again, is associated with a high rate of adjuvant treatment, higher surgical morbidity, more fertility issues, and in reduced obstetrical outcome. Also in the just published systematic review from the French colleague about fertility sparing, you see the pregnancy rate for abdominal trochanectomy, and this is in smaller tumors, is only 36%. What is the other concept? The other concept is neoadjuvant chemotherapy plus fertility-sparing surgery. The concept is to reduce the size of the lesion in order to perform a less radical surgery for fertility-sparing, to improve fertility outcome, and of course, to reduce the rate of adjuvant therapy. And the first question we have to raise is cervical cancer, chemosensitive cancer. And there are a lot of papers describing the efficiency of neoadjuvant chemo. I want to focus only on the ORTC 55994 study. This study failed to show a benefit compared to chemoradiation in a randomized setting, with all the problems of this trial. And again, there was no difference. But if you look at the subgroup of 1B2, there might be a slight benefit for the neoadjuvant group. And in fact, the data suggests that the response rate is approximately 70% in this group, and that cervical cancer is, of course, a chemosensitive cancer. Other studies showed the same, like the Czech group by Robova, who had in 3 to 4 cycles platinum-based chemo in 154 patients with stage 1B1 and 1B2, and the response rate was also around 80%. And another group by Chan also reported a response rate of 69% in a group of 142 patients. Thus, it is really a good option to reduce the tumor size. The problem is we don't know which patient responds to the neoadjuvant chemo. And this is one of the facts that we have to tell the patient in advance before they undergo this procedure. The second question is, what is the optimal chemotherapy regimen? And these are the usually frequently used. We have the very effective TIP schema with Taxol, ifosfamide, and cisplatin. You have the ovarian, like the ovarian cancer with Taxol and carboplatin, also in dose dense form. We have in so-called Belgian also dose dense, and one of the Czech Republic with ifosfamide and atrimicine combined with platinum. So it's not totally clear what is the best regimen up to now. Interestingly, most of the patients resume normal ovarian function post-chemotherapy. Thus, again, this is not a factor that we have to take care for the cancer. Here are some good impressions for you how neoadjuvant chemotherapy works. On the left side, you find the pictures, large-sized tumors before neoadjuvant chemotherapy, and on the right side, the same patients following the neoadjuvant chemo before fertility-sparing surgery. And this is also for the dose dense protocol, very similar finding. This raises the next question: what type of fertility-sparing we have to perform following the neoadjuvant chemo? Should we do a radical or a simple trachelectomy, or is even a cone or repeated cone sufficient as a fertility-sparing surgery following post-neoadjuvant chemotherapy? Indeed, we have a trend towards less radical surgery, but again, the data are very scanty, and it's really, in my opinion, too early to give a recommendation for less or more radical at the moment. Again, the concept is in good chemotherapy therapy responders with node negative patients, and to have no or minimal residual disease in the MRI, which is the best tool to measure this. The chance to have a parametrial infiltration is very low, and therefore in less radical surgery could be reasonable, but again, this statement is to handle with very caution because the data are very limited. And this is reflected also by a good systematic review published in 2021 by Bobano et al. And they summarize the type of fertility sparing performed following neoadjuvant chemo. And you see the majority of patients were done either by the vaginal radical trachelectomy or an abdominal radical trachelectomy, but in considerable number also by cone only or by simple trachelectomy. Again, the next question is this concept associated with a good obstetrical outcome. We know from the tumors less than 2 centimeters that the premature rate is significantly lower in patients following neoadjuvant chemotherapy combined with fertility-sparing surgery compared to the abdominal radical trachelectomy. You see 57% compared to 15%. And the again, also summarized in a paper by Holloway, by the group of Holloway, also in 2021, the obstetrical outcome appears to be favorable in the subset of patients with a low recurrency rate. If you try to compare these two concepts of abdominal upfront radical trachelectomy on the right side and the concept of neoadjuvant, we have to consider that the recurrence rate in this review by Van Cole is slightly higher in the concept of neoadjuvant chemotherapy compared to upfront radical hysterectomy, but the major difference is in successful pregnancy. You see, in abdominal radical trachelectomy, it's only 21% for the upfront radical trachelectomy compared to 70% in the neoadjuvant group, and this is really a huge difference. Again, there are a lot of questions in both. In the upfront radical, again, adjuvant treatment is more than 50%. It's a very radical resection. We have the lowest pregnancy rate and the lowest chance for live birth. Whereas in the neoadjuvant chemotherapy, we have no standardized chemo regimen, no standardized number of chemo cycles. We don't have the best tool, probably it's MRI for the measurement of the response. We don't know which extent of surgery we have to do, but we have a better chance to get pregnant and relatively comparable oncologic outcome. Probably there will never be a randomized trial because comparing these both groups, because it's a very selected and rare group of patients, and we would need a very large number of patients to show a significant difference. And it's also very difficult to tell the patients both concepts to make a decision for the one or the other. The only trial that is open in this field is designed by Marie Plant, the so-called Contessa trial, to have a standardized neoadjuvant chemotherapy. This is a schema of the trial, and as you can see, the patients undergo 3 cycles of platinum paclitaxel. Then is a pelvic MRI to confirm the shrinking of the tumor, and in case of complete response or partial response with a residual tumor less than 2 centimeters, they perform a simple trachelectomy or even only a cone. And this is my main behavior to this study, because we don't have sufficient data, to say that we can this high-risk group also tailors the radicality. I would rather favor the radical trachelectomy in this subgroup, but again, it's a matter of discussion. Again, we have a substantial response to the neoadjuvant, and we have to look for the results of the Contessa trial, but will take a longer time. What are our own results? We have done this concept in 31 patients, again, following 2 or 3 cycles of neoadjuvant chemotherapy, and only in patients where we have proven before the tumor-free lymph nodes done by laparoscopy. The majority of patients were nulliparous, 84%, usual histology, and we have had a lymph vascular positivity of 23%. In most patients, we have performed a complete lymph node dissection with a mean of 22 lymph nodes, and then the patient underwent 2 or 3 cycles of TIP chemo or carbotaxol chemo. There was residual tumor, and this is interestingly in more than 50% of the patients. Thus, 4 patients had to go immediately to secondary radical hysterectomy or hysterectomy plus adjuvant chemoradiation. These patients who were seeking for parenthood got pregnant in the considerable percentage of 60% and gave live birth to 12 babies. 10 women delivered 12 babies, but there were also miscarriages below the 12th week of gestation and late miscarriages. Our recurrence rate is totally in accordance to the literature, with 9.7% recurrences, and 1 patient, with 3.2%, died of the disease. In conclusion, in my opinion, fertility-sparing therapy in patients with tumor 1B2 is still experimental. The best treatment is unclear, also due to the limited database, and should only be performed in women without lymph node metastasis, and this can be easily proved by laparoscopic lymph node dissection. Dear Leila, I really thank you that you gave me the opportunity to participate in your outstanding Congress, and thank you for your outstanding friendship, and I wish you all the best personally and to your Congress. Thank you so much.
Дорогой профессор.
Dear Professor Köchler, you know, it's a great happiness. It's a great happiness that there are people like you. Honestly, you, Simone, everybody, you are all brilliant colleagues, great friends, fantastic professionals. To us, it's a great compliment. It's a compliment to Russian medicine, to Russian healthcare, and it's a compliment to the fact that medicine is above everything else, and the friendship is above everything else. Thank you very much. My big kiss and big hug. I wish you all the best.
Nice day and a good Congress.
Спасибо.
Bye-bye.
Большое спасибо. Я желаю удачного конгресса.
Уважаемые коллеги, дорогие друзья, начинается наша программа.
So we start our plenary session, and this is day 4 of the Congress, and I delayed the program by 15 minutes because, according to the approval of the director, I could not refuse to Professor Köchler because Professor Köchler could not join us before because he was on a very difficult surgery, and that was prolonged surgery. And now I'm happy to give the floor, and me and Gennady, we are waiting for the keynote lecture today, New Horizons of Surgical Intellect, the True Gift of Surgery, Asa Stepanyan. This is Academy of Female Health, Endoscopic Surgery, and she's a founder and the chief editor of the first in the world surgical portal, Surgery U, Atlanta, Georgia, and she is the graduate of our center. Floor is yours.
Vladimirovna, it is a not just pleasure, as we say sometimes, but a true and profound honor to be part of this Congress. I would like to express special gratitude, tender friendship, and the warm words and the warm feeling to you and to Gennady Tikhonovich as you produce this Congress that enhances the education not only in Russia, but everywhere in the world. Thank you very much for this profound work, for the fundamental applications of new technology, for friendship, for perseverance at the times that are sometimes not the easiest. So thank you very much for the eternal and everlasting friendship in this world. I would like to speak about the subject, which is actually very interesting for us, and no wonder that the Congress that has such a profound devotion to the new technologies and new developments selected this lecture. The lecture is called The New Horizons of Surgical Intellect and the True Gift of Surgery. So when we speak about the development of technology at the time when the technological progress and intellect advances, the time may become to think about the advancement in the human intellect and the potential role of the human intellect in the upcoming future. When we speak about it, we think of the state of being, we think of the state of mind, something that we have been taught about from our earlier childhood, and also the state of learning and adaptation as they unite under the intellect as the faculty of reasoning and objective understanding, both for the machines and for the humans. So when we talk about the state of being, we need to realize that we are approaching the world in the beginning of 22nd century, in which we will have the population numbers of over 10 billion people. It has been the quickest rise ever occurred. In 1970s, there were roughly half as many people in the world as there are actually now. And this comes with the time of increasing age of the population. The age is going to be over 65, increasing. Age of 25 to 64 years of age will continue to be stable. The maternal age at the time of delivery and pregnancy increases also, and this is associated with the higher mortality and morbidity, both for the mother and for the child. This comes at the time when we will have the shortage of health care workers and the doctors. It is estimated that in the year of 2030, we will reach the deficit of over 15 million doctors in the world. So that's a global number. It comes at the time when we have the higher complexity of the healthcare because the population is aging and because we have morbidity potentially associated with the later maternal age. So this comes with no surprise that the various organizations and the countries and government start to be involved in the tendencies and doctrines in order to enhance the preventive, predictive, and therapeutic approaches to health. Just recently in the United States, those doctrines and the directives were issued with the accessible health monitoring everywhere in order to reduce the impact on the time of the physicians and the healthcare workers to economically address those times. The precision multi-omic medicine is enhanced by manufacturing of cell-based therapies, AI-driven bioproduction of therapeutics, advanced techniques in gene editing. You can see how important all subjects of medicine are here. But also there is an ecologic impact of medicine. Actually, it has a major contributor to pollution. It is estimated that the health sectors of the United States, Australia, England, and Canada emit a combined 748 million metric of carbon dioxide equivalent annually. And look at what's happening in the ORs. This is the most pronounced in operating rooms, where the conditioning requirements account for 90 to 99% of energy use in an attempt to improve sterile conditions, of course. And then here we also use the single-use instrumentations that impact the supply chain activity. Not only medicine is contributing. Look at what we're doing here with artificial intelligence. You can see that approach to the ecology comes from the GPT-3, not even 4. Not because every machine and every connection produces so much of energy use, but simply because there is so much of that connection. We spend so much time here. Look, every person is surrounded by 26 smart objects that are located near them at all times. 2.5 quintillion bytes of data gets generated every day. For the first time, I spoke about quintillion just this February, and it is also only increasing. So again, it comes at no surprise that there is a major contribution, colossal, I would say, contribution into the healthcare, specifically associated with artificial intelligence and also associated with the education in the sphere of artificial intelligence when it applies to medicine. You know this slide very well. So the hopes are that with this kind of association of artificial intelligence, we would like to be more efficient and economic, putting together all the knowledge that has been created so far, integrating the various kind of knowledge, potentially with the purpose of putting together the various markers that have been studied by different people and with positive findings into one most potent marker. We are still looking for that in endometriosis, for example. Potentially, we will understand the variability of diseases and then prevent them, generate and individualize plan of care, prevent and predict the disease, enable earlier diagnosis. We may be able to minimize the need in extensive surgery, maybe guide a surgery and surgical knowledge further, find new developments in even the tissue knowledge, facilitate development of local molecular therapies, locally applied potentially, and promote collaborative approach to health. When we look at these slides that are very dear to me because they are produced at that very center that presents in so many places, thanks to you, in so many places in the world, putting the new frontiers to what we are finding in medicine. We're not looking just at those pictures and saying, how nice is three-dimensional view. We are looking at them and studying what happens when there is a 3 millimeter association between the tissue, 5 millimeters association, creating the new standards in understanding of the surgery, an understanding of anatomy as the fundamental aspect of surgery, and learning from it. And yes, being guided, as you can see in the central slide, where the tissue comes with different visualization. We learned about the Nervier fascia, for instance, in the patients with MRKH, which can be then translated to the patients with the pelvic floor prolapses and various approaches to this beautifully avascular space. So after looking at the new type of data, computer-generated three-dimensional models. This is done at the department of Leila Damian's department. After looking at these models, we say, well, the surgery in this field did not really have a lot of bleeding. Why is that? Why is that we are taught to go to this field? And we're discovering that there are two layers of the Nervier fascia. We can guide them, we can apply to them, we can teach them, and we can learn from them. So this is also advancement of technology. If one looks at the IBM data, they are describing 4 types of robotic technology. The purpose behind all that is that there is a finding that up to 98% of medical errors are actually preventable. And so The doctors would be getting a little bit more tired. There are errors that needs to be prevented. So one of the conclusions and solutions was actually creation of the robot that is autonomous. That means that the robot is able to produce some aspect of surgery independent from the physician, but guided by the purposes of strategizing the plan of care. There is augmented reality. Also, when we look at an augmented reality, we need to realize it's not the reality. It's just an augmentation for our human intellect and decision making. For instance, there was a case that I was sharing as a live event, and the professor was showing the greenfield field for us. So the ureter appeared incredibly clear. And somebody from the audience said, "Why don't you keep this vision all the time?" And I asked the question, I said, if we keep the vision all the time, look at the screen that we are looking at right now. You see the highlighted material, but you may not be seeing everything that is written there. And there could be some very precious information. So we should highlight and augment when we need that augmentation, because we need all of the information, both with our intuition, with our vision, with our full perception that is through the years and previous generation applied to us. This case is of Johns Hopkins University. It was an autonomous robot surgery. What were the findings? And the gentleman in the right corner is Professor Krieger, who actually came up with this technology, at least in relation to that center, of course, and IRCAD and other facilities, much is produced as well in this field. They found that when compared with the expert surgeon STAR, which is a smart technology autonomous robot, made fewer mistakes and was more consistent in suture spacing and depth. It was found that the flow through the resected phantom bowel was the most laminar when it comes to the STAR performance. There was a higher quality anastomosis than those performed by the expert surgeon. And the idea and the main decision there was that the human operator approved a plan of surgery. Where do we go from here is not clear, but here are the findings. We're stepping into the world where the institutions and the facilities can already, by the facial recognition and the body dynamics, recognize some of the conditions of this individual. And with more thorough approach, also non-invasively, without even a blood draw, give the diagnosis, and actually reliably. So let's step in from the state of being to the state of mind. And here we're talking about levels of artificial intelligence. Most of the things we know now are artificial narrow intelligence, and we're so fascinated by it. But then we don't even completely know the artificial general intelligence. The reason why I have the chessboard here on the left side is because that particular robot was able to win not only the champion in the chess, but he won from the master that created him. So there is a step into the artificial superintelligence, localized and focal right now. Is there concern for anything more? Here we speak with Max Tegmark, who is a professor in MIT, president of the Future of Life Institution. The picture that I show you is not fun, neither were his words. He talks about optimization. So what stands behind the artificial intelligence? Why is there a concern? Because artificial intelligence is efficiently driven, and we're talking about stepping into the general intelligence and superintelligence. It does not have a concern for the cost of the task of delivery. It does not have the ethical principles instilled in it. It does not have the generational knowledge of many, many years, the chains of generation, they refer to it. The well-optimized artificial intelligence system will eventually create harm, per Professor Tegmark. Humans consistently reassess their goals. Machines do not. Machines continue optimizing without the regard for surrounding environment. Machines will continue optimizing what initial decision is, regardless of that, and will come after the initial seeming benefit. They will come to further development, and potentially that further development would be not only not needed, but potentially harmful, similar to dissection in the field in the surgical field when the dissection is no longer needed. Harm can be created. A different individual, Stephen Russell, the professor of Harvard and Stanford University, and then he published the book on artificial intelligence for the Internet of Everything, speaks about the civilization and control. He speaks about the way that the artificial intelligence think. It's extremely efficient in categorization. The goal is categorizing so that we can move on to the next task. Sometimes people get caught in that kind of a feeling as well without stopping, thinking, analyzing, and then doing. So, however, he says, sometimes wrong categorization can occur. The chain of civilization in tens of thousands of years are unbroken so far. He warns us, look at the image to the right. It is comfortable when machines can do things for us. It is, quote, unquote, easy, but is it good? When one becomes machine dependent and gives civilization to the machines, we lose incentive to understand it ourselves or to teach the next generation on how to understand it. One of the main principles of Hippocrates when we give our oath is that we will teach the children. In order to teach the children or the next generation, we need to know the reality. We need to understand it itself. We need to continue learning. One way he suggests that we can have a control over artificial intelligence would come from machines' uncertainty in what the objective is. Therefore, optimization is not ultimate. How interesting it was to listen to the TED Talk of Max. What he said here was critical. The question was, if superintelligence arrives, who should control it? Please note that 5% of people, humans, stated that they prefer that machines control us. Where does it come from? Of course, there is a concern that is raised at World Economic Forum. And then, being a curious person that I am, I decided to ask ChatGPT concerning this myself. I said, what is the future of humans in presence of artificial intelligence and artificial superintelligence? Yes, it says that in the realm of artificial intelligence and superintelligence, humans are likely to play a unique and evolving role. Initially, humans will continue to be the creators and developers of these technologies. As AI advances, humans may increasingly collaborate with intelligent machines. We're not speaking here, notice, about machines collaborating with humans. The humans will collaborate with intelligent machine, leveraging their computational power and so on. And then it says, however, as AI progresses towards superintelligence, there is a potential for a significant shift in the balance of power. In this scenario, humans may need to adapt and redefine their roles in the society. It is crucial for humans to maintain control and ensure that artificial intelligence aligns with human values and interests to prevent unintended consequences. Ethical considerations and responsible governance are needed. Again, that's ChatGPT. It may have its own mistakes, so we are not looking at it as ultimate, but isn't this interesting? So at what level of artificial intelligence do we stop? And the companies and organizations did stop. The leaders of the artificial intelligence, including those of OpenAI, which produced the ChatGPT, Google DeepMind, etc., made a statement. The statement was one sentence in order not to dilute it. The sentence reads as follows, done by 350 executives, researchers, engineers, all working in artificial intelligence. This is a statement. Mitigating the risk of extinction from artificial intelligence should be a global priority alongside other societal scale risks such as pandemics and nuclear war. It was only one statement made by these people. Look at World Health Organization that warns the people. It says, the data used to train AI may be biased, generating misleading or inaccurate information that could pose the risk to health, equity, and inclusiveness. The generated responses can appear automative and authoritative and plausible to the end users. However, they can be incorrect and contain serious errors. The machines may be trained on data for which consent may not have been previously provided for such use, and therefore that may include sensitive data. Machines can be misused to generate and disseminate highly convincing disinformation in the form of the text, audio, etc. While committed to harnessing new technologies, including artificial intelligence and digital health, to improve human health, WHO recommends that policymakers ensure patient safety and protection while technology firms work to commercialize it. So, do the machines make mistakes? For instance, the face recognition machine for various animals was given a task to see whether or not, look at the lower picture, that's a husky or a wolf, and vice versa. So, when looking at that picture, when looking at the wolf, the machine stated that this is husky. But then a researcher was further interested and said, why? Why did you make that question? So we should ask the machines why, based on what the decision was made. Guess what the machine said? It wasn't about the eyes of the animal. It wasn't about feet or anything else. The statement was, because we know that husky has snow around it most of the time. We do not know what the machines think. We know our way because we concentrate on something that we are used to looking at as information. The machines don't have that decision. They don't have that training. They look at everything that is in front of them, potentially making the mistakes in choosing what to concentrate on. And then what happens if they break? How are we going to come from very advanced robotic surgery to something else? Therefore, the upcoming generations of people, their abilities and intellect need to be exposed, trained, and perfected in the other types of surgery, laparoscopic surgery, open surgery. At the time of risk, all has to be applied. The fundamental skills might be emphasized in both simulation and real-time training, and there will be much more simulation going in the future just because the OR time will be way too precious, less surgeons performing more surgeries. This concept was interesting. It's called actually GIGO, garbage in and garbage out of the computers. Again, needing to see what information comes in. Is it biased? Is it just simply, excuse my language, trash? And then the machines do not specify between them, and the potential end result would be the conclusion made of information that is not valuable because the data has not being introduced as the value. So intellect and intelligence. Intellect is ancient. It's the power of knowing. Intelligence is trained as an ability to learn and understand the detail. And of course, we go to Albert Einstein. Always love hearing this person's information. The intuitive mind is a sacred gift, and the rational mind is a faithful servant. We have created a society that honors the servant and has forgotten the gift. Intuition is not easy. To enter intuition, one has to step away from the immediate and rushing pieces of mind. An urge to find the question, to find the answer, an urge to categorize, but to stop and see how does it feel? Where is the true answer? Where is the truth? It is based on human values of empathy, imagination, and experience. Intuition is defined and one's ability to understand something immediately without the need for conscious reasoning. Intuition is deep. And interestingly enough, this study shows that it is essential to the success of the surgery. And this study also shows that data and artificial intelligence created data and summarized data is also critical. In the center, in the box, you see the aspects of surgical decision-making, patient values and emotion, patient-surgeon interactions, high decision-making volume and complexity. Also present as well to the left, unhealthy outcomes, when there is an isolation, not collaborative and collegial approach, when there is no talk with the patient, as opposed to listening to the patient, understanding that decision-making, agreeing on the surgery, agreeing on what needs to be done afterwards, better patient satisfaction because the patients are emotionally attached with the physician. So augmentation plus intuition is the further development health. And intuition is also based at something that is very prehistoric to humans, actually. It's autonomic, it's ancient, it's without cognition. It is capable of self-restructuring. It is the first responder. Located in the amygdala, centers are associated with all inputs from all sensory system. There is a stimulus that is paired with non-contingent reward that does not become controlled. So the contingent reward is always there. Therefore, there is a possibility of restructuring. The autonomic response is not something that machines are capable of. We are capable. We love the machines, but we need to remember who we are and use that. There is an attempt to create an artificial intuition, ladies and gentlemen. The MIT specifically found that we're able to improve the performance of planning algorithms in solving a range of problems by 10 to 15% if the intuition is added. Harvard University, understanding that there is that 45% of executives in their business school and then associated facilities, 45% of executive directors are making their decisions primarily based on intuition, especially when the number of data is significant beyond their possible perception. And they would like to ensure that the decision-making that occurs is considered both the hard facts and the intangible factors at play. The decision-making made with participation of intuition is higher in quality than the decision that is made without participation of intuition, just based on the linear data. Furthermore, the Harvard teaches in their school now how to listen to intuition. The data looks good, but I'm feeling anxious and fearful, they're saying. That's actually one of the first steps in intuition. So we need to stop fearing our emotions. We need to look into them, welcome them, and listen to them. And that starts long before we know it. So with Piaget's theory of cognitive development, the first development starts at 0 to 2 years of life. But we are discovering that fetal movements have been observed starting at 8 weeks of gestation, and that all senses other than pain develop by 24 weeks of gestation. So it starts way beyond that. That starts in utero, and actually probably before that, just from the standpoint of genetics. We need confidence to make a difference. We need confidence to stop and say, my GPA is telling me to go certain way because it shows that the traffic is very busy. I should listen to that GPA, one would say. Another person would say, yes, GPA says that. So the artificial intelligence says that. But I don't feel that the road is blocked, and I see it's not blocked. So I'm going to select this road that requires confidence. Interestingly enough, confidence is associated with the high levels of metacognitive learning process, which refers to awareness of one's own knowledge, what one does and doesn't know, and one's ability to understand, control, and manipulate one's cognitive process. Look how high there is self-confidence. And also notice that all these roots come to actually cerebellum and also subcortical loops that connect to the cerebellum. Cerebellum, as we know, is movement and balance. No wonder people say, take care of yourself and your bodies, and the confidence will increase. Historically, we did the surgeries. 31,000 centuries BC was the first surgery described. It went into the trepanation. By the way, at the Dnieper river banks, the surgeries were performed in 12,000s, and it was stated that some of these trepanation areas, which were performed for seizures, migraines, mental disorders, and so on, actually had healing So that means that patients survived those. So they were good surgeons at that time. And then came the era of the Enlightenment, when the scientific surgery came through. The age of reason was intellectual and philosophical movement that occurred in Europe, but it started as a scientific surgery with John Hunter in the 18th century. I would like to especially point the social connections that enhance the adaptability. I remember a lecture by Gennady Tikhonovich at some point in time when he demonstrated how the two mice behavior were different in connection with the mother and without the connection with the mother, and also in social interactions. So I kind of thought about this here, and I found this article in which they showed that isolation strongly affects markers of neuroplasticity in the prefrontal cortex, and that this is restorable. Some of these defects normalized after resocialization. So when we're turned away from each other, looking at our computer screens, because actually that's addictive to the point that the actual substance abuse can be treated by the blue light treatments. When we start looking at each other, maybe the world will become better and our neuroplasticity, longevity of our brain will continue further. Professor Darwin on evolution, it is not the strongest of the species that survive, not the most intelligent that survives. It is the one that is the most adaptable to change. This picture is I took from the TED talk. This picture shows which professions and which activities are the ones that are under the risk with development of the artificial general intelligence. The areas in green depict the one that will be at highest: chest recognition, arithmetics, jeopardy, and so on. Look at the top of the lines, look at the mountains. That is art, cinematography, science, book writing, anything creative will continue to be present, even at the time when so much will be done by the machines. The older I get, says Queen Elizabeth, the more conscious I become of the difficulties young people have to face as they learn to live in the modern world. Well, if we listen to people or to the person whose oath we continue to give these days, we will be okay, because we promised that we will respect our teachers and honor them. We promised that we will teach the new generation of people. We promised that we will continue to learn. We promised that we will do when we can and do not when we feel harm. We promised that we will prevent disease whenever we can, for prevention is the preferable cure. And it says, I will remember that I remain a member of society with special obligation to all my fellow human beings. We are in special profession. Those sounds of mind and body as well as the infirm. You know, the brain is truly beautiful. The intellect is eternal. It is highly capable. Look at the flowers of our brain. Look at the upcoming young generation. As long as we collaborate with each other, as long as we switch on the intimate human capacity of intuition and integration, collegiality, emotion, we should be okay. In general, in medicine, we need the stimulation programs. We need the virtual reality because we will be struggling in the near future. But we must know how to use it. We must know them. We must learn them and give ourselves time to do that before we implement it at the highest possible level. The new horizons of the surgical intellect evolution of the integrative capacities of human brain through experience of society and technological interactions are present. Intuition is our precious and ancient guide and gift. It brings automatic, remember, autonomous nervous system, attention to the most important issues at the times when the answers are not clear. And again, I asked GPT. I said, okay, so tell us, what is going to be the role of the surgeons in the future? And guess what it said? Now, I asked after I prepared the lecture. I asked actually just today. It said collaboration with technology, specialization and continuous expertise, decision-making and patient's interaction, lifelong learning and adaptation. Beautiful. So far, we are in the sync. And I wanted to say a special thank you to, again, Leila Adamian, to Gennady Tikhonovich Sukhih, much gratitudes, profound gratitude, and honor to be able to speak with you today, with your audience today, because I feel that I am a product of one of the evolutions of this center, of people in it, of eyes that I've seen, of OR that I've gone to, lectures that I listened, and the attitude that creates a character. Character will drive the evolution. And I also am an internal and eternal optimist. I remember that 50% of success of surgery is listening to our patients and also learning. Thank you very much for your attention and for the privilege to give this keynote lecture on today's Congress. Thank you.
Уважаемые коллеги,
Distinguished colleagues, I have no doubt that you enjoyed dramatically this presentation. That was Dr. Ася Stepanyan. She is truly a product of our country. Thank you very much, dear Ася. And it is very clear that I have very emotional, personal attitude to your lecture, but you are brilliant. I'm proud of you. I wish you all the best. Distinguished colleagues, dear friends, and now I'm happy to give the floor to Dr. Zagrab Makiyan, and he will speak about functional intrauteral surgery, new approaches, new instruments, operations, and original data.
The data of the Kulakov Center, starting from this minute on, please do not overrun your time. We had the presentation by Professor Kerchler outside the schedule, and then a 30-minute presentation by Dr. Stepanyan. Zagrab is a wonderful surgeon, and he's our product of the Obstetrics and Gynecology Center. Zagrab, the floor is yours. Distinguished Leila Vladimirovna, dear colleagues, first of all, I would like to thank the organizers of the Congress, and Leila Adamian in particular, for organizing this wonderful Congress, which is important for our practical activity. And I would like to express my gratitude because we grew up on such congresses when we were students. That is why it is very important for us to present our results under your auspices. As for our presentation today, it is devoted to a unique organ, uterus. Uterus is the organ where birth develops. There is the intrauterine growth of the fetus before the fetus becomes a baby, and organogenesis takes place in the uterus. At this time, different vital organs are being developed up to the 6th week, and after the 6th week, there is the development of the organs of the reproductive system. And you can see, fetoscopy shows you that's an embryo of the female gender, 14th week. Genitals have already been formed. And I should say that until now, when life appeared on Earth, determining what sex the fetus has is done using the anatomy of the genitals. Here we can see that fetoscopy shows that genitals are female, but ovaries, vagina, uterus were already formed. But nevertheless, modern imaging does not allow us to see the internal organs as we are talking today, including the uterus. So the entire spectrum of anatomical or structural options. When we're talking about anomalies represented here, And that's a wonderful cumulative table. Each of these options, from the first to the final stage, well, that's a female embryo that goes through all these stages of embryonic development, and each female embryo has a chance to be born in this or that particular form, including those anatomical options shown here. And we do not see them in the intrauterine period. Modern imaging modalities do not allow us to do this. We can see only external organs like genitals, and the first debut, as we call it, when these structural anomalies are manifesting themselves is the adolescent period, like when there is the outflow of the menstrual blood. All other anomalies shown at the bottom happen when the reproductive age occurs. And also, when we start studying the anatomy, using, for example, IVIS or other types of ultrasound. Here you can see the 2D ultrasound, 3D ultrasound. We can study the anatomy, but we do not see the shape of the uterus. And when we examine the patient with reproductive problems, and here you can see Professor Us is doing a 3D ultrasound. You can see the frontal plane, and the ultrasound shows that there is an anomaly where there is the narrowing cavity of the uterus. This woman had 7 pregnancy losses, starting from the first pregnancy loss and up to the study. Usually it takes 10 years in 60% of the patients. Just imagine what kind of statistics this is. And here you can see what is happening during the operative intervention. This is hysteroscopy, and there is a tunnel, the narrowing of the cavity, uterine cavity, but in order to detect it well, we should use specific methods. First of all, imaging, we should see the fallopian tube, then we do the radial incisions, and only after this we can see this problem. You can see the fundus of the uterus, the septum. It is not very well manifested, but there is a layer of the fibrotic tissue which does not allow this woman to develop an embryo. That is why she has had 7 pregnancy losses. Well, you can see that there is a fold here. This fold is an obstacle, so we remove this layer, and visually you can see that we increase the area and the cavity. You can see there are capillary vessels, and in the future we need to assess the uterine cavity. Why is it important to increase the area where in the future fetus is going to develop? Like in the upper left-hand corner, there is the pregnancy at the level of the fundus. It's the 6th gestational week. The fundus is the most optimal place here for the development of pregnancy. In the future, when vital organs are going to be developed and when the reproductive system is going to be developed, as you can see it here on this slide, this is a 10-week embryo, chorion, and it's kind of round, and it occupies the entire uterine cavity, and the entire chorion is being supplied with blood because here the key events occur, and that's when the blood supply system is being developed, metabolic processes are being developed, and if there is not enough blood flow, there might be the death of the fetus up to 7th week, or when we can compensate this process later, then the fetus will be born with specific structural anomalies. In this context, I would like also to say that if, according to the WHO statistics, Bone and muscle anomalies rank 1, then cardiovascular anomalies rank 2nd, and then according to statistics only reproductive system anomalies follow. And we're talking about the statistics like cases per 1,000 births. And then in adult patients, anomalies detected at this age do not fall into these statistics. These are patients with structural anomalies of the reproductive system. So if we bring these statistics into the WHO pattern, then automatically reproductive system anomalies would rank first among all statistics.
By far. And then we'll get back to this. After the operation, what do we get? What are the fundamental matters of principle that we seek to accomplish? First of all, we need to restore the anatomical structures of the uterine cavity. Other than that, area of the surface where the blood supply of the fetus is coming through. Our modern opportunities to use 3D ultrasound probe in different modes, we give you different scans. It helps measure the surface, the area of the uterine cavity, pre and post, and its volume. This, as you can see, during the operative intervention, we can, so to say, relatively judge to which extent the surface or this area is growing. But using these digital indicators, we see by 25, 30, or sometimes by 40% the area grows, as well as the volume of the uterine cavity. So, what are the key points I wish to highlight in my presentation? Firstly, we need, of course, to have early primary diagnosis. It's clear that in order to identify these structural anomalies, we need 3D ultrasound. At that, we speak about expert evaluation, where specialists can differentiate different abnormalities. This is where I would like to highlight one point, what Leila Vladimirovna quite rightly pointed out when we were discussing this topic. If you have identified structural anomalies, it does not at all is not at all tantamount to having to rush to be seen by the surgeon immediately. But if this information is available,
квалифицированной помощи часть из этих пациентов, у которых есть
a number of these patients who have these structural anomalies, their success chances are rising significantly. But in case where these chances are poor, or the patient has seen some failures, then we would suggest an operation which seeks to, firstly, restore normal anatomy, to remove vessel-free zones and increase the area and volume of the endometrial cavity of the uterus. In conclusion, dear colleagues, I would like to express my personal opinion. The main strategic potential of my country, as I say it, is reproductive health of our population, of our public, and we clearly do all it takes to help those who need our help. Thank you very much for your attention. Well, thank you very much, dear Zagreb Nikolaevich, for being such a unique, clear, specific specialist. That is your attitude towards our medicine and our surgical work that you do. You at least have 10 patents for the most novel, up-to-date operations. Because having such a teacher like you, sorry, yes, thank you. Let's try to do without it. Next speaker goes Andrei Yurievich Popredukhin. Uterine and vaginal malformation, pre-op modeling and intra-op navigation using ultrasound, 3D ultrasound and MRI navigation. Please be as succinct as you usually can be. Calls a PhD. Dear colleagues, Leila Vladimirovna, thank you for the presentation, for taking part in this. Allow me please to present my presentation. What is relevant? Clearly, these abnormalities are seen in 7% of women in the population, and in patients with impaired reproductive function, it may be as high as 25%. Today, gynecological practice does not apply uniform one-size-fits-all approach to diagnosing, surgical care and rehabilitation of patients with congenital uterine disease, as well as combination with other comorbidities and extragenital anomalies. Our center and our Department of Operative Gynecology, led by academician Adamian, is a reference institution in this country, since we work with different constituent entities of Russia who are referring their patients to us. For most part, they are seeking help because of primary or secondary infertility, pain syndrome, and inability to have sexual life. Well, the gold standard in diagnosis are ultrasound, and today the new is 3D ultrasound. And this is where we like to thank Professor Vos for adopting novel technologies in uterus and in vagina. And we use MRI, CT, and in a number of cases, hyster and laparoscopy. Aplasia of uterus and vagina is an extreme manifestation of morphogenesis impaired, and mostly the patients cannot have sexual life, and they want to have all sorts of correctional therapy, irrespective of possible risks. Well, as of today, the best recognized method to treat this is colpopoiesis of the pelvic peritoneum, but developed by academician Academian, but given its high incidence, as well as in combination with other defects, this operation has not yet been standardized until today, and is done for most part at tertiary care institutions, and is part of high-tech operations. One of the modern methods that helps optimize surgical care is 3D computer modeling in pre-op setting, which helps do pre-op planning to identify optimal amount, surgical access. We can predict all possible technical difficulties that we can see, as well as do it many times in virtual format, given all the anatomical peculiarities. We, as well as academician Academian, have studied international and national experience of 3D modeling in trauma, in neurosurgery, and we have patented our own method of pre-op examination of the pelvis in patients with aplasia of a vagina and uterus. In the study, we used high-field MRI systems using the slice as thick as 1 millimeter, and we identified the thickness and width of the fat tissue in the pelvis, and we look at facial topography of the anatomical position of the levator ani, as well as main anatomical guidelines, because in many patients this may be impaired and may differ from women who do not have these congenital defects. Later on, because of specialist software, we did 3D reconstruction of the organs, and this is what you can see in this slide, so that we could see 3D detailization as well as measurements that we seek to get. In some spaces, we could go down as much as to 1 millimeter. Main fascias and main sheaths of the organs, as well as we looked at the rectum, bladder, levator ani, as well as verification of the projection of the vascular and nervous bundles, plexus. In this study, we first identified interrelations of rudimentary structures in pelvis in patients with aplasia in regards to the bladder and rectum, and we look at the main fascia. And we, for the first time, we look at the rudimentary complex. This is main rudimentary vagina, muscular pila, and whatever. This opens new horizons to study embryological entities and does not go against modern anatomy theories. We first describe the single uniform muscle complex, and these facial structures and muscles that you can see on this slide. This was first published data that has to do with the internal anatomy of the pelvis in patients with aplasia. Well, during the operation and colpopoiesis, it is indeed a unique operation. It helps to create a canal between the rectum and the bladder, and this is the main stage of this. As part of this study, we looked at the non-Villiers fascia in all cases, and we think that ossification of this anatomic structure is the main stage when we form the rectovesical canal because it helps position everything correctly anatomically and reposition using blunt dissection because of pneumoperitoneum, and in some cases we do not use any energy. Besides, we did in a number of cases, we visualized the pelvis. This is where the ostium of the bladder is, as well as levator ani, in anorectal angle projection, which is for hypergastric plexus and mid-artery. These special features are taken into account when we look at the canal between the bladder and the uterus, because extreme dissection, especially laterally, may injure puborectal muscle, which later may need to impair the levator function, and which may lead to incontinence of the urine and feces. And if we go beyond the fascial injuries, for example, the pelvic fracture may have to do with massive arterial and venous bleedings. Well, reconstructive plastic surgery to create a new vagina is impossible unless we know proper knowledge of anatomy. In patients with aplasia, what is typical of them is both diaphragm in the genital area as well as the pelvis, as well as the anus. We have seen step-by-step procedure for colpocoesis, irrespective of which approach we use. Either we go inguinal or total laparoscopic colpocoesis. And this study shows you in this slide, dear colleagues, and since the main purpose of the work we do is to standardize the surgical interventions, we study the blood loss, the length of the operation, pre- and post-op complication depending on the thickness of the rectovesicular space, using optimum volume and axe and approach in this operation. We established that if the thickness of this fat tissue ranges between 3 to 6 millimeters and the distance between the muscles, levator ani, is over 25 millimeters, so it is, we can do dissection of the tissues using inguinal approach, but it has to be reproduced. But if the thickness of this space is under 3 millimeters, but sometimes it may be as thick as 1 millimeter only, we need to do colpocoesis from the pelvic peritoneum because of high risks of injuring these structures as well as all the organs, including the bladder. Because of this study, we firstly approached and used this technology in patients with aplasia, in pelvic dystopia of the kidney, which used to be a contraindication. But since we did this, we can have the strict criteria when and where we can operate on these patients, in this pool of patients, using minimally invasive approach, as well as the volume of the reconstruction operation. This slides shows you the data in this 3D modeling, helps the only doubled pelvic kidney, you can see it, the only ureter that was positioned alongside the lateral side, where it entered the bladder, ostium of the bladder. And the pre-op setting, we did intra-op navigation, and this patient had laparoscopy, removal of the functioning uteral rudiment, and we did colpocoesis from the pelvic peritoneum. This was done with laparoscopic approach, laparoscopic section. And what I would like to say, we've established a truly novel multidisciplinary approach that includes MRI, with further 3D computer modeling and intra-op navigation that helps choose optimal amount and surgical intervention approach and further care. We in detail studied the topography and anatomy of the pelvic structures, uterine rudiments, the peritoneum, and the fat tissue under it. And this methodology helps open new horizons to treat patients with aplasia and helps physicians come up with one-size-fits-all unified approaches when we do colpocoesis from the pelvic peritoneum, but from gynecological practice as a whole. At this time, we have prepared a number of monographies, especially in uterine and vaginal defects, which will include this data, and later you will get access to it. I would like to thank you, Leila Vladimirovna, for being able to talk to this conference, unique conference. Thank you very much for your attention. Dear colleagues, once again, I'm saying our Center of Obstetrics Gynecology, we are training you students. He came as a student, but now he has become a mature, high-class surgeon and a very nice person. So much for when you can have both artificial intelligence and very profound natural intelligence. Thank you very much. Dear colleagues, the floor goes to Andrei Vladimirovich Kozachenko. He was the first professor of Russian Academy of Science. Novel opportunities of endoscopic and X-ray methods in comprehensive care of patients with malformations of the uterus, scar pregnancy after C-section, and cervical pregnancy. Fantastic material which is presented every day and, amongst other things, abroad too. He is the leading researcher of our leading fellow of our staff, of our department, a fantastic surgeon, a physician from Dynasty of Physicians. Thank you very much, Andrei Vladimirovich. Probably we won't have any other opportunities to praise you, but I believe that you already are presenting Russian medicine at a very high level. So, please be succinct. Distinguished Chair, distinguished colleagues, first of all, I would like to thank you for this flattering presentation, and this talk will discuss a very difficult multidisciplinary problem. So amongst the co-authors, we have a radiologist and endovascular surgeon who are members of the authors. In line with the guidelines of the Ministry of Healthcare, risk factors for ectopic pregnancy are the presence of the ectopic pregnancy history, intrauterine contraception, but regrettably none of these factors seem to be playing the key role. We cannot discount the reproductive ART. This is also supported by the data by the Russian Association of Reproduction, Human Reproduction. The same is true not in Russia alone. In the United States of America, ectopic pregnancy, which goes hand in hand with massive bleeding, may kill as many as 3% of women, pregnant women. But the main site where ectopic pregnancy would be present would be uterine tube, fallopian tube. They take up to 97%. But other pregnancies, although they're not well represented, also may pose a hazard for the woman's health. Speaking about ectopic pregnancy, cervical ectopic pregnancy, we realize that until recently, the most frequent methods to treat this was to remove the uterus. Despite a lot of effort and alternative approach to treat this very difficult condition, such as mifepristone, application of chloride of calcium into the gestational sacs, extubation, endovascular surgery, you name it. There is no one-size-fits-all gold standard to treat such patients. Attempts were made to use balloon and compression using 2-lumen catheter. Still, a very high risk of bleedings and hysterectomy in these very difficult conditions. Global literature supports this view, but it has changed as we started using the achievements of interventional radiology, which was fathered by Charles Theodore Daughter since the early 1960s, came up with an idea to treat hemorrhage using embolization of the uterine artery and using balloons. In this country, the first endovascular surgery was used back in 1984, and at that, it involved Leila Vladimirovna Damian, who at that time was not an academician. She was a physician on duty in our center, and using endovascular surgery in our center, in Vishnevsky Institute, they did embolization in a female patient with massive blood loss, over 25 liters after postpartum, with a mutation of the Willebrand factor. And this is extract from Soviet time newspaper that covered this. Today, there are no specific pathognomic signs because this may be perceived as a threat of the loss of the pregnancy. In our department, we analyzed a lot of clinical material, 97 women with cervical pregnancy from 5 to 10 weeks and 20 pregnants on the scar pregnancy after C-section. We have experience of using methotrexate and leucovorin with further removal of the gestational sacs using ovoscope. We're also well versed in endovascular surgery. Our data also show that today, very high efficacy in all the methods in our specialty. One should point out that in 36 patients with cervical pregnancy, we used embolization of uterine arteries bilaterally, in 12 through femoral, in 23 through right radial, in one case in one humeral. One patient was very tall. That's why catheter could only go through humeral artery. This is a cervical pregnancy, 5-6 weeks gestational age. We can see the only place where the gestational sac is attached. This is a classical picture you see in cervical ectopic pregnancy. I'd like to say that less invasive approach, even when we do embolization, helps patient to be discharged from the clinic on day 2 or 3 because we use less invasive approach. In terms of diagnosis, we're well equipped to help both localize the gestational sacs and see how well it grew in the villi into the stroma. And we can evaluate the blood flow, possible blood loss, and in women who need embolization of uterine arteries. On MRI, we see the gestational sac is better visualized. It is bigger than the uterine cavity. We see lumen, good vascular network, and in some slices during the embolization, we see a vascular zone, which is taken into account during the operation. It is a dry field. We see good contours of gestational sac, and the blood flow would be minimum. I'd like to say that we use absorbable embol that in further months could not be visualized. We see revascularization of the organ, which fully preserves the reproductive function for the woman. In one case, where the woman came up with choriocarcinoma, which was treated in a specialist center using methotrexate. Also, the data speak about the effect of this method. And speaking another ectopic pregnancy in the scar, we would like to say that for the first time it was identified as a disease in its own right in 1978 by Larsen and Solomon. Today, there's no universally accepted, approved surgical approach on scar pregnancy after C-section. Yes, instrumental removal using hysteroscope works fine. Embolization of uterine artery works perfectly well. Ultrasound works too. And other methods are also widely used. Arterial use of methotrexate also works, but embolization of uterine arteries remains a pretty good and effective method. Our department has treated 20 patients. In 16 cases, we did EUA, but in 4, we avoided it, we endoscopically removed. In every case, we preserved the uterus and fertility in these women. This is one of the cases of the operation performed by Professor Arakelian. We embolized uterine arteries, laparoscopy, we removed the ingrown gestational sacs. Please note that the pregnancy was in high gestational age, 12-13 weeks. In combination with embolization, we preserved the uterus and fully repaired it. Recently, last March, we have our own experience in managing such a patient doing this operation. Literature fully supports our clinical data, but the systematic review that included about 30,000 women on scar pregnancy, EUA and hysteroscopy, was considered as one of the most effective methods to treat this pathology. And last, arteriovenous malformations of the uterus. This is a very hazardous program, and it's hard to diagnose, even further harder to manage, keeping the fertility. It was described 26 by Dubriel and Luba. It may be the cause of massive bleeding, both menstrual bleeding and intermenstrual bleedings. Well, risk factors are not yet elucidated. C-section, multiple uterine interventions may be playing a role in terms of diagnosis. You'd better do ultrasound and do proper mapping, this is a must, 3D, 4D ultrasound, and MRI using 3D reconstruction that helps identify both the arteriovenous malformation, this huge bypass where it goes into the arterial from artery to the vein, bypassing the smaller veins. And we also see reference vessels we need to close first. This is our observation. After using trophoblastic, we use huge lacunes with huge blood flow here. And the angiogram shows us that it's fully supplied by ovarian arteries and the outflow goes into the iliac veins. It mostly has to be treated surgically, including hysterectomy, whereas we always seek to leave in place the uterus. In our department, we came up with a radical method. Angiography shows a big malformation, which is seen both in venography, arteriography. You see the huge lumen, and it starts with the embolization of the reference vein using spirals. You see how we close the vein. We first close the outflow, but then the inflow comes next. What we do? We see complete click closed pre and post embolization. The nucleus of this malformation has been shut down, so the patient no longer complains of bleedings. We have experience of treating 49 patients with arteriovenous malformation. In some cases, we did have to do 2 or even 3 repeat reembolizations, but the outcomes were good. Out of these 58, 14 had pregnancy and have babies, and 1 is pregnant, so it is a great success. The use of those technologies would be impossible with OB/GYN alone. This requires multidisciplinary approach to tackle this challenging issue. Endovascular surgeon, expert specialist on visual diagnosis on imaging is a must too. And women after cervical pregnancy and after scar pregnancy, we need to control beta Hg to identify the probability of trophoblastic disease that might return to these patients. Thank you. Andrei Vladimirovich, brilliant presentation. Thank you for being next to us. And people like you are the top our research center can suggest. The floor goes to Professor Arik Ilyan, who holds a PhD, who has been working in the center all his life and is a surgeon of the very broadest scope. He's like a phantom, has been working in the center both day and night. He never says no. Aplasia of uterine and vaginal aplasia, 4 variants of colpopoesis, original data, senior fellow in Gynecological Center. So, as usual, please be succinct, logically, and the most important things. The floor goes to you. Thank you very much, Leila Vladimirovna. Thank you very much for giving us this festive occasion with this high top-level Congress, and for the opportunity to present before this distinguished audience. Well, Andrei Yurievich, in his presentation, focused mostly on matters that have to do on pre-op diagnosis and planning of the operation. Our presentation will deal mostly with technical aspects when we need to do colpopoesis in patients with uterine aplasia. I'd like to say that our department is a reference center to treat defects, congenital defects, and in the last 10 years, we have seen over 1,500 patients. Out of them, 161 are patients with aplasia, with uterine and vaginal aplasia. Well, the incidence of defects is 1 per 300. Newborns, Rakitansky syndrome is seen in 1 patient out of 15, as he says, newborn patients, girls. Syndrome of testicular femalization, congenital dysfunction of the adrenal cortex. Besides, when we speak, there were cases of sex change and iatrogenic situations after radical colpectomy.
Well, I should say that these are special patients, because often there are other malformations that they have. At our department, we use the malformation classification offered by Leila Adamian. Moreover, there are other classifications, such as ASHRAE, SE, SGE. Patients with Myra Rokitansky, Kuster, Hauser syndrome have the female karyotype, no vagina and uterus, normal ovarian reserve. They have ovulation. It's possible to stimulate ovulation, eggs donation, and ART program with gestational carrier. Well, there are three types of the syndrome: the pure variant, when there is uterine and vaginal aplasia, also the symmetrical rudiments. Well, the type 2A symmetrical rudiments, also aplasia of uterine tubes, and 3-2B or 2B type is vaginal and uterine aplasia with ORC syndrome. What are the options of colpoproesis? Well, non-surgical or bloodless, offered by Frank. In Russia, it's the Sherzhnev method, colpo elongation, also surgical methods, which can be replacing plastical surgery, such as abdominal options, the skin patch, well, abdominal approach. Modern medicine allows us to use tissue engineering as well, and I should say that the abdominal colpoproesis is often called the Davidov surgery, but abdominal colpoproesis was done in the early 20th century by Dr. Martin, and there were episodic events about such surgeries, such as Dr. Strassman and others. And also in the 1930s, it gained momentum by XXXVI et al. Department. We've been doing this since the 1960s, when three-stage colpoproesis from the pelvic abdomen was used with the incisions of abdomen. Then we used one-stage approach through the vagina. And right now we do the colpoproesis with the laparoscopic assistance, which was offered in 1993 by Leila Adamian. And later on, these methods were modified depending on the situation, depending on the pathology. Now we've got 4 patents depending on what modification we're going to use. This slide shows laparoscopically assisted colpoproesis from pelvic peritoneum, option number 1, and you can see the tunnel can be formed, the abdomen will be fixed, and there is a cupula of the vagina formed after this. You can see the video. We start the operation with revision. We identify ureters, all anatomical structures, and here you can see the double ureter on the left. As soon as we have all the anatomical landmarks identified, we identify the pouch of the abdomen, and then through perineum, we do the incision at the level of lower corners of labor minor, and then we form the tunnel between the bladder and rectum. This stage requires tactile feelings from the surgeon, clear knowledge of anatomy, and that is why we call it the blind stage. As soon as we identify the abdomen, we fix the margins of the abdomen by clips or by grasps, and then we fixate the skin of the perineum, and we go to the mucus of the vagina. We usually lay 8 or 9 separate stitches. Usually we use our suturing technique. We usually use biological glue. At our department, when the margins of the abdomen are fixed, we check the volume and the patency of near vagina, and we restore by using the gauze tampon the structure. The second stage is the laparoscopic approach, the formation of the cupola of the near vagina. We use one purse suture laid with the capture of the bladder. We use PDS. The suture covers also uterine rudiments to strengthen the cupola and to form tactile feelings. At this stage, we should exactly know where the ureter is. As soon as we tighten the suture, the procedure is over. The next option is the intermediary one. Usually, the intermediary surgery is used when there is rigidity of abdomen, or patients are obese, or patients with the androgen syndrome. In this situation, as you've seen before, first we fix the abdomen with ligatures or the purse suture or T-like suture, and then the procedure is the same as in the first option. We open the abdomen, we use ligatures, we pull the abdomen toward the perineum, then we fix the abdomen and form the cupola of the near vagina. The next one is the total abdominal colpopoesis. The laparoscopic approach is used under visual control. This option is primarily for those surgeons who know how to use the laparoscopic approach, and this is a more standardized procedure because you can do video fixation, and this procedure is good for training of would-be surgeons. The procedure starts with revision. We identify the anatomical landmarks. Well, the rudimental tinea and the rectum. We open the abdomen here. We do the blunt dissection toward the perineum. We open the fascia, the perineal fascia, and then colpotomy is done, or we use the vaginal probe to open the vestibule of the vagina. Then we use the laparoscopic approach to fix the margins of the abdomen to the perineum. We use the tampon, and we use the purse suture to form the cupola of near vagina. The tampon is removed on day 2 or day 3. I'd like to note that in the post-operative period, and that's also important to follow up those patients, because at different stages of epithelialization, different approaches can be used, different ointments and different local therapy. Option number 4, colpopoesis, on patients who want to change sex. Well, you can see this is the male pelvis, and this is ductus spermaticus. After the first stage of feminization plasty, we use a perineal approach. We do the incision. Then we use the blunt dissection to form the recto-ureteral tunnel. We identify the abdomen, and we use this to open the abdomen and fixate it to the perineum and to the orifice of vagina, or the vestibule of vagina. Well, totally laparoscopic approach allows us to do colpopoesis with just one pelvic kidney, because we do it under the visual control. This allows us to do colpopoesis on such patients, especially patients with partial obliteration of cul-de-sac, because we use the abdomen of the bladder and the side wall of the pelvis. In order to assess the quality of life, we used FSFS 19 questionnaire. I should say that all stages were basically the same, and you can see FSFI results here. Colpopoesis, total colpopoesis, provides better results. In conclusion, I'd like to say that abdominal colpopoesis allows us to form the enough depth of near vagina. We use organisms' own tissues. The procedure is accompanied by the minimum blood loss. There is no need to use special equipment. We can use the painkillers as minimum as possible after the procedure. The activity restores very fast, and we can also say that such patients can start their sex life as early as possible. Here you can see long-term results. Thank you very much for your attention. Thank you, dear Alexey Aralikian. You convinced me that we have wonderful data colleagues. If there are any problems in life, come to us. We're ready to accept you at the Kolokov Center. Both me and Dr. Aralikian and Andrei Popridukin and others, all my staff have different options to hospitalize you, well, through the mandatory medical system or other systems. Well, thank you very much. We treat different types of malformations. Dear colleagues, the floor is given to Stanislav Kiselev. He's a professor, a doctor of medical science, a professor of the Department of Reproductive Medicine and Surgery of the Yevdokimov University. But Dr. Kiselev worked at the Kulakov Center for Obstetrics and Gynecology. He's a brilliant surgeon, he is an erudite, and he's a person who has wonderful qualities. I heard the presentation of Aisha Stepanyan. He has intelligence, human intelligence. First and foremost, the theme of the presentation is the so-called Robert's uterus, types of classification and surgical correction. Just on this subject, do not deviate from it. Thank you very much. Thank you, Leila, for this wonderful presentation of my persona. Let me just share my slides with you. I hope you can see my slides. Dear colleagues, distinguished Professor Damian, this is already the 36th Congress, right? Terrific. And that's wonderful. The theme of my presentation, the so-called Robert's uterine and types of surgical correction. Well, there are different names of this malformation. You can see in Russian we have 3 different types, the way Robert's uterus is spelled. And As for Robert's uterus, it was described first way back in the 1970s, and there was a draft of clinical guidelines on uterine malformation. That's a symmetrical septum of uterus with collaterals, and you can see lots of problems stemming from that. First of all, as you can see, it's Robert's uterine, and basically it should be pronounced as Robert because he was French, and you can see some of the articles in French here. Moussin describe Robert's uterus. In the 1980s, Daniel Derjang, who mentioned this as Robert's uterus, which was not exactly what it was. Well, but in 2021, there were some Chinese articles, some British articles. Well, Hélène Robert was a woman, and, well, you can see that there were even more articles like this. But in fact, Dr. Robert was male. Well, just look at this picture. Henri Guy Robert is definitely a man. Well, Dr. Robert was a very famous professor who was a surgeon at the same time. And the first surgeons dealt with operative gynecology, and he wrote several books on operative gynecology and several textbooks. Roe Palmers was one of the co-authors. He was also very famous in France in 1969 or in 1970. Well, most people quote 1970 and this article, well, double uterus and poor outflow of menstrual blood due to vaginal aplasia. Nothing is mentioned about the septal uterus. Well, and as for ipsilateral kidney agenesis, Robert describes this malformation as primary dysmenorrhea, unicornate uterus according to laparoscopy. Well, no abnormal kidney development according to laparoscopy, and also you can see ultrasound was not used at that time. That is why they used urography. If we look at ipsilateral kidney agenesis, it was described only in one patient. In 2019, 63 patients who were subjected to the tests, they detected only one case as for patients with unicornate uterus with the horn. 29% usually have this condition. In fact, in 1895, this malformation was described for the first time by Richard Wirth from Kiel, Germany. He was a German surgeon. And in 2003, this article was published, Pregnancy in Asymmetric Blind Hemicavity of Robert's Uterus, Previously Unreported Phenomenon, by Savita Sinhai. In India, this is the event which was not mentioned before, but in fact that's wrong. Richard Brown Cheston in 1814 had a patient like that, and he thought this was ectopic pregnancy, but in fact it was Robert's uterus. An autopsy was done after her death, and there was a fetus in the uterus with just one cavity, but he did not understand what that meant. But in 1889, Hubert Redinger, an Austrian gynecologist, well, could not assist a woman with delivery. Then he realized that the cavity, uterine cavity, was empty. He did a C-section and subtotal hysterectomy, Perot's procedure. And what he saw, he depicted in such drawings. And after this, there were several cases like that described by some authors. Well, you can see some of the articles here by Frankel in 1903, in 1905 by Werner, and Dodeline in 1918, Andreas Fischer from Basel, Switzerland, also described this. As you can see it here, Izofi in Turkey. There were many cases like this, and there were different diagnoses made. Some considered this as ectopic pregnancy, some as unicornuate uterus, some cervical uterus, some septal uterus with partial cavity aplasia. Well, this can be considered as ectopic pregnancy. 21 cases, ruptures occurred in 3 cases. Well, that's 14%. There were also frozen fetuses. The fetuses were supposed to be removed somehow. As for classification, septal uterus with one cavity or unicornuate uterus with interstitially located horn. There were different descriptions and different classifications, but primarily the first classification by Adolf Kurzweil was used when he described a unicornuate uterus. Also, the septal uterus, unicornuate uterus probably is the wrong term. Well, you can see another classification, ASRM, Müllerian Anomalies Classification of 2021. It identified Robert's uterus as one separate condition, but there is still the mentioning of the unicornuate uterus. It's complete and incomplete uterus with aplasia, cervical aplasia, or partial corporal aplasia of one of the horns, and that's that. In fact, well, this is an embryological hypothesis, but not a theory. We do not get the right answer to this question. And here is another classification offered in 1950 by Moni and Sergeson, the Canadian pathomorphologist. You can see also one more classification by Ashre and ESGE consensus on the classification of female genital tract congenital anomalies. And here Robert's uterus is classified like this: class U2 septate uterus, or class U4 hemi-uterus, classified by Moni and here. But if you look at the classification of such anomalies of the body of uterus, well, if you look at this from a different angle, we can classify this as class U3, not U4, but with cervical aplasia, for example, and that's that. But that's the wrong classification. In fact, But since we got used to this type of classification, we still use this name. Here you can see the options of surgical correction. The worst option of surgical correction, that is performed laparotomically or using laparoscopy, is the removal of the part of the uterus with cavity. You can see the Japanese article of 2021. Half of the uterus was removed. Why? We don't know. They say that was the wrong surgery. This year, there is an Italian article published. There are 5 cases of this kind of procedure. And I'm pressed for time, so I showed you just the 2 cases. Absolute Roberts uterus, which was operated on the wrong way. Why? Because there is still the rudimental horn, which was not separated. Usually we remove the horn. That's the problem. Well, Robert's uterus, or Robert's uterus, the French way, has a different degree of aplasia. So it can be the cervical aplasia. That can be one classification, or it can be considered as part of the uterine body aplasia or as complete aplasia. That is why surgery can be different. If cavity is small, well, this cavity can be removed. You cut the myometrium, you remove the cavity, but you do not remove a lot of myometrium. The second surgery is LTOS, or robot-assisted metroplasty, usually performed in case of pregnancy. When women are pregnant, it's difficult to remove it, so that's why we do metroplasty. And also hysteroresectoscopy under the laparoscopic control or under ultrasound. For the first time, the procedure was done in 1995, so that was quite a long time, but hysteroscopy began to find its momentum quite recently, and I think the most optimal method is hysteroresection, dissection of the septum under ultrasound, or just using transrectal or transvaginal ultrasound. I think that this is the most advanced option to correct this anomaly. There is no need to dissect the septum fully because in most cases, dysmenorrhea occurs right after menarche, and so it's enough to have just a kind of anastomosis or a junction between the cavities and to have drainage, and then you can do the reconstruction of the plasty through the hysteroscopic approach. So in conclusion, I should say that the rudimental horn, in case of unicornuate uterus, Robert's uterus, are 2 different malformations. The wrong classification of Robert's uterus leads to wrong methods of correction. Pregnancy in the cavity of the uterus in this situation can be considered as ectopic pregnancy, and using eponyms and quotes, we should pay attention that classification should be more exact. Thank you very much. Thank you, Stanislav. Well, you just confirmed the fact that you are a real doctor, and I'm very proud that you worked at our center. You are my student. Thank you very much. Well, dear colleagues, if Professor Bari is ready, we can give Professor Barry the floor. All right, that's great. Now the floor is given to Professor Perry Barry. And I'd like to say that Professor Barry is head of the Department of Obstetrics and Gynecology and Reproductive Medicine of the University of Texas Clinic, Barcelona, Spain. The theme of Professor Barry's presentation, lessons learned from follow-up and team building after 500 colposacropexies. Well, I met with Professor Barry at different events.
And different congresses. Well, you know, in our team today, Professor Barry among our team is somebody new. But we know, we met the father of Professor Barry. He is a unique surgeon here and he will also address our Congress too. Dear Perry, I look forward to your lecture and our team of over 4,000 people who are online now are looking forward to your lecture. You are a unique person. Thank you very much for carrying high the banner of the Professor Barry family. The floor goes to you. Please, please.
Leila, it's really a great pleasure to be back with you. And everyone loves Leila all over the world. I'm super happy to be back with you here, and I sincerely hope that the situation will let us meet in person in Moscow as short as possible. I would love to, and you know. Meanwhile, you know that my house is your house in Barcelona, and we can meet in Barcelona wherever you want. The topic you asked me to discuss about is to share our experience with in the world of colposacropexy, which is one of our favorite work lines and work projects, and recently we have collected our data and it's now in press, so I will be able to share what is not yet published. The way I have structured the lecture when I was thinking about preparing the lecture is traveling through the standard colposacropexy that we perform during this trip, during this journey of the colposacropexy. I will be introducing not only tips and tricks, but also lessons learned on what to do and what not to do. And I will finish with the data that I already told you. Okay, so I like to transmit message to surgeons that first of all, we have to be humble. Because in functional surgery, which is what we do in endometriosis, which is what we do in pelvic floor surgery, every bad outcome is not the disease fault, it's not the patient's fault, it's our own fault. The goal in colposacropexy is not the anatomical restoration, this is not enough, but the functional outcome. The patient has to be happy, not the surgeon has to be happy with the result. And the best thing we can do, of course, is sharing our experience. I think nowadays it is clear that colposacropexy is the gold standard, it's more anatomical, the result lasts long, and the functional outcome is much better. Everybody started proposing colposacropexy for young women, but nowadays the concept of young women is very open, and I'm sure that the physical condition of ladies of 70, 75 who are still sexually active, physically active, practicing sports, why shouldn't we propose this technique? Let's start the journey. We were taught many years ago about the importance of doing organ suspension and exposure in order to gain, to avoid restrictions and to gain hands of the surgeon and the assistant in order to expose the promontory area, which is an area that before the training of colposacropexy we were not really used to work. No? Once this exposure is done, we have to know the anatomy of the promontory. We have to deal with thin and fat patients. In fat patients, you just have to dig to palpate more and to dig deeper, but the anatomical structures are the same. In older patients, sometimes the iliac common vein can be closer to the promontory, and be careful with that, particularly if you are putting a very high Trendelenburg, a very high pressure, this vein will be very flat. Be careful. The ureter, of course, it is a concern, but in general is far enough. And my main focus, my main stress is the nerves. Hypogastric plexus, hypogastric nerve. You don't need to dissect it. You just need to know where it is and to work lateral to it in order to avoid not only cutting the nerve, which is something that we discussed in endometriosis, but sometimes in these cases, you don't have risk of cutting the nerve, but it has been described that surgeons that don't manage well nerves, sometimes they place the mesh, the stitch, or the tacker through the plexus, and that can cause pain and make you come back to the OR. Let's have a quick look at the anatomy at the promontory. This is a video that this one particularly is not mine. It's recorded by a super great friend of mine, by Alfredo Ercoli, but it's particularly nice and very, very straightforward anatomically, and that's why I like to spend this just minute with you. It's always the same. Once the sigmoid is what's suspended to the abdominal wall, you have a good access to the promontory. You see that in these long surgeries, because at the beginning of the learning curve, this is a surgery that takes long, you don't need to move faster your hands, you just need to remove things that don't help, steps that don't help. You see with this exposure, you are already seeing the nerve, you are already seeing the promontory, you are already seeing the presacral fascia open that you will see right now, and the middle sacral vessels. And it's a matter of working on the right side of the middle sacral vessels. You can see that if you work on the right side, you will be away from the vessels and away from the nerve, okay? And then you have to progress the dissection of the pararectal fossa. But this is not cancer. This is not deep endometriosis. You don't need to do a deep dissection of the pararectal fossa. You need to do a superficial dissection right underneath the peritoneum. You just need to create a space in order to place the mesh at the end of the surgery and to cover the mesh gently. And the same thing, this is another video for the dissection, the posterior dissection. What I like, and the way we teach to our fellows, colposacopexy as well as deep endometriosis surgery, the fellow program teaches both techniques together. I want my fellows to be fluent and to be confident in colposacopexy first, because I want them to work on the retroperitoneum, on the healthy retroperitoneum, and once they are able to develop the spaces in colposacopexy, then they jump to deep endometriosis. I think it's a great learning model if you put both together. That's a nice message. Another message is not only working underneath the peritoneum, but also respecting the mesorectum. When we prepare the dissection for bowel resection, we have to detach entirely the meso of the rectum until we go below the lesion. But look, for example, here. This is a deep dissection. We go to the puborectalis, but it's very economic. We are not doing a dissection of the mesorectum. We are not denervating the distal part of the rectum. We are preserving somewhere here and somewhere here the middle rectal artery and the innervation of the last third part of the rectal ampulla. We are just creating a hole, or let's call it window. It sounds more fancy, going deep down at this level, and once we get deep down here at the central body of the perineum, we jump laterally, and here systematically we will find our puborectalis, and we will be able, once we find the puborectalis, to do a very economic dissection and a very economic suturing. You will see that you have enough, sufficient access in order to create what is described as a big bite. The bite on the muscle has to be big, but the dissection, the orifice of the dissection doesn't need to be super big. You see here, it is very clear, and anatomically, everything is well respected. I know that there are devices in the market, like some types of tuckers, some types of glues, that can help you avoiding suturing. But my advice is that if you plan to start a program of colposacropexy, don't even think of doing the training of colposacropexy without being well trained in suturing with your left hand, with your right hand. Look here, for example, at the level of the pubis rectalis, we are doing the suturing with the right hand. At the level of the anterior dissection, we will do it with the left hand. There are three types of, in general, of colposacropexy. In cases when we keep the uterus, which is not the most common situation at least in our environment. The most common is cases where we remove the uterus, and of course we do a subtotal hysterectomy, and the cases where the patient does not have a uterus anymore, and in this situation is what we call the repair of vaginal bulk prolapse, which although you could think that not having the hysterectomy time can save time, but in general, it's not so easy because most of these patients have prior prolapse surgeries, prior colporaphies in the dissection. Sometimes it's not so easy, and you need to fill the bladder with serum and things like that. No? The anterior dissection follows the rules of the classic hysterectomy, where you have, as you can see here, the balloon, you have the manipulator, and you have the bladder dome. The surgeon shows the bladder dome to the assistant. The assistant does not pull up the peritoneum, but pulls up the bladder dome. And this shows the bubbles. And you just follow the bubbles. You dissect, attach to the vagina, and follow the bubbles. In cases where this plane is very sticky because of prior colporaphies, you should be, of course, you should not open any organ, but you should be more scared of opening the vagina and causing and assuming then a risk of erosion rather than opening the bladder. If you open the bladder, you can just go ahead and close it and continue with the surgery. Okay. What is the anatomical landmark of the anterior dissection? There is no anatomical landmark. You need to use a different indirect landmarks. How deep you have to go? You don't have to go super deep. You don't have to go below the bladder trigon, because then you could cause urge incontinence. Patients would be very unhappy, although the anatomical result would be good. And of course, reducing the risk of urethral damage is important, and that's why you work in between the bladder pillars and not lateral to the bladder pillars. Again, as you can see, thinking of this functional outcome, the suture, that in this case is done with the left hand, the suture is done between 5 millimeters or 1 centimeter above the deepest part of the dissection. And you see how here we are using a combination of both hands. This is a 22 millimeter needle, but the space is not small, and you use one hand to pass the needle and another hand to help. We are using in all these large series this type of Y mesh, okay, and the anterior arm of the Y mesh is fixated again, not at the tip. We respect this exactly same around 1 centimeter in order to reduce the amount of material next to the bladder trigon and to reduce the risk of urge incontinence, because believe me that this is a problem. And it's a matter of tying this knot and laying the mesh completely flat. With this is what I call the first trick in order to do a practical restoration of the anterior compartment. But very often it is not enough. Sometimes you have what is a critic of the laparoscopic colposacropexy, that sometimes it treats very well the apical defect, but the anterior compartment sometimes is not very well treated. And you will hear people saying that you would have to do a combination of part of the colposacropexy by laparoscopy and then combine it with anterior colporaphy. This is not our advice. Our advice is to use everything that is available regarding techniques to treat the anterior compartment. So this is the deep dissection is one thing. Okay, you can do it with in cases where you do a hysterectomy, like on the left. You can also do it, as you can see on the right side, in cases where you keep the uterus. You just divide the anterior arm of the mesh on two, and the arms go around the isthmus, and you fix them in the front, and you do exactly the same correction. But again, this only corrects the central cystocell. But you need to add another trick that is super important, which is the restoration of the pericervical ring. This is for us, and when we installed this, it really made a change in the treatment of cystocell and diminishing the de novo cystocell that sometimes used to happen in colposarcopexy. This is very important. You see, it's a bilateral suture that includes the anterior mesh, pericervical tissue, fascia, posterior uterosacral ligament, and posterior mesh. And all this suture stabilizes the mesh. It lays completely flat and it stabilizes very well the anterior compartment. And with this, you treat very well the anterior compartment. And this is something that has to be done systematically. This is a video recording and showing the full placement of the mesh anteriorly, as you can see here, the same as at the apex of the vagina or the cervix, as you can see here, and posteriorly, you also see here that the mesh is not under very high tension and is well fixed to the levator animasus, to the pubis rectalis. Okay. And here comes what is also important for me, the third trick. This third trick that I already tell you that the trick is in the peritonization, including the bladder pillars, you will see now the video. This third trick is particularly useful in ladies that have large cystocell with a lateral component. It's a way of solving the problem of paravaginal defects. Why does that work? Instead of opening the rectus space, suturing in the pelvic fascia, or placing meshes in the rectus space. This works because, as you can imagine, when you tie this running suture, the bladder pillars will come up and will be medialized. And you avoid the cystocell under the mesh, okay? And you treat very well the lateral defects. If you do these three tricks, very rarely you will have de novo cystocell, and very rarely you will not be convinced that you will have to combine with a vaginal approach. I think that's one of the important take-home messages. Regarding the promontory, we defended from the very beginning the use of sutures. I think it is easy to do a suture at the level of the promontory if you use your left hand, but of course there are options of using tackers that you can discuss. We can discuss. As you see, we normally do the peritonization in two steps. The first is low peritonization, then the fixation at the level of the promontory, and in the end we do the high peritonization. I think it's much more practical, even in cases where you keep the uterus or in cases where the uterus has been removed. As you can see here, you can do it with barbed sutures, you can do it with classic running sutures. It's just a matter of protecting the mesh. What is also very important, and I think I started the presentation saying that we have to be humble and we have to make sure about the result also of the technique. Before you finish, before you end the peritonization, examine the patient. If for some reason you are not happy when the patient is in the OR, there is no reason you expect to be happier later. So make sure if it's not well corrected, do something else or restart something, okay? Once you are convinced, then you finish the surgery. What happens when things go wrong? I think it's also nice to share. It happens to all of us. If things go wrong very early, there was a problem with the technique. Check it with imaging, ultrasound or MRI, and do not hesitate in going back to the OR again. Here you can see images of patients that things didn't go wrong. Be careful because sometimes the MRI or the ultrasound will tell you that the mesh is well fixed to the promontory, like here or here, but probably there is some granulation tissue in the promontory that looks looks like the mesh and confuses you. But if things go wrong in the short period of time, go back to the OR and you will find surprises like here, where everything looks fine, but once you ask the assistant between the legs to push the cervix upwards, you can easily identify that the problem is that the mesh was not attached to the promontory. That's a defect of the technique. It was again our fault. But this is not the most common type of defect when there is a relapse in the long term. In the long term, the most common defect, as you can see here in the picture, is the loss of the fixation of the mesh around the uterus. You see here, this is the case of a lady that had 2 pregnancies after the colposcopy, and everything came down again. And in this case, you have to restart, remove the mesh and start the surgery again from scratch. And there are cases where things do go wrong. This is a patient, I will skip the video for the sake of time, a patient that the mesh completely disappeared, got lost from the cervix. And in this case, we did remove the mesh and fix it again. The problem here was, and we didn't notice at this time, was that, as you can see, there was quite an inflammatory tissue that didn't really surprise us, unfortunately. And the problem of this lady was that the anatomical correction was fine, but after the reoperation, she had an important infection, an important abscess. And it's also a topic that I like to treat in cases of infection, which is very rare with meshes placed through the abdomen. What should we do? In general, the recommendation is a removal of everything, okay? But it's not easy, and it's a shame because then the situation starts from scratch. What I advise you to do, and it can work, let me skip a little bit in order to show you the situation. You see, this is the reoperation 3 weeks later. You have to know, of course, the spaces, to know your technique and see if you can drain without removing everything, develop the space, drain the infection. Of course, the patient has to agree that this assumes a risk of another reoperation if it doesn't work, if the conservative approach doesn't work. But you see here that with a little hole, you can access the pararectal space, you can access rectovaginal space, clean, wash with serum and iodine, and then, of course, IV antibiotics, place a drain in the area, and normally it should work without impairing the anatomical outcome. We can discuss later if you want. And now we reach the last part of my presentation, where I just present what we've learned in the long run. I think for functional surgeries, it's important to discuss about long-term results, because if you don't follow your patients, if you don't have data of long-term, you don't see your patients and you tend to think that they will be doing well. You will be surprised that, of course, patients do well in general, but you have a less good outcome in the long term if you don't know it, okay? We are now in the presentation, which is now in press, it's over 500 cases with the technique that I just described, that have been operated and followed during the last around 10 years. And as you can see, these are the outcomes. What do we find as risk factors for failure? And that's what is important, is that a risk factor is when patients were operated young, when the uterus was kept in place, and when there was initially an avulsion of the levator ani. What happened to these patients? And the follow-up was pretty long, as you can see, the global follow-up. The global recurrence rate was around 10%. Does that mean that we reoperated 10% of the patients? Certainly not. As you can see, that 4% of the patients were reoperated. And of these 4%, most of them needed an anterior colporrhaphy for a defect de novo or not properly corrected of the anterior compartment. Okay, and there were a couple cases of patients that we had kept the uterus, and after pregnancies, the prolapse came back again. The overall recurrence rate, as you can see, is sustained through the time. I personally learned a lot from analyzing the data. I had the feeling initially that if nothing happened in the first year, normally nothing would happen in the future, and that is not correct. As you can see, from year 1 to year 5, there is a slight decrease in the outcome. And reanalyzing with a Cox regression analysis, the main risk factor is what is an indication itself of colposacopexy is the levator muscle avulsion. So I think that's something that we have to assess, we have to treat, we have to prevent as possible at the moment of the pregnancy and the delivery. Prevention strategies are important. I think the overall cure rate is comparable to the literature. Colposacopexy remains as gold standard, and I think it has to be generalized as the main approach for a prolapse surgery. This does not mean we don't have to do vaginal surgery. I know there are lectures with that in the Congress. Everything has to be well offered and well indicated. In our teams, we have to offer everything. But the most frequent approach for prolapse surgery, I think definitely has to be like that. Recurrences are in the anterior compartment, and we are able to show with this study that the complication rate is low and the technique is safe, and probably we can still make it a bit easier. Just a quick show, because the data are very, very preliminary, of an ongoing RCT that we are doing in Spain. With the idea of making the technique more simple, we are running a multi-center study comparing between different hospitals, comparing if we can propose the patients to do the classic colposacopexy to the levator, or we can randomize them going to the levator or avoiding the posterior dissection. These are the hospitals involved in this multi-center study that we are running now together. And just to share with you how we are measuring anatomical outcomes and functional outcomes with surveys, with questionnaires. Up to now, we are following patients at 1 month, 6 months, and 1 year, and we are analyzing functional and anatomical results. And up to now, look at just the drawings, the initial drawings with few patients. This is preliminary data. We are not finding important differences in apical correction, in anterior, in posterior, not statistically significant for the moment, but probably there will be an evolution of the technique. This is my last slide, Leila. I'll be done soon. So in general, to close, the choice of the adequate surgical procedure, as I said, is crucial for the long term. I think that colposacopexy is a great technique that even if we do it in one way, or maybe Leila's team does different minor changes, the outcomes are very good. We have to be very well trained in dissection and suturing skills, and I'm sure in the present and future, simplified alternatives would also help you to make this technique more available in our hospitals. Thanks again for counting on me. I'll be open to take questions if you wish.
Dear Professor Barria, knowing perfectly well your technique and knowing your clinic's approach to this, tell me please. Thank you, fantastic presentation. You are a surgeon, sort of a broad specialty, and you do high-tech surgeries amongst others too. What is the share in percentage of those operations that you do? Vaginal operations? How many in percentage? How many go with endoscopic consultation? Tell me, please, what is your take on this problem? What is the distribution between them? There is another question, too. When any variant...
Подождите. Вы слышите вопрос? Да, пожалуйста.
Can you repeat the question, because I didn't hear? I was with the Russian and English, and I didn't get it.
Дорогой...
Dear Professor Barria, I have several questions for you. Thank you for your lecture. The first question is, what is the share in percentage of operations that you do laparoscopically assisted as a whole in the treatment of prolapse? One. Second question, knowing that your clinic has deep knowledge of prolapse, specializes in prolapse, and Professor Barria is one of the specialists, your father too. What is your perspective on the problem? Do you think prolapse has to do with genetics, or it is a dysplasia of connective tissue that causes prolapse? Could you go deeper into this scientific aspects of this? I would be happy to give you another 5 minutes for these questions. Thank you.
Regarding the second question that I heard better than the first for some technical issue, I'm sure, and that was part of the last of the prior slide, that we have to focus a lot on preventive strategies before the prolapse gets established. No? And I think we have to work more on that, because although our patients are having less and less kids compared to the prior generation, women are having kids at an older age. So I think there is a higher risk of prolapse and damage of the pelvic floor. And although the overall cesarean rate in worldwide is increasing, and there are less vaginal deliveries, I think not everything has to be admitted, although it's technically feasible when the time comes to have a vaginal delivery of a very large baby. I think we don't only have to measure the baby, but also analyze the pelvic floor of the patient. If you think about pelvic floor of our patients and you think about it when the patient is pregnant, we have to be a little bit more proactive and cause less long-term complications. I think that's the most important message here is preventive. Being proactive in prevention during pregnancy and of course during delivery. If this implies assuming a little bit more of a C-section, why not if we identify high risk of prolapse? And if I understood well the first question, I think it was about implementation of this technique according to endoscopic knowledge. I think if you look at the indications of endoscopic surgery in all our departments worldwide, I think we will be operating in the future probably less cancer because there's other options. We will be operating less benign procedures because there are other medical options for heavy uterine bleeding, for example. There will be more and more. What I think will gain in percentage is the surgery for prolapse. So definitely we have to teach very well our fellows, our future surgeons, on doing all the approaches, abdominal, laparoscopic, and vaginal approach for prolapse. And the advice that I shared with you that works in our fellow program extremely well is make them work in parallel with deep endometriosis and prolapse. Why? Because they are two very prevalent diseases, much more prevalent than cancer. And if they work together, they start with familiarization in healthy retroperitoneum. Once they are familiarized, they switch to deep endo where the retroperitoneum is not healthy. And how do we transfer our learning curve, to answer your question, from the experienced surgeon to the less experienced surgeon? I think the patient must not pay this transfer of knowledge, delaying and making very, very long surgeries. What we do is we make our fellows do part of the colposacopexy during their first year. We divide the colposacopexy in 4 parts. They do first hysterectomy and anterior dissection, then promontory and posterior dissection. Number 3 is the placement of the mesh, and number 4 is the full peritonization and the morcellation. We measure their times, okay? And once we are sure that they are doing reasonable times in each part, then we let them do the entire colposacopexy. With this, normally in a year and a half, they are able to do it safely and in reasonable times. I don't know if this answers your question.
Yes, thank you. You answered my questions fully. I'd like just to say that the problems of prolapse are the problems of women of all generations. There was a time when we did vaginal procedures. We had our own procedures. Then we introduced the sacrocolpopexy, promontory fixation. And right now we can do both. And we use past methods and modern methods, but unlike other clinics at the Kolokov Center, we are dealing with issues of dysplasia of the connective tissue, and we're trying to identify risk factors leading to prolapse. And we know all too well that Filipino women give birth to 10 children or more, but they have a different culture of working with the pelvic floor. And they have almost no prolapses in the Philippines. So we're studying all these issues, scientific, genetic, etc. at our center. We have doctoral dissertations written on that, studying the reasons for prolapse, why some women have prolapse develop quickly, but others almost have no prolapses after many births. Thank you very much for your elegant presentation, and thank you for sharing your material. Thank you very much, dear Professor Barry.
Entire team. Bye-bye.
Thank you. Well, dear colleagues, Andriana Genozani is with us if he is ready, because right now we have Professor Genozani, or we give the floor to Emmanuel Delorme. So what's Delorme will be first, according to Andrea. I hope you do not mind if we follow the schedule. Professor Genozani, I'm glad to see you, but first we give the floor to Professor Delorme. You won. Well, the art of native vaginal surgery in 2023. Dr. Emmanuel Delorme, a urologist, and he is based in France, Chalon-sur-Saône. Well, Delorme surgery is known to everyone. Thanks to Delorme procedure, we started doing TOT and other operations, and I saw how Professor Delorme operates in France and in Russia. So, dear Emmanuel, the floor is yours, please.
20 минут.
20 minutes. Do not overrun your time. Thank you.
Professor Delorme.
Professor Delorme, can you hear us? Professor Delorme, can you hear us? The floor is yours. Please start your presentation. Well, we need to have your slides on our screens. Please share your screen. It should be a full screen. We can't see you. Please, we can't see you. Professor Delorme, can you hear us? Can you hear us? Professor Delorme, can you hear us? Professor Delorme, share your screen, please. Professor Delorme, can you hear us? 1, 2, 3, 4, 5, 6.
Problem.
Please share your screen.
Okay.
It's okay.
It's okay?
Please open your presentation.
Yes. But
No. Please close it. Close this window, please.
yeah.
Вот я хочу сказать, что надо не лезть не в свое дело. Вот и все.
Dr. Delorme, please choose the English channel once again.
One, two, three, four, five, six. This is the voice of a translator. 1, 2, 3, 4, 5, 6. Dr. Delorme, can you hear the translator? 1, 2, 3, 4, 5, 6. No, we can hear you. Yeah, I can hear you. Yes, the translator can hear you.
Screen I share the screen that close. Okay. Okay.
Green button, screen share. Okay, now we see your email. Please open your presentation.
Okay. It's okay now?
We can't see your presentation. Please open
No.
PowerPoint.
Yes, I am on PowerPoint, but there is something wrong. I don't understand why.
I will.
Professor Delorme.
I will share my screen and then I will go to that one. Condividi. Ecco. Okay. Then, ladies and gentlemen, friends,
Значит,
Professor
профессор
Adamian.
Джаназани.
All right, Professor Andrea Gynazani, demystifying contraindications to menopausal hormonal therapy, president of the European Society of Gynecological Endocrinology, Pisa University, and our great friend for many years. Please start the presentation, Professor Gynazani.
Leila, Professor Leila Damian, dear friends from Russia, and it's my pleasure to be with you today to speak about to demystifying contraindication to menopause hormone therapy. This is something very important. As you know, we will, one second, we will go on the next slide. Okay, as you remember, since the publication of the Women Health Initiative study, which was in 2002, which was a study done in United States by using conjugated equine estrogen plus medroxyprogesterone acetate in a group of postmenopausal women, a very important group of more than 150,000. They stopped the study after 5.6 years due to an increased risk of breast cancer. And in the group of women treated only with conjugated equine estrogen, only after 7.2 years, they stopped the study for an increased risk of stroke. This was their interpretation of the study, and this was what they published. The study was, the results of the study had a tremendous impact on the general press. You see here what happened in Time on the, and all the study where all the journal, they publish that harmful results occurred on the basis of this study. And this study bring to the closure of pharmaceutical factory, to patient deprivation of a good therapeutic option. And we had in the world a 63% total reduction of prescription. You can believe that in Italy, we remain only 6% prescription for women. However, after 17 years, they were obliged to publish the revision of the study. And the follow-up of 18 years, follow-up in the WHI to use estrogen and progesterone therapy for a median of 5.6 years, or estrogen therapy for a median of 7.2 years, dear colleagues, they were obliged to publish that this was not associated with the increased risk of all cause, cardiovascular or cancer mortality. And the problem was that the American study had already a tremendous negative impact. But at the end, they were obliged to conclude that the study was not associated with any increased risk. You believe any increased risk, but in the meantime, the menopause hormone therapy was totally destroyed. In fact, they found that if women start menopause hormone therapy at less than 60 years, and normally the women start the hormone replacement therapy at the moment of the menopause, and they had and then they have also a low risk of breast cancer and cardiovascular diseases. And then they concluded that the treatment have to be started at less than 60 years or at less than 10 years since the onset of menopause, and this have to be done for the future. When we see the other studies started in the meantime to better understand, also in the United States, Howard Otis, a very famous cardiologist, published a study on oral estradiol therapy, who was associated with less progression of subclinical atherosclerosis than placebo when therapy was initiated within 6 years after the menopause, but not when it was initiated 10 years or more after the menopause. This indicates that we have to start our treatment as early as possible. And the conclusion of the study elite study were that oral estradiol therapy was associated with less progression of subclinical atherosclerosis than placebo when therapy was initiated within 6 years after the menopause. And estradiol had no significant effect on cardiac measure of atherosclerosis in either postmenopausal stratum. While in Europe, a very important study done in Finland, very close to Russia, Tommi Mikkola and Olafili Korkala and all the group, they have demonstrated that in Europe, if the women start in an age group from 50-54 or 50-59, the reduction of cardiac death risk is of 45%, the reduction of the incidence of cardiac heart mortality risk. And also in women who start from 60 to 69, they had a 30% reduction. There also a reduction in women starting from 70 to 80 years. Then, in our point of view, in Europe, the treatment strongly reduces the cardiovascular mortality. And the same group published what was the effect of the discontinuation of postmenopausal hormone therapy after the WHI, who increased the cardiovascular mortality risk. Then women who stopped, they have an increased risk of cardiovascular mortality after the interruption of the treatment. Now, another problem is, as you know, is the problem that the treatment is done by estrogen, plus if the woman have the uterus to protect the endometrium, a progestogen. But progesterone, they are very different origin. We have natural progesterone, micronized. We have dihydrogesterone, which is a stereoisomer of progesterone, and then we have synthetic progestogen, who can either originate from progesterone or originate from testosterone. But what means this origin? This origin is a family. You know, when you have in a family a child, the child has some similarities to the parents, and then those coming out from testosterone, they have some androgenic effect also. And when we evaluate the effect of medroxyprogesterone acetate, the other terrible fear of the woman is the breast cancer. Please look this result in Women Health Initiative. Here you have the two groups, the group treated with conjugated equinestrogen plus medroxyprogesterone in red, and the placebo group, and the group treated with conjugated equinestrogen alone and the specific placebo group. If you see the incidence of breast cancer in these two groups, is clear that between CE alone and CE plus medroxyprogesterone acetate, the addition of medroxyprogesterone acetate significantly increased the incidence. While the presence of only estrogen, the CE alone, this significantly reduces the incidence of the breast cancer. Then the breast cancer develops when you have also an progestogen in addition to the estrogen, and mainly medroxyprogesterone acetate. This is something that we have to maintain in mind. But it was already known before. We had the Fournier study in 2005. It clearly showed that in comparison, it was a French study, in comparison to the use of only estrogen, you have no significant increase with estrogen alone. But with estrogen plus a progestin, if you are using a micronized progesterone, which is the natural progesterone, you don't have any increase in breast cancer. If you use a synthetic progesterone, this brings up an increase. And this was something that we have already known since many, many years. I want to show you that the result of studies going from 95, which is nearly 30 years ago, until 2002. And it was already clear that the addition of progestogen increased, while estrogen only, they don't do. And when we see, this was another study from Magnusson in 1999, he have clearly shown that if you use a testosterone derivative after progestin, you have an age-related time increased risk of breast cancer, while not if you use a progesterone or a progesterone derivative. Then the role of progesterone is very important. Another side, the risk of venous thrombosis. You know, it is also, all studies show that oral estrogen administration, by the impact that estrogen have on the liver, increases the coagulation risk and increases venous thrombosis. While these do not happen if you use transdermal, because transdermal estrogen go directly to the vena cava, while oral estrogen, they go to the vena porta and they reach the liver from a side where they are able to interact with the protein, with liver protein synthesis. And this is also always present, also related to the quality of progesterone. Also, the venous thrombosis risk is such, and you can see here in the beautiful study from Switzerland that the progesterone and pregnate, they don't affect, while the norpregnate, then androgen derivative, they strongly stimulate that one. And it was also clear in the million women study, independently that is a very not so well conducted study in my point of view, but you can see here the important difference between the use of oral or transdermal estrogen and by the addition of MPA or testosterone-derived progestogen. The same is with venous thrombosis. A series of studies clearly shows that the thrombogenic risk is absolutely increased by the oral administration and less or no at all by the transdermal. Then it's also very important to go in individual to go to a better use of transcutaneous or transdermal estrogen too. And this was also reflected in many other studies. Another study of Canonico showing that transdermal estrogen use have no effect independently from the body mass index. Certainly, individuals with a greater body mass index over 30, which are obese, they have a greater risk. But if you use transdermal estrogen, these do not happen. And the same is for the ischemic stroke. In that study from Lermite in 2017, clearly shows that the stroke risk increases if you use oral administration of CE or estradiol, independent if it is less, it is 1 or 2 milligram oral estradiol, but not if you use a transdermal administration of estrogen. Then take care. In nature, estrogen have to be given by the same way that nature provides. Normally, the estrogen are produced by the ovary. They reach the vena cava. Then they don't reach the vena porta. They reach the liver through the liver arteries and not through the vena porta. Then you have to go and to follow what nature is already doing. And also it was important, the effect of estrogen after the menopause. And in this nice paper, always from Ola Filicorca and Tommy Mikkola group, they show that even the small dosage of estradiol administered to protect vaginal structure, they have an effect, a significant effect in reducing cardiovascular mortality. And at the end of the study, in the group of WHI was obliged to terminate their analysis, telling that the risk of cardiovascular disease and cancer were not elevated among postmenopausal women using vaginal estrogen, providing reassurance about the safety of the treatment, that the vaginal administration is absolutely free of any risk. It's important to see, related to the cardiovascular prevention, that in the Danish osteoporosis studies, Scherbeck, then published in 2012, she demonstrated that the use of triphasic estradiol norethistron acetate treatment in women who had hysterectomy, only estradiol. This intervention was stopped after 11 years, but they found that they have a significant reduction of pulmonary embolism and stroke. And you can see here, this is the result of the study. Looks how the treated group in green, how they have a lower incidence of cardiovascular diseases as long as 18 years of observation. Then the hormone therapy is protective for the women, is protective in comparison to the control group. And this is because, if you see, this is a beautiful study done on the association of premature, natural or surgical menopause with the incident cardiovascular disease. And you can see here the comparison for hypertension, hyperlipidemia, or type 2 diabetes between normal menopause at age after 40 in blue, in green, you can see natural menopause before age of 40, or surgical menopause in pink. You can see here that surgical menopause or natural menopause before the age of 40 is associated with a significant increase of risk factor for cardiovascular diseases such as hypertension, hyperlipidemia, and diabetes type 2. And then now I want to go on another point, another very important one. This is the evolution of dementia. The evolution of dementia from until 2050, as it is expected in low and middle income countries in orange, and in high-income countries. Please look out what is this terrible increase of million people having dementia, growing dementia, going on in the time. And if you see the group which is mustached and significantly different between the female, then we have a higher risk growth. We are expecting a higher incidence. It is already existing, the higher incidence in female, but are strongly growing of the risk of dementia for the next 10 years. And already a beautiful American study. It was a beautiful study published at the same time that the WHI, but look the difference. They analyzed it in the Cache County, the incidence of the Alzheimer in men in yellow on the left and in women in red. And you can see that women, they have a significantly higher incidence in comparison to men. While if the women were treated with hormone therapy, you can see in violet not treated, then in green treated for less than 3 years, then in gray, in pale blue, treated from 3 to 10, then in orange treated for more than 10 years. More than 10-year treatment after the menopause. It was a study done in population of an age that they have treated the symptomatic women. In the symptomatic women, this reduces the difference in the incidence of Alzheimer between men and women. Certainly Alzheimer is a human disease, but the women, they have a gender fragility, and this can be corrected by a long-term treatment with hormone replacement therapy in sensitive and symptomatic subjects. And when they have reevaluated the study 10 years after, they have published another paper, and then they have evaluated the endogenous estrogen exposure, which was calculated taking care of the reproductive window, then age of the menarche to the age of the menopause, and adjusted for pregnancy and breastfeeding. And they have found in that one that the longer duration of endogenous estrogen is associated with better cognitive status in older adult women, and this effect are extended when hormone therapy use, particularly among the oldest women in their sample. And women who initiated hormone therapy earlier showed higher cognitive test score than those who initiated hormone therapy later, providing some support for the critical window hypothesis of hormone therapy that we have always sustained. And the same is for the bone. You can see here, if you start early at the beginning of the menopause with an hormone therapy, you can maintain the bone. For some years, you can at the beginning also increases the bone mass. Later on, you will maintain, but you will not rise more. And this study was published in 1987. Then you have to believe that estrogen replacement therapy is strongly supportive of the maintenance of adequate bone masses. And when we discussed it together with a group of friends, is there a role for menopausal hormone therapy in the management of postmenopausal osteoporosis? The conclusion was robust anti-fracture efficacy of menopause hormone therapy in patients unselected for low bone mass density, regardless of concomitant use with progesterone, but with limited evidence of pre-existing skeletal benefit following cessation of therapy. Then overall, the benefit risk profile support menopause hormone therapy treatment in women who have recently, less than 10 years, become menopausal, who have menopausal symptoms, and who are less than 60-year-old with a low baseline risk for adverse events. Fundamental positive effect on the bone. Then This brings us to publish recently a paper that in the different phenotypes of the menopause. We have premature menopause, surgical menopause, menopause in healthy women, late postmenopause healthy women, menopause in overweight or metabolic syndrome or hypertension women, then who have a greater cardiovascular risk, and also late menopause in these women. And we published that from all the data, we are also in agreement that we have to start in younger age, the treatment. We have to start in women who are close to the recent onset of menopause. But I will tell you, if you start in later age, you don't have increased risk, but you don't have the same benefits. You know, the benefits are greater in younger age. The benefits are greater close to the recent onset of the menopause. But this is not that you have more risk. This is you have neutral. You don't have protection, but you have a neutrality. And then it's important tailoring the treatment. And for that one, I would like to remind that oral estrogen undergo first pass metabolism in the liver, resulting in a marked hepatic response, who include an increase in C-reactive protein, increase in insulin-like growth factor 1, in clotting factor, in hormone-binding protein, and then declining free testosterone, T3, T4 ratio, and cortisol due competitive binding. While transdermal estrogen, they bypass gut and liver metabolism, and then you have higher parent drug concentration and lower estrogen metabolic concentration. And this minimizes the effect on testosterone, on T3, T4, and cortisol. And then to whom certainly always transdermal. Always transdermal, remember, in difficult patients. Diabetic, obese, women with hypertriglyceridemia, women with increased venous thromboembolic risk, smoker, women with sexual dysfunction or gallbladder stone, and then you have to follow, in any case, the women preference and offer an adequate insurance. Then what are the tips and tricks, dear friends? Choose the natural route of administration, vaginal or transdermal. Choose the right molecule, estradiol, to prefer vaginal progesterone. And if oral progesterone is needed, choose dydrogesterone for cardiovascular disease prevention. And remind also that normally during the women's life, when the ovary stops its production after the menopause, all the circulating androgen and estrogen depend from the adrenal gland production of DHEA. But I remind you that also DHEA is profoundly declining from the 25 till to the elderly. But the DHEA is metabolized until estrogen in adipose tissue, not in the mammary gland, not in endometrial tissue, but in the skin, in the bone, in cardiovascular system, in the brain, and in the vagina. And then related to delta 5 androgen, remind that what are the tips and tricks. If peripheral DHA sulfate concentration are 1.2 milligram per liter, need to restore DHA sulfate level to 2 to 2.5. Start orally with 25 milligram a day. Check DHA sulfate levels every 6 months and modulate, decrease, or improve DHA therapy. Remind that DHA start to decrease in young women and determine DHA sulfate levels also in young women, mainly if they are during contraception. Check and modulate DHA sulfate levels across the entire menopausal tissue is of fundamental importance. This is the general picture. I remind you that we have no limit in the treatment. You have to start in healthy individual, treating them. And after 10 years, you have to reevaluate and then to reduce the dose, but you can follow and continue with the treatment with estroprogestin, only in elderly more transdermal or transcutaneous, but also oral. But remind you that the possibility to add the DHEA, to add tibolone, and to have also possible topic therapies. And in women with metabolic syndrome, obesity, hypertension, you can use only transdermal and transcutaneous. You have to avoid, to not increase any risk, to avoid the oral treatment. But you can also integrate with DHEA and topical therapy. And also in metabolic syndrome, obese, and hypertensive patients treated for the hypertension, after 60, you have to reduce the dose, but you can continue with estroprogestin by transdermal or transcutaneous route and topical therapy. Topical therapies are very important in all the group because sometimes the treatment that we use orally or transdermally is not sufficient to provide an adequate effect at local level. And then these are the conclusion of our recent paper on human reproduction update on hormone therapy in postmenopausal years, considering benefit and risk in clinical practice. And I suggest you to go to read the paper and to analyze that one. Then the final conclusion is that when beginning hormone therapy, low dose should be used and increased gradually until effective control of symptoms is achieved. Unless contraindication develop, patient may choose to continue hormone therapy as long as the benefit outweigh the risk, and regular assessment of the women's health status is mandatory. Women with premature menopause who begin hormone therapy before 50th year of age seem to have the most significant advantage in terms of longevity. Then, dear friends, what are the conclusions? The conclusions are related to the new insight in healthy aging. Fundamental are the behavioral intervention to improve quality of life. Remind that menopause hormone therapy is not a replacement of lifestyle intervention, but integrative. It's fundamental to take care of primary prevention, tailoring of the treatment, window of opportunity. We have to evaluate the contraindication and the risk related to comorbidity. And we have to remember that we have the availability of several and different compounds. Then, dear friend, I thank you very much for hearing my presentation, and I invite Professor Leila Damian as first. She's member of the board, and all my Russian friends to the World Congress of Gynecologic and Endocrinology, 8-11 May 2024. It will be an hybrid event, also available online, but all the speech will be done locally in Florence. I wait all of you. And thank you very much. I'm sorry if I was too long.
Dear Professor Dzinazanie, it is always such a pleasure. It is a real feast to listen to you because you know this problem from A to Z, from the beginning until today, till we see you at any planet. And I will certainly take note of your invitation and I will send it out to my colleagues. Dear colleagues, I can see Professor Delorme. Emmanuel, are you in line? Are you in line with us? Please.
I am in line. Do you hear me?
Please, would you like to begin, Professor Delorme, words of introduction, The Art of Native Vaginal Surgery in 2023. The floor goes to you, Professor.
Bravo.
Bravo.
Yes. I am very sorry for this technical problem, Leila. Hello, all my colleagues. I will tell you about transvaginal native surgery. Currently, it's a difficult subject because it's an old surgery, and this old surgery was 1 century ago, and there are a lot of surgery, but since 1996, it was the new transvaginal mesh surgery that change the vision of this surgery. But with these meshes, we got a lot of complications. It's why the mesh are forbidden in a lot of countries since 2020. But we have a lot of detail and topic to speak to learn about the experience of vaginal mesh surgery. Firstly, anatomic efficiency of the vaginal mesh are better than native surgery, that's sure, but it is anatomic and not functional or comfort. If we cure only 1 or 2 compartments of the prolapse and the vaginal axis is respected, the recurrence risk don't increase in another compartment. Excessive corrections unbalance the vaginal anatomy, as we saw with the mesh, and increase the risk of recurrence of the prolapse in the compartment not treated during the first operation. That's very important to make the organ in the good place and not to strongly repair the anatomy. The complications of mesh are more than native surgery. It's why the mesh are contraindicated more often, actually. To cure functional symptoms, it does not need a perfect anatomy. That's very important to understand when we do surgery. And now we look at the different topic, the vaginal mesh surgery bring us to change the surgery, the native vaginal surgery. Firstly, we look at the anatomy. We can see here the bladder, the subvesical fascia. The subvesical fascia is attached to the pelvic aponeurosis by the arcus tendinous fascia pelvis, and the aponeurosis above the levator muscle is attached to the levator muscle by the arcus levatori ani. These two attachments are very important to know to the approach of by vaginal route, the pelvis. And the arcus tendinous fascia pelvis is the key to go inside the pelvis. And to open it, we must open it lateral to the bladder neck because it is the area where it is very wide, and when we have opened it here, it is no risk to injury the ureter of the bladder. It will be a risk to open it more posteriorly. So that's very important to go inside the pelvis, that open the door inside the pelvis. And when we are inside the pelvis, it's not a blade surgery, it's a blade surgery for the eye, but it's not a blade surgery for the finger. And we have to know the arcus levatori ani, and the finger follows the arcus levatori ani to go to the sacrospinous spine. And from the sacrospinous spine, it is very easy to freeing the anterior area of the sacrospinous ligament until the insertion of the ligament on the sacrum. We have here a wide expositions of the anatomy of the pelvis by the vaginal route. And we put inside the rectum the fat of the rectum and the vessel of the rectum. The second topic we learned from mesh was to hold the vagina inside the pelvis. Firstly, we know the anchor to hold the vagina inside the pelvis, but this anchor are synthetic material and very aggressive and difficult to remove. It's why it's better to use suture, and the company developed for us tools to put suture inside and very high in the pelvis. The first experience was with the capio, and with the capio they proposed to catch the superior head of the sacrospinous ligament to introduce the suture, but that is very dangerous. And on this publication, we can see a lot of buttocks pain after this surgery. It's why it's forbidden to do this surgery like that. But this instruments are very interesting, and particularly the capio, because he has a curved needle. And if we go back to the anatomy, we can see it's possible because the curved needle to insert, to attach the suture inside the ligament and not upper the ligament. The suture must be on the middle of the ligament, far away the pudendal nerve, the uterosacral plexus and the posterior root of the uterosacral. There is no risk on the middle of the ligament. There's a high risk if it is the upper edge of the ligament. Another technique can be interesting. It is the lateral suspensions of the anterior vagina by transobturator suture. Is look like the sling surgery, but with suture. It's another trick to suspend laterally the anterior vaginal wall. What about the cystocele? There is one kind of cystocele. We know that deficiency of the fascia, a dislocated ring of the high cystocele, the more frequent, and the paravaginal defect, the lateral désinsertion at the level of arcus tendinous fascia pelvis. The classical technique, like anterior colporrhaphy, have high recurrence rates. It's why other technique were looked for. And for example, the Camper bladder suspension, that's very interesting. It is to cross the uterosacral ligament behind the bladder and suture to the puborectal muscle. On this last series about Campbell surgery, we can see there is a good outcome on cystocele, but the bad outcome because there is a recurrence in other compartment of the vagina. That is demonstrations if we use uterosacral ligament, classically suspend the vaginal vault, If we use it to suspend the bladder, it's imbalance the vagina and we increase the risk to have a recurrence of the prolapse. The other suspension interesting is the lateral suspension, as we described, with the help of this tool to put inside the deepness of the vagina, the suture on the vaginal wall at the level of the arcus levatori ani. And one surgery is very interesting. It is the subvesical vaginal flap described firstly by Crépin. The flap remains attached to the vagina and is but the problem is this flap is not a good quality of tissue. It's why we develop a reinforced vaginal flap, the same surgery, but we use capio to suspend laterally on the arcus levatori ani and posteriorly on the sacrospinous ligaments, this subvesical vaginal flap, and it's possible to reinforce this vaginal flap with woven suture inside of polypropylene inside the vaginal flap that give a surgery between native surgery and mesh surgery. We can see on the right the flap with the suture and the suture inside the flap. About hysteroptose, hysterectomy increase the operating time, the bleeding, and the perioperative complications. And with the follow-up, we note in the outcome of hysterectomy, there is approximately 25% of chronic pain, low or high chronic pain, if we look at all these 9 publications. It's why it's better to don't remove the uterus, and Donald and Fogeltil and Chiotka describe the surgery, the technique of Manchester, where they conserve the uterus, and to support the uterus, they cross the uterosacral ligament in front of the neck of the uterus that give best outcome than the hysterectomy. When there is no uterus, the Markle is a very good surgery, and it is a suture of the two uterosacral ligaments on the middle. Markle is a well-diffused, well-known surgery, and the second possibility for the vault vaginal prolapse, it is the surgery described by Richter, the sacrospinous fixation, we know well too. But it's possible to do the sacrospinous fixations with the uterus, it is the Richardson. But whereas cystocele occur less frequently in Markle than in sacrospinous ligament, because often the sacrospinous fixations is too much strong and imbalance the vagina. The colchosis remain a good surgery for all women with no sexual intercourse. There is a very good result and a low regret rate of the patients. About the posterior prolapse, the POPQ classification is not good to appreciate the posterior prolapse. There is three kinds of rectocele. The superior rectocele, it is a uterosacral deficiency, often associated with enterocele. Second, it's the middle rectocele. It's a fascia recti deficiency only. And the inferior rectocele is a perineal muscle deficiency. Three rectocele, three kind of mechanism. And it's for the upper rectocele, it's exactly the same than for vault prolapse. Remove the enterocele and close the pouch of enterocele. And second, it's possible to do a Markle or a sacrospinous fixation. The results are not so bad, but the laparoscopic approach for the upper rectocele gives the best efficiency. For middle rectocele, we have three kinds of technique. We have the posterior colporaphy par endovaginal route, the endorectal route, and the transperineal repair. Definitively, the endovaginal route with posterior colporaphy is the best vaginal surgery for the middle rectal prolapse, and remain the best treatment more than mesh and by laparoscopic route for the middle prolapse and to repair the fascia recti. The inferior rectocele, we know the classical surgery, hyperineuropathy and myopathy, but inferior rectocele most often give no discomfort, no symptoms. There are low indication of surgery. Perineuropathy is more often sufficient. Myopathy increase the risk of dyspareunia, is only for women with no sexual intercourse. We describe a technique in the publication in 2017. It was the plications of puborectal muscle bilateral incisions every side of the genital hiatus, and with a suture to make together the puborectal, the posterior area of the pubis to the insertion of the puborectal on the anal canal that decrease well the fascia and reinforce the perineal body. And in our series, it don't increase dyspareunia, and the outcome, the anatomic and functional outcome was good with 1 year follow-up. In conclusion, transvaginal native surgery remains the main surgery for prolapse. With the vaginal matches experience we got the background to improve the quality of vaginal native surgery, improve the quality of pelvic dissections after surgery of only the prolapse compartment. If the vaginal axis is respected, the risk of recurrence does not increase in another compartment. The cervix must be exactly upper the anal canal. Chronic pain and dyspareunia are exactly in the last publication, the prospect publication, are exactly the same percentage in native surgeries than in vaginal surgery. That's very new to understand that. But we can decrease pain after vaginal native surgery if we don't do too much myopathy and too much hysterectomy. Thank you for your attention.
Я
I'm happy, Professor Delorme, that we managed to listen to your entire presentation. Sorry for technical problems at the very beginning, but we have great opportunities. We have technical support anyway, and I hope that you will be a member of our team from this time on. Thank you for your surgery, and thank you for sharing your methods with us. All the best. Bye-bye. Dear colleagues, let's move on with our marathon, I would say. And now the floor is given to Professor Smetnik, Antonina Smetnik. She is head of the Department of Gynecological Department of the Kulakov Center. She is a great specialist. She is the one who continues to develop this area of menopausal metabolic therapy, aging issues, but she deals with different issues as well. Menopausal metabolic syndrome, please, the floor is yours. Try to get straight to the point. Thank you. Well, distinguished Professor Adamian, thank you for your invitation to participate in this Congress. Dear colleagues, in 2021, the Russian Society for Menopause and Endocrinology conducted a survey that showed that the major fear of patients who are going to have menopausal therapy is obesity and gaining BMI. Well, we also realized that if the patient suffers from infertility, suffers from obesity, well, more than 40% of doctors do not administer menopausal hormonal therapy. And if the patient also had complaints about gaining MBI, in this case, 40% of doctors were going to cancel MHT. Well, there was a need to have three criteria to determine the metabolic syndrome. Well, the waist is more than 80 centimeters in women. Well, the level of triglycerides more than 1.7 nanomoles, or the patient on therapy. Of course, a woman encounters different critical periods in the development of the metabolic syndrome during her life, in the prenatal period, in puberty, during pregnancy and lactation, and the menopause can be the trigger of this syndrome. If we look at the impact of age on mesenchymal stem cells, we can see that with age, well, the tissue and muscle tissues are thinning. At the same time, well, fat tissue thickness increases. Well, and this can lead to menopausal metabolic syndrome. We know that the major sources of androgen in the postmenopausal period are adrenal glands, but also ovarian traumas due to the high level of LH that continues to secrete androgens, and due to aromatase, they can turn into estrogens. Naturally, many women have the propensity for increasing BMI in the postmenopausal area. It may not be menopause per se, but age, but menopausal period can lead to increasing the fatty layer. The metabolic syndrome prevalence increases after the menopause to 70% as compared to women before menopause of 14%. The menopause has the higher risk of diabetes mellitus type 2. The study WHI has shown that the lower estradiol concentration led to a higher risk of diabetes mellitus type 2 during the menopause period. All diagnostic markers of metabolic syndrome increase significantly in the period of early post-menopause. An increase in BMI, abdominal fat, insulin resistance, blood arterial hypertension, and dyslipidemia. According to the meta-analysis, women who are on MHT have a significant drop in abdominal fat. MHT can prevent obesity in the post-menopausal period. Oral MHT increases the homeostasis of glucose and lipids. Estrogens have a positive impact on the lipid spectrum of blood because going through the liver, the concentration of hormones increases by a factor of 5 as compared to parenteral introduction. Of course, the dose, the type of hormone, and the way of introduction have very important factors. MHT have positive effects on reducing fat, increasing lipid oxygenation, and increases the use of energy. Estrogens levels were reduced when prostogen dose effect was detected. Progesterone and DDG are more neutral as far as this aspect is concerned. Women with diabetes mellitus type 2, MHT, increases insulinemia and other components of the metabolic syndrome. Despite that, the frequency rate of MHT on women with diabetes mellitus is 50% less than in general population, maybe due to the fact that in the past, diabetes mellitus type 2 was considered as the equivalent of cardiovascular diseases, and this is still quite a prevalent theory, preventing many clinicians to administer MHT to patients with diabetes mellitus type 2. Progestogens such as progesterone, DDG, or transdermal nortestosterone should not be administered in this case. According to EMAS guidelines, MHT has a positive impact on glycemic profile for women of diabetes mellitus type 2, and without it, when MHT is administered properly, it can postpone diabetes mellitus type 2, and unless there are contraindications. And as for estrogens, as oral therapy, progesterone and DDG are more preferable. A combination of estradiol and dydrogesterone had a positive effect on insulin secretion and on glycemia, especially when they were taken on light stomach. According to EMAS, oral estrogens induce the lipid spectrum of blood, and DDG or progesterone, or patients with triglyceridemia should get transdermal histogens together with DDG. According to the results of the study, 2 milligrams of estradiol and 10 milligrams of DDT improved the lipid profile, such as an increase in protective high-density lipoproteins as compared to treatment with tibolone. A combination of 1 milligram of estradiol and 5 milligrams of DDG had a positive impact on body mass and to the hip waist ratio. When we're talking about MHS, we should talk about the venous thrombosis. According to the British data, among combined MHT, only therapy with DDG did not show the risk of venous thrombolism regardless of age and body mass and regardless of the dose and regimen. If we look at this scheme, menopausal hormonal therapy is one of the strategies to prevent menopausal metabolic syndrome. If needed to prevent MHS, when there are no contraindications, and also when there is MHS developed without triglyceridemia, and in case of diabetes mellitus type 2, in case the risk of cardiovascular diseases is low, well, oral estradiol and DDG should be administered. If we have a patient with menopausal metabolic syndrome and hypertriglyceridemia, well, MHS with diabetes mellitus type 2, if there are additional risks of cardiovascular diseases, combination of transdermal estradiol with DDG is possible. If we have a patient with menopausal metabolic syndrome who already has CAS, in this case, we're talking about non-hormonal therapy, such as transferetrol. Let me just show you the data of the European Society on Menopause and Andropause of 2022, and I was a member of this group that says that not only women with a low risk of cardiovascular diseases, but also women with the intermediate risk of cardiovascular diseases can offer any type of systemic menopausal hormone therapy, oral or transdermal, in combination with primary prevention of factors of cardiovascular risk. Thus, we understand that the menopause is linked with poor metabolic profile and an increase of the risk of diabetes mellitus type 2 and cardiovascular diseases. The right chosen MHT has a positive impact on glucose homeostasis and lipid metabolism of women with diabetes mellitus type 2, and without it, oral estradiol and DDG have the optimal profile of safety and efficacy. Women with diabetes mellitus type 2 can get menopausal hormonal therapy after the assessment of risk of cardiovascular diseases. Naturally, we also recommend they change their lifestyle, such as diet, cessation of smoking, and alcohol consumption. Unfortunately, the use of MHT in our country still boils down to minor cases, because still women are afraid of MHT. They think that MHT can have an impact on obesity, on gaining BMI, and comorbid women are especially afraid of that, and that means prevention is not quite sufficient, and that means their quality of life goes down. Dear colleagues, once again, I would like to invite you to our regular conferences on endocrinology and menopause. Thank you very much. Dear Antonina, you were right, and I was right. Your presentation was straight to the point. Antonina Smetnik, head of the Department of Endocrinology of the Kulakov Center. Thank you very much. The next speaker is Sergei Kuznetsov, MHT and osteoporosis, evidence in prevention. All right, please, Sergei Kuznetsov. Only he knows what kind of bones I have. Thank you very much. Please start your presentation. Thank you, Leila, for this introduction. Well, menopausal hormonal period is accompanied not just by vegetative manifestations, but can be accompanied by changes in the bone mineral density, and that leads to osteoporosis, which is characterized by a drop in the mineral content of bones, thus leading to low trauma fractures. Unfortunately, this condition is very widespread. Every third woman, 30% over 55 have the risk of osteoporosis development. At the same time, even when women have normal mineral bone density, 10% of patients in 17 years can have osteoporosis. Those patients who before the menopause have some minor osteopenia, the risk of osteoporosis occurs after 5 years. And women with the manifested osteopenia, the risk of fracture, the risk of osteoporosis development after 2 years is very high. We underestimate the situation. The percentage of women who had not been examined is about 80%. Of course, the bone tissue health is determined by food, by sex steroids and by vitamin D. Women's sex hormones are involved in the resorption of the bone tissue, restoration of bone tissue, and in case of estrogen deficiency, there is a situation which is characterized by the fact that estrogens cannot suppress negative processes, and thus bones will be destroyed more actively. Well, bone resorption becomes more dominant, especially in the post-menopausal period. For the first time, the dependence between estrogens and osteoporosis was shown at the beginning of the last century. Patients under 65 had more cases of osteoporosis due to premature poor ovarian failure or the menopause. Later studies showed that women in menopause, well, after 47, had a higher risk of fractures. Osteoporosis developed more rapidly. Also, in the menopausal period, when it started late, well, like 1 year late, well, it led to the reduction of the risk of osteoporosis by 2 to 4%. Well, you can see that the reduction in bone mineral density occurs in the period of menopause, but this can happen 1 year prior to that, and also can be 2 years after the last menstruation, but the loss of bone density can be transmenstrual, can start 10 years before the last menstruation and 10 years after the last menstruation. The peak of bone marrow density, well, can happen also when women have hypogonadism. Well, you can see that the bone density, mineral bone density peak may not be achieved. The development of osteoporosis is due to the degree of loss of the density during the lifetime. You can see different, well, diseases shown here when we administer drugs causing breast cancer or ovarian suppression, when we administer drugs like aromatase inhibitors, which block the peripheral synthesis of estrogens. All these drugs may lead to the higher rate of mineral bone density loss. Well, we should detect women who have the high risk of osteoporosis to start preventive treatment. As of today, we have developed the FRAX algorithm to monitor such women. It was modernized and was updated. Now we have new indicators, not just the original risk factors, but also additional risk factors shown here, such as the length of the hip bone and also the intake of aromatase inhibitors, diabetes mellitus type 2, and now we can correct the regimen and assess the risk of fractures much better. This is the algorithm adopted right now. Patients are broken into 3 risk groups: low, intermediate, and high. Patients with high risk get hormonal therapy. Well, there is proof that this therapy helps a lot. You can see WHI study and 22 randomized clinical analysis. The meta-analysis was done starting from 2001. The analysis of 28 randomized trials in 2016, they showed the efficacy of replacement therapy. Here you can see the WHI study. The risk of fracture is reduced when combination therapy or replacement therapy is administered. The risk of fracture drops 34% after 5 and 6 year periods. The efficacy therapy was shown. Hormonal replacement therapy was accepted earlier to prevent osteoporosis, starting from 1986. Even before biphosphonates were approved. As for the safety profile, in accordance with the recent data and drugs have changed, we do not have any serious complications such as breast cancer. They are reduced. Now a global consensus was adopted to administer hormonal replacement therapy to treat osteoporosis. We use it for prevention of osteoporosis. Osteoporosis can be treated per se. There is also an algorithm for the use of MHT, the consensus of 2021 by the Russian Society on Osteoporosis and the Society of OBGYNs of the Russian Federation. And you can see that here hormonal therapy is being used for some time with a particular dose. The therapy can change. Well, we use a personalized approach. Doses of drugs can change. And of course, we just look at the time of the optimal use and administration of MHT. The markers of the bone tissue change as well due to the therapy. And this is comparable with the data of other osteoporosis drugs. Here you can see not only standard doses, but microdoses can be used to stabilize the situation, such as DDG and estradiol shows that 2 milligrams is enough to maintain the density of the bone tissue. Even microdoses have the stabilizing effect. Here is a clinical example at our center, a 9-year monitoring period for patients who had hormonal therapy. One patient had the radius broken, but we managed to stabilize this woman and even to increase the hip joint bone density. Here you can see that the therapy has some effect even after we stop the therapy. So thank you very much again, and I'd like to show you the slide. These are population studies in Switzerland, the follow-up period of 15 years to prevent fractures of ulna, of radius, and the therapy had a very good effect on patients who were on therapy for more than 10 to 15 years. The risk of osteoporosis dropped significantly. Well, thus, in conclusion, I should say that as of today, there is still a discussion on this issue. Why do we administer MHT for prevention, not for treatment? And some authors have a radical approach in terms of administering MHT. They provide data saying that what's the difference between a woman of T criteria of minus 0.2 before and after, and we can see that women after 40 had very good effects when MHT was administered. We hope that soon we'll have better means to deliver drugs and hormones right to the bone tissue. And I'd like to say that now we have enough means to combat osteoporosis. We must do our utmost. If you need any counseling or if you have any questions, well, here are our contacts. Call us anytime. Thank you. Thank you, Sergey, not because you are a brilliant speaker, but also thank you for sharing your knowledge with us. We keep referring our patients to you, and that's important for us in terms of prevention of the bone tissue, especially those who have such conditions or have poor menstrual cycle. Elena Yermakova, the senior fellow of the Kolokov Center, will speak on innovative methods for the correction of menopausal disorders. I should say that Dr. Yermakova has very deep knowledge in this issue. We refer patients to Dr. Yermakova, not those patients who have menopausal disorders, but also urinary disorders, to mention but a few. And she has been dealing with those patients for a long time. Please do not overrun your time. Just go straight to the point, dear Dr. Yermakova. Thank you. Well, thank you dear Leila, for the opportunity to make this presentation at this important Congress. Good afternoon, dear colleagues. Well, bring to bear that women's life expectancy increases and the average age of menopause, according to the meta-analysis, is about 49 years. We can say that the modern population of women spend from 30 to 40% of their life in the condition of post-menopause. And of course, maintaining the quality of life and women's health in this period is one of the priorities of Russian healthcare. Menopausal symptoms differ depending on the woman, the length, the severity, vasomotor symptoms hopefully disappear in time, but other disorders continue to progress, often leading to severe complications. And of course, MHT is the gold standard in correcting climacteric disorders, in preventing aging. The efficacy has been proven, but not all patients can have hormonal drugs administered due to several factors. Objective factors such as contraindications, absolute and relative contraindications, side effects, and subjective factors such as different prejudices, phobias to MHT. And here I would like to show you the results of the population study, which were published in 2022. They polled more than 5,000 French women. 87% complained about menopausal syndromes. 25% had severe manifestations. Only 6% of women were on MHT. While they were being polled, others refused MHT due to the fear of side effects. 62% of women reported that the decision not to administer MHT was supported by the attending physician. If for any reason we cannot administer MHT, we should choose alternative non-hormonal methods to correct menopausal disorders. The first line is phytoestrogens. As for phytoestrogens, and you can see stirpans, well, a lot of attention is being paid here. Resveratrol is the main representative of this group. It is effective not only to correct vasomotor syndromes, but also to prevent aging diseases. Resveratrol is coming in two forms, and well, Transform has the biggest biological activity and chemical stability. The Transform has the ability to bind with alpha and beta estrogen receptors. Resveratrol was included in more than 200 clinical trials showing that this molecule has multi-target properties. Of great interest are the studies related to the impact provided by resveratrol on the metabolic syndrome. It increases the use of energy. It reduces the accumulation of fat in the liver. It reduces resistance to insulin, enhances metabolism of the fatty tissue, and also regulates the energy exchange in muscles. Also, there were a lot of studies showing the positive impact of resveratrol on the cardiovascular system. Like estrogens, resveratrol reduces the level of lipoproteins and increases high-density lipoproteins who have the protective effect. It increases fibrinolysis due to plasminogen type 1 activator, reduces platelet activation, increases the activity of endothelial synthase, increases nitrogen oxide production, and this protective action by resveratrol can be seen not in patients with a high cardiovascular risk, but also in patients who suffer from some kind of cardiovascular diseases, in particular hypertension or heart insufficiency. There is a lot of experience in using resveratrol on patients with cognitive disorders. The studies have shown that resveratrol causes the release of neurotropic factors, helps neurons to survive, increases cerebrovascular perfusion. Some studies have also shown that resveratrol inhibits the aggregation of beta amyloids, causing its degradation, removal, and prevents the apoptosis of cells. The major reason for Alzheimer's. Placebo-controlled study showed that the intake of resveratrol improved the memory, neurovisualization, and led to an enhanced the function of hippocampus, which is responsible for memory. In 2020, the results were published of a randomized trial on the impact of resveratrol on bone mineral density. The intake of resveratrol for 12 months increased the density in the hip bone and in the spinal column, reduced the resorption of the bone as compared to the placebo group. This multi-target effect on the organism is due to the mode of action of resveratrol, not the impact on the estrogen receptors. Resveratrol has a powerful antioxidant effect. It has an impact on sirtuin system through the activation of sirtuins. It reduces the activity of the nuclear kappa B factor, which controls the gene expression responsible for cellular aging and inflammation. Those modes of action are responsible for another effect of resveratrol, anti-tumor effect. And right now, there are a lot of data proving that as a result of multiple trials. The recent review of 2022 showed the mode of action of resveratrol against tumors. It was shown that it inhibits the cellular cycle, activates apoptosis in tumor cells due to the modulation of different pathways. In the Russian Federation, well, there is a line of resveratrol-containing drugs such as pills, sublingual, and the sublingual spray containing D3 and E vitamins.
So when this sublingual form, effective form, became possible only after nanotechnologies became involved, because resveratrol is metabolized pretty fast under the influence of digestive enzyme. Nanotechnologies alone made it possible to elevate solubility of resveratrol and make its bioavailability higher. That's why we use lower doses. Efficacy is not impaired, but side effects go down. Sublingual resveratrol becomes very effective pretty soon. Peak concentration is in 15 minutes after sublingual pill is taken. At that spray, I'd like to clarify, can be used as monotherapy to correct menopausal disorders, but you can also use this as an emergency care in hot flushes. So spray could be combined with other ways to correct menopausal disorders and use it together with MHT. The efficacy of sublingual drug of resveratrol as to menopausal disorders was well studied in a number of randomized trials. This is a study of 2015. 13 patients received spray with resveratrol for 3 months, and the results showed that this phytoestrogen decreased the number of hot flushes almost by the factor of 4, and also damage such as heart impairment, psycho-emotional as well as vaginal dryness, and sexual problems. In the other randomized placebo-controlled trial, which enrolled 50 patients with severe and moderate impairment, sublingual drug decreased the number of episodes by 57% in the main group compared to 9% in the placebo group. And also the number of intensity of the symptoms as well as improved quality of life was seen in 76% of patients that were in the control group, in the treatment group compared to placebo. Well, dear colleagues, sublingual resveratrol could serve as an alternative to correct menopausal disorders in patients who where MHT is contraindicated. Besides, sprays could be used jointly with other drugs, including MHT, if we couldn't fully correct vasomotor and the other symptoms. And as the article in Obstetrics and Gynecology Russian journal says, this phytoestrogen, this is not, transresveratrol is not a mix of phytoestrogen that is difficult to standardize. It is a dedicated phytoestrogen, has a complete market activity and broad evidence-based. Dear colleagues, I thank you for your attention. Thank you so much. Thank you. Елена Ivanovna, as always, you're precise, and you help really all our patients. Congratulations on a successful talk. Thank you. Svetlana Yureneva goes next. Practical guidelines to evaluate the breast risk cancer before prescribing hormonal therapy. A doctor of medical science, a very experienced endocrinologist, a great friend. We've worked together for a long time, Deputy Director for Research for the Institute of Gynecology and Immunology of the Obstetric Center named after Kulakov. Please continue like your colleagues. Deliver us a presentation. Please, thank you. A very good day, distinguished chair, distinguished colleagues. Lila Vladimirovna, thank you so much for the invitation to take part in this Congress. My objective is to cover practical recommendations, practical guidelines to evaluate the risk of breast cancer. We say how important it is to get proper history, do screening, and we're saying what questionnaires are available. There are 3 groups of risk factor, and we do know today that a number of them, we can influence them, we can modify them. This is our potential prevention. We should avoid excess body mass, avoid abuse of alcohol, smoking, have more active lifestyle. But what we cannot yet modify is aging. Women in postmenopause, especially over 60, are a group that are in high risk group because the peak of breast cancer is seen exactly in this age. We should get family history, especially first-degree relatives, their mother, sister, daughter, since especially where cancer is seen as breast cancer in the family, ovarian cancer, it matters because mutations BRCA1, BRCA2, especially in relatives under 50, substantially increases the risk of breast cancer in close family. And today, we will highlight the importance of evaluating the density of the breasts, because high density, D, is a high risk factor for breast. Out of iatrogenic reasons, menopausal hormonal therapy, but today we'll speak about gestogen component and about radiation therapy. Let us take a look. What is the contribution of each factor into risk degree? Highest risk, highest input, genetic mutations. As I told you, BRCA. What matters here is not so much your first-degree relatives on female line, where they have the family history of pancreatic, ovarian, breast cancer, in males, breast cancer, and prostate cancer. Family history, where there are 2 more close family members, they have risk factors which increases the risk 4 times. Lobular cancer in situ, very high risk factor, and high density, D density. All other factors play much smaller role. This questionnaire, you can highlight it, you can question it, this slide, because today it is the most optimal because it helps evaluate family history of the relatives both on maternal and paternal side, ovarian or breast cancer both in relatives first degree. It takes into account the density of breast density as well as hormonal therapy at this time or the history, given not only regime but how long they took. What do we have today? First, the breast nowadays is managed by obstetrics and gynecologists, women under 40 in absence of risk factors. We need ultrasound of the breast once every 2 years if risk factors are or complaints are present, once a year. But if we have any suspicion for pathological change in mammogram or ultrasound, irrespective of the age, mainly the first peak of breast cancer is seen after delivery. This is what obstetrics gynecologists should not forget about. Women over 40, 75, mammogram once every 2 years. We OB/GYNs, as we manage our patients, as we follow up on our patients, if mammogram and BI-RADS say the woman belongs to category 1 or 2, it's normal, or diffuse dysplasia of the breast. Why is that the case? Because BI-RADS 1 or 2, the probability of malignancy is 0%. In other situations, we need either further evaluation or patient has to be referred to mammologist for counseling. Type 4D, when dense structures take anything up to 75-100% of the surface area of the breast, this is a very high risk factor of a breast cancer in a woman, both in reproductive, in post-reproductive age too. Meta-analysis of 42 trials showed it very clearly. In red is D density, both in young women as well as in older patients. Elevated risk of breast cancer by a factor of 4, 7 or more. So don't miss it. Make sure mammologists should give you evaluation not only by BI-RADS but also density, breast density, in line with ACR criteria, then you wouldn't miss this risk factor. Well, hormone therapy. The thing is that it's been 20 years since WHI trial. And follow-up on this, women showed clearly that breast cancer risk in case of monotherapy with estrogens, which were prescribed to patients with removed uterus, decreased risk and significantly decreased mortality, whereas combined therapy of conjugated estrogen with high HA significantly decreased the risks. We should clearly select gestogen component to minimize the risk of cancer. Observational study in Europe, as Finnish and French, they both showed if we choose micronized progesterone or dihydrogesterone, we don't significantly increase the risk of cancer. In Russia, we actually have these gestogens available. In the market, we have a large number of combinations of estradiol with degesterone. Another confirmation of the importance of the proper choice of gestogens in MHT is database analysis that was done in the UK. This is where you can see that combination of estrogens with gestogens, derivatives of nortestosterone such as levonorgestrel, nortestosterone acetate, as well as hydroxytestosterone from the first years, significantly increase the risk of breast cancer. Unlike this, monotherapy with estradiol, combination with dihydrogesterone, somewhat elevated the risk only 5 years after non-interrupted use. But what happens after it is discontinued? We see that the risk of breast cancer goes down. And again, what is safest is monotherapy with estrogen, estradiol, tibalone, and combination with DYD. How do we follow up on our patients, those who receive or do not receive hormonal therapy? In case where a woman gets it, then mammogram once a year, and in high density at least once a year. And this is reflected in clinical guidelines, menopause and climacteric state. It clearly says that micronized progesterone in the dihydrogesterone DYD, it in the least degree related to the elevated risk factor, so we leave it in place. These two particular gestogens, to the least degree, are associated with a high risk of venous embolism, which is also very significant. And in conclusion, may I say, mammogram, control mammogram as a screening of breast cancer is a must, but we should have a clear description in BI-RADS and necessarily draw the attention to the breast density. And high density is a risk factor. Monotherapy E2 combination estradiol with dydrogesterone, micronized tibolone have lowest risk of breast cancer. When we prescribe hormonal therapy, we need annual control with BIRADS and ICI evaluation if the patient is on MHT. Thank you. Thank you very much for the brilliant lecture, and even more thanks, dear Svetlana, for working together, and you do take part very much like your team in drafting all the guidelines, all the clinical guidelines. All the best. Good luck. We continue. Thank you very much. The next speaker on our list is Elena Vitalyevna Uvarova. Rational choice of drug therapy for abnormal uterine bleedings in early reproductive age. She is corresponding member of the Russian Academy of Science. She is in charge of the Gynecology Pediatric Department of our center, and she is also chief unpaid gynecological physician for teenagers and for pediatric patients. Thank you very much, Elena Vitalyevna, for dedicating so much time to this unique problem. Your creativity, your art, and what you do. I want a succinct, in-depth, beautiful lecture. Well, thank you very much, Leila Vladimirovna. I particularly liked that I dedicated my creative years to this work. In point of fact, we've been going hand by hand together at all times. So all the questions that have to do with how to manage girls, young ladies with endocrine, gynecological disease, it really deserves our joint attention. So today we realize that variants of an abnormal uterine bleeding most certainly change the quality of life of women, no matter when they occur first, depending on the age of menarche. So, in this sense, we don't take the blood loss 80 milliliters per cycle or more. Instead, we look more how the woman feels, irrespective of the blood loss. And of course, for teenage and young age, what is typical women in early youth is typical that there are impairments and disorders that may give rise to diseases that are known as ovulation diseases. If you look at the structure of the states that may lead to uterine bleedings in women from menarche to 18, we see that ovulatory dysfunctions are most frequent. Of course, there are many other reasons for AUBs that need to be properly assessed. Given that today the International Federation has come up, FIGO has come up with the new menstrual disorders as ovulatory disorders, this gives rise to all those predictors and, most importantly, all those special features of pathogenesis, which may give rise to this impaired ratio of estrogen to progesterone, absence of ovulation and menstrual cycle, and this gives rise to anovulation, and this, against this backdrop, we may see abnormal uterine bleedings, AUBs. So the highlight is here to properly and correctly understand when a woman will see this young patient, what is our flow chart for evaluation to make sure that we should give the proper diagnosis, and secondly, treat the right therapy. This gives us algorithm of flow chart. We need to look at the family history, we look at lifestyle, what diseases a patient's relative had with uterine bleedings that may be related to endocrine disease to understand whether there is ovulation dysfunction or not, screening of hereditary coagulopathy, and correct, proper medical examination that is supplemented with lab findings, which should take into account lab findings, deficiency of iron, overt or covered, C-reactive protein, microscopy of the vaginal swab, and smear, And in this cohort of investigation, a very important role today is done by ultrasound examination, which gives us a very good picture of what is going on with the uterus and in its cavity. Hysteroscopy has to be supplementing this too. Hysteroscopy belongs to this, which helps do it contact-free, without speculum, without grabbing the cervix, without dilatation of the cervical canal, but gives a very good diagnosis. Today, look in girls, teenage girls with AUBs, hysteroscopy, who never had sexual life, hysteroscopic picture of endometritis, hysteroscopic findings of polyp of the endometrium, hysteroscopic findings of focal hyperplasia against the backdrop of endometritis. So surely, for this reason, when we choose the algorithm how to stop, arrest the uterine bleeding, we take into account this, that the existing uterine bleeding over 2 months or 2 weeks, or recurrent nature has to take into account this inflammatory factor. And what matters here, what do we choose to arrest this bleeding? The first thing that comes into play, we need to look at biostenosis of the vagina and cervical canal. It turns out that PCR, real-time PCR, has proven there are a number of moderate dysbiosis or marked dysbiosis. And normal stenosis is seen only in 70% of girls with AUBs. This is proven by morphological characteristics of endometrium. This is proven by identifying immune components, CD138, markers of inflammatory process. This is proven by this. We certainly need to use drugs that, amongst other things, have not only anti-proliferative effects, not only hemostatic effects, but also anti-inflammatory drugs. Tranexamic acid is one of these, but we need to calculate the one-time dose, 10, 15 milligrams per kilo body mass, from 10 to 25. It helps pretty rapidly stop the uterine bleeding. Then what do we do if tranexamic acid doesn't work? COCs, especially in acute, severe AUB, or gestogen. Well, in severe, when we need to rapidly arrest the bleeding, in poor effect of tranexamic acid, we prescribe COCs. But the dosage is 30 microgram of EE per os every 6 to 8 hours. And this regimen gives us a chance to use only 2.5, sometimes 2 pills to achieve normal effect, irrespective of what monophasic combination oral contraceptive, what progestogen it contains. But if we increase the dose, this gives rise to higher number of side effects, which is well illustrated here. I was saying that today, and it's been proven, hemostasis is possible using gestogen components, progestogen components. This is an alternative, especially where there is hemostatic instability, where we see thickened endometrium, because the use of gestogens gives the same marked hemostasis, but ensures proper decidualization. Smaller stroma layer stimulates and tone of musculature goes down, and rejection of endometrium goes better. And if you choose the drug, DYD is having a good effect on progesterone receptor, and it has a good anti-inflammatory effect. We compared micronized progesterone, DYD, dydrogesterone, the leaflet says 20 milligrams per day or even 30 milligrams per day, and we showed highest effect of using 30 milligrams per day. The UBs would be stopped, as you see, on day 2, 3, and side reactions are absolutely non-existent. So we took into account that micronized progesterone is poorly tolerated. It is done per os. The girls who've never had a sexual life, we can't administer a lot into the vagina, and that's why per os administration may provoke headaches, nausea, and vomiting. We realize we need to select the dose properly, and we realize that so that we could properly create decidual reaction, we need at least 10 days, and this helps replenish iron deficiency too. You should given that this good decidual reaction, good rejection, will provoke profuse uterine bleeding for when we cessate the drugs. This is where the use of tranexamic acid would come in very handy and very timely to serve these purposes. But what do you do next? What do you suggest? If you combine COC, how long? Do we need to continue? Do we need to cease? Do we use gestogens? It turns out where we need contraception, we choose COCs. Where we need to use androgen normopathy, prevent the cysts, no contraindications, we use COCs. But in any situation, we take into account vulvar vaginitis, modified biostenosis, and the inflammatory disease of the pelvis, especially if there is a history of at least 2 IUBs, recovery of the microbiota of vagina, genes with anti-inflammatory, anti-proliferative effect come in handy. How long? Well, COCs, monophase, low dose, it turned out that their use gives more recurrences if it's used for 6 months or longer. If contraception is not needed, 3 months would be enough. And further on, we should follow the path so that we need to kickstart a physiological mechanism of regulation. Let the corpus luteus be formed. This is an important component because progesterone works in such a way when insufficient level, the activity of the apparatus of endometrium to the impact of progesterone and estrogen, highly specific dihydrogesterone, activates progesterone receptors and may be used in poor sensitivity. We understand that anti-recurrence therapy to prevent AUBs should be mostly used using progestogen drugs. This drug, the drogesterone, works well because it's not hepatotoxic, doesn't change lipid, glucose, doesn't influence the temperature, and subfibrility is possible and has anti-inflammatory effect and creates conditions for ovulation. We compared at the use from day 16-25 through days 11 to 25. And this is where we showed that days 11 to 25 gave more robust results after cessation when normal menstruations come. In 79%, regular micronized looks sad for one reason, because it's per os. I suppose it can be used, but dihydrogesterone, I'll repeat, DYD, doesn't have that many metabolites that could impact these modified neurotransmission regulation. That's why we won't have that many vegetative side effects as DYD compared to micronized form. So, the use from day 11 to 25 compared to 16 to 25 has shown also a good that regular rhythm of menstruations, they will not be that heavy, and most importantly, absence of follicular cysts and corpus luteum cysts. That's why I would like to thank you for your attention. I suppose I was on time, and I hope my presentation was useful. Thank you. Irina Vitalina, how can you not be on time? Especially, how can you not be useful? You always deliver brilliant presentations, very good, and thank you very much for the work that you do both at the center and in the country at large. Thank you. Good luck. Thank you, Leila Vladimirovna. It is my pleasure to give the floor to Anina Alexandrovna Smetnik. Problems of perimenopause and their solution. Will gestagens work? Will COCs work? Or MR or MHT? She's in charge of gynecological endocrinology in our clinic, our famous, largest and best center in the world. Leila Vladimirovna, allow me please to once again thank you for the invitation. For me, this is a great honor. Dear colleagues, I'd like to start with modern classification, International Society for Menopause, that says that woman's life from first to last menstruation is known as premenopause, whereas menopause in tradition, 1 year after the last menstruation, is known as perimenopause. And this is one of the terms, perimenopause, that comes to transition from regular ovulatory menstrual cycles to irregular menstrual cycles and the absence of menstruation because of the aging and accompanying decrease of the number and quality of oocytes. Clinical manifestations in a late reproductive period in perimenopause have infertility, irregular menstruations, IUBs, as well as poor psycho-emotional disorders and other manifestations of the climacteric syndrome. Which symptoms can a patient face in perimenopause? Well, changing menstrual cycle and high rate of AUBs, vasomotor symptoms, psychological, cognitive, somatic symptoms, and a number of others. Unlike postmenopause, which has poor level of estradiol and progesterone, what is a hallmark of perimenopause, very rapidly changing level of sexual hormones with peaks up and down that are known as hormonal chaos. And management of conditions that have to do with perimenopause is a challenge. For this reason, too, we need to compensate these large ranges of sexual hormones depending on the aging. Well, in line with the classification STOR plus 10, late reproductive periods have maximum range. Perimenopause begins with disorders of menstrual cycle and goes for 1 year after the cessation. This phase of reproductive aging may have a place in broad age, anything from 42 to 58 years. Multi-ethnic study of women, SWAN, starts 4 to 8 years before the last menstruation, although the median is 51 years. So we are not surprised when sometimes the patients at 42, 43 come to us and we diagnose them early phase of perimenopausal transition. The immediate reason?
One of the reasons of perimenopause is the reduction of the quality and quantity of follicles. They do not respond to the stimulation of gonadotropins. Poor follicle range leads to poor AMH and low antral follicle counts, but none of these criteria is an effective instrument to diagnose the time of menopause. AMH reduction to undetectable can happen 5 years prior to the menopause. At the very beginning of perimenopause, after 40 years, FSH level increases slightly, stimulating the follicular growth, which leads to an increase in the general level of estrogens. FSH growth is due to the low secretion of inhibin P by ovaries, and higher FSH during the luteal phase will stimulate the follicular phase, but the phase will be short because this can lead to early ovulation, poor luteal phase, lack of ovulation, and the higher fluctuation of estradiol level. In early perimenopause, such symptoms as flushes, especially hot flushes, reflect the changes in the estradiol level from high to low, and this can lead to vasomotor symptoms. AUBs can be due to the drop in the estradiol level and the lack of progesterone action. In late perimenopause, 2 years prior to the last menstruation, the level of estradiol drops, leading to an increase of FSH. The frequency rate of AUB is about 30% among patients of reproductive age and can achieve 70% in the perimenopausal period. The hormonal fluctuations of anovulation are the major reasons for AUB in the perimenopausal period. This time interval is characterized by the high level of estrogens and low progesterone. Women in the perimenopause, especially in the early phase, can be subjected to a higher risk of the development of hyperplasia or endometrial cancer. The pathogenesis of AUBs boils down to lack of progesterone production, thus leading to the estrogen effects and endometrium proliferation. The proliferation of endometrium leads to higher blood supply. That means bleedings become prolonged or excessive. Histogens can stop induced estrogen-related endometrial growth, stabilize the vascular network, have hemostatic and antifibrinolytic effect, and also inhibit the activity of matrix proteinase. This is done through the progesterone receptors with the safe profile. According to the recent Russian guidelines, monotherapy with progestogens can be administered to women in the perimenopausal period to prevent adverse events such as DDG. 10 to 20 millimeters per day is administered for usually 10 to 14 days. The safe profile of DDG to control AUB leads to the positive estrogen effect, the positive androgen effect. DDG is allowed to be administered to women in case of thrombosis, and unlike combined oral contraceptives, DDG can be used in women with diabetes mellitus. It can be administered to patients with migraine and epilepsy. Well, I understand it perfectly well that in some women, up to 60% of cases can have vasomotor symptoms. There is no direct correlation, but vasomotor symptoms can be provoked not by the low concentration of estradiol in late perimenopause, but also by the fluctuation of estradiol in early perimenopause, and histogens can be an effective method of treatment of vasomotor symptoms in early perimenopause. DDG is the preferable histogen according to the guidelines of major societies. Dydrogesterone has a bigger bioavailability. That is why it is suitable for the long-term use, and if climacteric symptoms develop, DDG can be used with oral or transdermal estradiol in late reproductive period and in perimenopausal period if there are AUB due to ovulatory dysfunction. Well, with or without climacteric symptoms, DDG can be administered 10 milligrams twice a day from day 11 to day 25 of the cycle. Women in perimenopause are usually on combined oral contraceptives, but if we look at the oncological risks, you can see that combined COCs can reduce the risk of ovarian cancer due to the blockage of ovulation. As for breast cancer risk, COCs and menopausal hormonal therapy, well, still lead to some questions which are unanswered. Well, micronized progesterone and DDG usually do not increase the risk, unlike synthetic histogens. But in speaking of the risk of metabolic disorders, which usually take place in perimenopause, well, this therapy can have the prophylactic effect. How to switch patients from COCs to MHT? There is an algorithm for the use of MHT. There is one criteria which is needed for climacteric syndrome when contraceptives are cancelled or when contraceptives are taken in the non-hormonal period, or off-label use of COCs or some other indications for hormone therapy, like to prevent osteoporosis, or when the menstrual-like erection stopped or at the request of the patient. We can measure FSH twice in the short non-hormonal period. If it's over 30, we can switch this woman to MHT. Well, how can this be done? Well, it depends on several factors. If it's under 55 or over 55, well, that's one thing. And also if she's on cyclic therapy, high dose, well, usually we administer cyclic MHT in the low dose. Of course, we should inform the patient about the lack of the contraceptive effect. After several months, we meet again and discuss different side effects, such as, well, blood discharge or menstrual-like erections due to the cyclic MHT or amenorrhea. In this case, we consider the question of switching her to the phase MHT. All the algorithms are written into the guidelines, and you can have free access to these guidelines. That's the website of the Society of Endocrinologists and Menopause of Russia. Well, the early phase of the menopausal switching, or when a woman has ovulatory dysfunction or delayed menstruation, or when there are light signs of the climacteric syndrome, DDG 20 milligrams is indicated from day 11 to day 25 of the cycle. Well, in case of recurrent cysts or need of contraception, well, we can administer COCs with estrogens, which are bioidentical. And if the patient is in the late phase of menopause and she has the climacteric syndrome, in this case, we can put her on the cyclic MHT. Thank you very much for your attention. Thank you, dear Antonina. That was a perfect presentation. That was an interesting subject and well presented. Thank you very much, dear colleagues. Our next speaker, Nana Tetralashvili, Doctor of Medical Science. She is head of the Department of Fetal Medicine, head of the Department of the Second Obstetrics Gynecology, of Pregnancy Pathology, of the Kulakov Center. The theme of the presentation is Pregnancy Loss in 2023. Well, you know Professor Tetrashvili in Russia. Our foreign guests know her. Well, she has had doctors in her family. Nana, please, the floor is yours, and I hope that this will be a very specific and short presentation at the same time, please. Well, good afternoon, dear colleagues, esteemed Professor Adamian. The theme of my presentation is some facts related to pregnancy loss in 2023. Well, what documents have been adopted in Russia to provide care for such women, as well as some interesting scientific publications that we can use in our practice. I'd like to say that as of today, there are more and more specialists pay attention to the problem of pregnancy loss. On the one hand, because there is an increase in the age of women who get pregnant, and as a rule, there are more cases of pregnancy loss. Also, this has an impact on fertility and on the formation of different symptoms, such as secondary infertility. Every next pregnancy loss increases the chance of women to become infertile. The Lancet journal published 3 articles in April 2021. This problem is relative indeed. Well, epidemiological and psychological aspects of pregnancy loss were considered, as well as what can we do to improve the chances of live births in such women. For the first time, there was a discussion of histogens that can help preserve pregnancy at the early stage, but also to have a positive impact on an increase of live births, and especially healthy children. When we're talking about Russia's healthcare system, there is a difference as compared to other systems. In Russia, the healthcare system has primarily relied on prevention, more volume of examination, not just after 3, but after 2 pregnancy losses. Right now, the countries are paying more attention to this problem. Now they treat couples after 2 pregnancy losses, not after 3. And as a result, well, late prevention of pregnancy complications. In Russia, we believe that every pregnancy should be preserved. If the pregnancy is accompanied by complications, histogens are administered. If the pregnancy, well, is impaired due to the previous history of pregnancy loss, histogens are also administered. Here you can see the Ashware guidelines. Only women who had the typical pregnancy loss and have bleeding will be treated. So here you can see that not all women are subject to treatment. As a result of it, those patients who had pregnancy loss due to the placenta-associated problems can have a repeat pregnancy loss. In 2023, this study was published by Figure. These are the guidelines on how to use histogens to prevent typical pregnancy loss. Oral histogens have some positive effect on this in the first trimester. We're also interested not in terms of efficacy, but also we're interested in safety of histogens and DDG in particular. And as of today, we have no doubt that DDG is absolutely safe. as you can see in the recent publications. Here is what I have already mentioned. We recommend histogens to a larger group of patients as compared to our European colleagues, because even if there is a threat of the pregnancy loss, histogens are mentioned in our clinical guidelines to prevent this situation. This is justifiable because we give a chance to pregnancy if it's a chromosomal pathology or there are some genetic aberrations. Well, this fertilized egg will die anyway. In 2023, we published this article together with our American colleagues, and Ashra Bashili, who has studied this project. Well, that was also the situation when in Israel, Bashiri published several articles. So we emphasize the fact that just the psychological support is not enough. Other methods of medical treatment should be undertaken because this helps us improve the situation with live births in women with a complex history. Well, you can see the miscarriage classification, but starting at the early stage, at the pre-embryo and embryo period, the administration of treatment will help us change the situation with live births. Of course, we understand this may be embryo development defects or fetal development defects, but we can do PGT, and we can also look at the range of different problems on the part of the maternal organism, and here we can change the situation. Naturally, well, the previous positive family history can lead to this. The age factor also plays an important role. Look at this Japanese publication, the study called Optimum, which showed that if the patient uses the extended panel, well, we can achieve better results. That means treatment of chronic endometritis, treatment of subclinical hypothyroidism, correction of thrombophilia disorders, and if there are no other risk factors, then vitamin D administration and histogens, as shown in this study, like in this case DDG, allows us to get good results in the group of young women up to 40 years old. Well, there was an increase in the number of live births by a factor of 2 in the group of women over 40. There was also an increase in the frequency rate of birth rates, live birth rates, maybe due to sometimes, but not as significant as in the first group, due to the quality of oocytes. So different ART can be used to improve the chances of these women to get pregnant. We translated this article into Russian. We published it in 2022, so you can read this article in Russian, including principles of treatment used in Japan. Why am I talking about them? Because they're very close to our principles in the Russian clinical guidelines. Habitual pregnancy loss. Well, we use this term habitual pregnancy loss. There are also cervical incompetence mentioned there, and we have all the regulatory documents allowing us to work normally. Right now, the guidelines on normal pregnancy are being updated. Let me just draw attention to, well, habitual pregnancy loss, 2 or more pregnancy losses. That means habitual pregnancy loss, examination therapy. Examination should start before a woman gets pregnant, and correction before a woman gets pregnant as well. As for methods of treatment, that's treatment of chronic endometritis, if it is confirmed. Also, surgical methods of correction of uterine pathology, if there is any intrauterine pathology or tissue deficit of the neck of the uterus, treatment of endocrine disorders, well, iron deficiency conditions or anemia, antiphospholipid syndrome should be treated with low molecular weight heparins, and acetyl salicylic acid starting from week 12, and the key aspect is the use of histogens such as DDG or micronized progesterone up to the 20th week of pregnancy. This is shown in our guidelines on habitual pregnancy loss, and the safety profile of DDG and micronized progesterone is very well studied, and these profiles are quite favorable because safety first, that's the principle we use. Well, let me also show you another publication of 2022, which sums up a lot of clinical data accumulated on the efficacy and safety of DDG on women with high risk. You can also read this publication. Also, Asher Bashiri's study, our Israeli colleague I have mentioned, is of great interest. And here, the role of DDG was confirmed in improving the situation with the live birth rate in women with habitual pregnancy loss. Also, I'd like to note, as far as this publication is concerned, and this is another meta-analysis of 2022, showing efficacy of DDG in case of habitual pregnancy loss on the basis of different clinical trials and publications. That's a meta-analysis. Of course, if we compare the use of DDG and placebo without histogens, here there are data in favor of DDG, so these data are reliable. We choose specific therapy for women with habitual pregnancy loss and other types of pregnancy loss. Just a few words about Catalinica data 2022. There was the confirmation of the high level of safety of oral DDG, which we're using here. And in conclusion of my presentation, I would like to say that right now we have all the opportunities to prolong pregnancy until optimal age for both the mother and the fetus. We have all the regulatory documents for that, such as habitual pregnancy loss guidelines. We can do pre-gravid preparation or preconception preparation, monitoring during pregnancy, and also giving birth at tertiary hospital. And that's all there is to it. Thank you very much. Thank you very much, Professor Tutrashvili. It's a very important presentation. Thank you very much for everything you're doing for us, for what you're doing for our families when they need to preserve pregnancy. You can help them. Thank you. Well, Professor Chernuka is the senior fellow of the Department of Endocrinology of the Kolokov Center, PCOS and hypothalamic amenorrhea. I've known Galina Chernucha for a long time, thousands of years. Well, she's the daughter of my very big friend, Yevgeny Chernucha, and she has been a unique specialist for a long time as far as endocrinology is concerned and gynecology as well. Thank you for your clinical recommendations that we developed together. We'll continue to work on these guidelines in the future. Once again, PCOS and hypothalamic amenorrhea. Please do not overrun your time and go straight to the point, please. Well, dear Professor Adamian, thank you for this introduction and thanks for letting me participate in this Congress. The topic of my presentation is very unusual, and actually I was very surprised because here we usually have to talk about two different conditions, but then as I looked at the situation in the past, well, I realized that I, as a practitioner, can say a lot about it. Both conditions are characterized by anovulation. These are the main reasons for secondary amenorrhea. Well, and I should say that as of today, there is a special form of hyperthalamic amenorrhea with the signs typical of PCOS. That is why there are more and more publications on the subject. So the pathophysiology of these diseases, when the patient has PCOS and functional hypothalamic amenorrhea, pathophysiology is different. That is why they belong to different types according to the new classification of ovulation disorders, well, functional amenorrhea, hypothalamic type, PCOS type 4. That means that today we do not consider these are ovarian forms of disease. So in speaking of functional hypothalamic amenorrhea, that's a reversible condition. Well, there may be stress, weight loss, well, excessive burden. There might be other behavioral factor involved. And to make a long story short, that's an adaptive mechanism in the conditions of energy deficiency. I should say that the adaptive behavior of the pituitary ovarian system is like a graded response. Right now, we encounter different deficiency conditions such as amenorrhea, but it can be oligomenorrhea. Well, it can be hidden forms like an ovulation and, well, the corpus luteum insufficiency. Well, as for PCOS, it is usually diagnosed on the basis of the Rotterdam criteria. There are 4 phenotypes of PCOS. As for functional hypothalamic amenorrhea, well, opinions are different, appearance vary, but usually when there is no menstruation for more than 3 months, well, hyper, also negative histogen tests, and everything looks like we know the differences here, but that's not exactly so. Of course, functional hypothalamic amenorrhea usually doesn't occur in women with high BMI, but usually it is typical for women of the normal BMI, although some women have a low FSH and normal BMI, but usually women with PCOS or hypothalamic amenorrhea have these conditions. Well, you can see the composition body mass where hypothalamic amenorrhea in 80% of cases has the deficiency of fatty tissue. In case of PCOS, most women have a normal BMI, but well, there are a lot of fatty layers, and that is why there is a need to use a densitometry to examine such women. Well, it looks like if all patients have a hypo, but it occurs only in 15%, it would be easier for us to make a diagnosis, but as you can see here, 26% of patients, well, the gonadotropic condition does not allow us to make the right diagnosis, and in 60% of cases there was an LH drop. This table shows lab signs of different forms of amenorrhea. I'd like to draw attention to the fact that elevated AMH is not only typical for polycystic ovarian symptom, but also it happens in case of polyfunctional hyperthalamic amenorrhea. All patients in this case, well, are sent to ultrasound, pelvic ultrasound. You can see echographic signs of polycystic ovaries in 30 to 50% of women. This happens when there is functional hypothalamic amenorrhea. Well, you can see it here, 50%, well, of them can have elevated elevated levels of different substances. Well, you can see that ovaries can be enlarged in this case. When there are enlarged ovaries and amenorrhea, well, we can diagnose them wrongly that they have non-androgenic phenotype of PCOS, which is not exactly so. There are typical forms which are quite clear, and also there is a hypothalamic amenorrhea together with PCOS when there are multifollicular ovaries, and we must diagnose such conditions because there are different conditions. Well, in case of PCOS, well, this can be the first line of therapy. There are publications on this subject. Functional hypothalamic amenorrhea means that several parameters should be taken into consideration, not such as FSH or LH drop, That would be a simple thing, of course. So we'll look at the markers. Well, 5-alpha reductase activity, some of prognostic models with the high prognostic value based on the correlation between low LH, FSH, less than 1, low testosterone level, and high level of globulin binding sex steroids. Well, and the first line is cognitive and behavioral therapy aimed at modifying the lifestyle, and often we administer hormonal replacement therapy because cognitive therapy sometimes is not fully is usually poorly provided. Well, you can see here that there is a need to identify stressor factors. Pharmacotherapy can be administered when stressor factors are eliminated. Combined hormonal contraceptives should not be administered in this case. We should prefer transdermal therapy with estradiol in combination with the cyclic intake of progestins. 70% were already on therapy, women who come to see us. Every second woman had COCs together with ART, of course. That means doctors are not properly aware of this problem. As for mineral bone density, those patients who were on oral contraceptives have 2.5 times higher reduction of mineral bone density as compared to those who were on hormone replacement therapy. There is proof of that the use of transdermal estrogens increases the mineral bone density, while oral contraceptives, so much liked by doctors, well, they do not allow to achieve the right results. As for the forms of presentation, 70% of patients who come to us got oral drugs, although in Russia, as of today, well, estradiol gel is available. Estrogel, well, it can be used in combination with micronized progesterone. We conducted the therapy of such patients using this kind of combination. So this corresponds to clinical guidelines.
And he realized we should follow the guidelines. The discussion about the link between functional hypothalamic HPA and PCOS, maybe it's transient manifestations of the symptoms that go down after MH goes down, and echographic signs of syndrome also are normalized. And maybe the patient has some sort of like suppressed PCOS, and when the body mass restores and inhibition gets away, then these lab signs of PCOS are still there. And this is how do we manage the patient following the clinical protocol for PCOS. But one should bear in mind that this patient had hypogonadotropic condition and inhibition of HHA. Treating the therapy is symptom-guided, and if there is an ovulatory infertility, a three-stage approach to enhance fertility and to correct the impairment. Insulin sensitizes if we need to regulate menstrual cycle to prevent hyperplasia, progestogens. And there are limitations in this group of patients in terms of oral contraceptives because they had hypogonadotropic condition. That's why the guidelines of European Endocrinology Society says micronized progesterone 100 or 200 milligrams daily, we use 200 to 300, is a reasonable alternative to oral contraceptives. These are products of choice probably in their situation. When HHA was blocked, if we speak about insulin sensitizers, as of today, meta-analysis 2023 say equally effective inositol with metformin. So inositol is planned, and this would happen when they would revise international guidelines that date back to 2018. They may probably be revised pretty soon. In conclusion, dear colleagues, PCOS is a functional hypothalamic amenorrhea. They have different pathology. The causative chain is not there. Different concepts are put forward. Different hypotheses are hypothesized. But mistaken diagnostic of non-androgenic phenotype of PCOS by Rotterdam criteria is possible in 2-3 cases, in 1 case out of 2-3. Ultrasound people help us when they say PCOS, but these women have functional hypothalamic dysmenorrhea, amenorrhea, sorry. So one has to look at clinical data as well as history. Maybe weight went down, maybe they had too much exercise, or maybe too much stress. Of course, it's important to look at compositional mass, LH, FSH, BMI, because the principles in therapy of these conditions vary greatly. I suppose further studies may elucidate this problem further. Thank you for your attention. Dear Galina Yevgenievna, we were afraid you would not be on time, but you did a brilliant presentation. Thank you so much for being on time, for presenting to us this general pathology. This is the value of this presentation. Thank you so much. The floor goes to Zulfiya Sabdullaevna Khodjaeva. Please, the floor goes to you. The continuum of pregnancy failure, pregnancy loss, and preterm birth. We are accustomed to seeing Zulfiya Sabdullaevna keeps us telling about preterm birth, but here she put all the two together. She's professor, deputy director for research of the Institute of Obstetrics in our center, Kulakov Center. Also, very many years we've been working together. She is an absolutely unique, in-depth researcher, and we value her highly. She's in great demand as an obstetric gynecologist. And she's mother of a beautiful girl, a beautiful doctor who works for our center too. Continuum of pregnancy failure and preterm birth, Professor Khodjaeva, Zulfiya Sabdullaevna. I do hope that you will be on time and you will describe what you will be doing. I will very much like to. Good day, dear colleagues. Let me please begin with what has become ABC for us. There's truisms that pregnancy failure and preterm birth are major obstetric syndromes. It's a multifactorial condition, but basic therapy that has been proven with the studies of high level of evidence and evidence strength, this has to do with the therapy with micronized progesterone. Most recent post-genomic studies have shown that continuum of the miscarriage is certainly there. And preterm birth, labor, we say that infection and inflammation are the leading reasons for these two reasons, but the most recent studies have shown that chemokine is anti-inflammatory pathway is playing a very important role. So it works as a very important thing in induction of different complications of pregnancy, including miscarriage and spontaneous preterm birth. Although in a number of cases, given the same pathomechanical mechanism, we can achieve similar results. We can prolong the pregnancy, or, regrettably, it will be terminated preterm. What else continuum proves? Of course, obstetric history. Please look at the high association in patients with habitual miscarriage and preterm birth. The key for successful pregnancy is successful implantation, and it has been proven it depends upon luteal insufficiency in 75% of cases. Most recent studies of molecular studies have shown then trophoblasty is hormone-independent. Progesterone supposes apoptosis cells on day 27 of the cycle in case where pregnancy has happened. Metabolism of cholesterol on progesterone has been shown in other studies, and it shows that the key enzyme, DHEA, dihydrosterone dehydrogenase of the trophic trophoblast is highly elevated compared to villus, but it's going down in patients with habitual miscarriage, and this is immediately related to secretion of progesterone. That is why it has been proven that if we prescribe progesterone to this group of patients, this may play a positive effect. Further studies have shown lower expression of progesterone receptors in membrane in women with habitual miscarriage. That also shows the need to give more progesterone to these women. Progesterone should not be given from the time it goes down, and since clinical symptoms rise of the threatened abortion. But starting with the conception, ESHRE has said so, and was further supported by the studies led by academician Saviljeva, the study Tristan-1 and Tristan-2. Most recent Cochrane review that includes 7 high-class trials have shown that there are irrefutable data that synthetic progestogens have little, if any, influence on live birth rate, whereas vaginal progestin may increase, utrogestan may increase both LBR in a woman with a history of miscarriages or bleedings at early stages of pregnancy, but may not have any side effects at all. But as to progestogens, well, these studies need to be further elucidated and continued. I should say in 2023, they withdrew from publication as Kumar's article that goes back to 2014 about EBD of progesterone in the therapy of habitual abortion, because authors could not provide the required information and documentation that would support the evidence. That is why the guidelines updated by ESHRE in 2023 on habitual abortion, only one recommendation of vaginal progesterone that can improve LBR in women with history or threatened abortion. This is a conditional progesterone, but dihydrogesterone is not mentioned at all in 2023. NICE Guidelines 2021, after Cochrane's review, were editing the guidelines and also recommend the use of this 200 milligrams twice a day vaginally up to 16 weeks of pregnancy in those women I've been discussing. But there are objections to week 16. If a woman doesn't have bleedings, it's suggested that they should stop high doses urogestan by week 12 of pregnancy. Interesting preliminary review by Alexander Katalinic about the safety progesterone. No data in favor of absent side effects, and that clearly showed that there is a clear need for further studies to elucidate this issue. Publication by FIGO 2023 about the recommendations the use of progesterone in the management of recurrent first trimester miscarriage unfortunately did not include Cochrane's reviews 2023 and disregarded ESHRE recommendations that end by 2018. So they cannot be considered to be up to date. They can't be considered to be cutting-edge guidelines. As to polyvitamins, multivitamins, it's thought that if you take several components, such as overfeed, help change their interaction, both quality and... That's why FDA and ECOG and Royal College of OB-GYNs recommends to be very cautious about routine use of multivitamins and minerals. And our guidelines also said on normal pregnancy, and nowadays, in principle, they will be repeating this recommendation in the updated version. That is why oligovitamin Vitagenal, which has micronutrients with proven evidence, high evidence level, the DHA, omega-3, folic acid, they're exactly the micronutrients that are required for normal pregnancy, for normal formation of CNS in a fetus. And the last component of my presentation would be perinatal programming. which is nothing other than a situation that is known back to the future, because the preconditions where the individual stayed in intrauterine time, this predetermines his future quality of life, intellect, good health, and his or her condition and well-being, physical well-being and mental well-being later on. From this perspective, of course, progesterones, when needed, are a situation of choice, since progesterone is neurosteroid too, because it can be synthesized in the brain cells, in hippocampus, in Purkinje cells that are responsible for our ability to acquire some mental and other skills. Besides progesterone to women with threatened abortion or imminent preterm birth, it also has neuroprotective effect because it ensures good resistance to hypoxia and takes part in myelinization, remineralization of the neurons of the brain, inhibits cascade of cytokines, cuts down cerebral edema, and plays important role for synaptic organization of the brain. And I'd like to say that it prevents FOM development, neonatal development of cerebral palsy, which in 60 to 70% of cases is not due to birth defects, but it is happening in pregnancy. I'd like to finalize my presentation by saying that intrauterine childhood or infancy predetermines psychosomatic status and quality of life. Safety of the drugs we prescribe in terms of the immediate and long-term effects should be viewed alongside with their efficacy. Natural micronized progesterone is playing an exclusively high role in problematic pregnant women from conception to the birth. We're now more speaking about safety alongside efficacy because for intrauterine infancy predetermines further well-being in life and predetermines the genetic fund of our country. A physician is a philosopher. There is no big difference between sageness and medicine. These are the words that are ascribed to Hippocrates that are still very much relevant today. Thank you for your attention. Thank you very much, dear Zulfiya Sabdullaevna, for this fantastic lecture. It is very much precise, very much in depth, something that we need given the demographic crisis and a huge number of all sorts of complications that we see during pregnancy. Thank you. It is my great pleasure to give the floor to Galina Evgenievna Chernucha. Abnormal uterine bleedings, differential approach to the choice of therapy. She is chief researcher of the Department of the Endocrinology Department of Kulakov Center. Dear Galina Evgenievna, a more habitual for us presentation, and it's very, very important because bleedings is manifestation of our disease. The floor goes to you, please. Once again, a very good day, dear colleagues. So, abnormal uterine bleedings, AUBs, is a problem that is relevant both in obstetrics as well as in gynecology. But it retains its important. It's profuse menstrual bleedings that certainly impair woman's quality of life, and the prevalence of heavy menstrual bleeding may be as high as 30 or even up to 50%. One woman out of 3 suffers from anemia. Today we're speaking about differentiated approach. Differentiated approach is predetermined by the etiology of the bleeding. And you do know there are criteria, there's classifications by FICO, there's PALM, COEN, a somewhat special feature when they identify PALM category where there are structural defects, and there is COEN criteria in absence of structural defects. So let's discuss them in greater detail. If a woman has a polyp, and polyps account for some 30% for all reasons for AUBs, then we could be guided by guidelines. But what matters most is that at this time, they're considered to be the tumor-like diseases, and we shouldn't think whether it is glandulars, fibrous. There is a polyp, and polyp that has atypical hyperplasia. This is the only thing that matters. Then, for polyps in the endometrium, what is typical intramenstrual spotting, regular menstrual cycle, risk of malignization is 3 to 4%, and usually hysteroscopic or hysteroresectoscopy with polyectectomy. And for the time investigation and final decision how we manage the patient further, we could prescribe tranexamic acid because it takes quite a while. As to our recommendations, our guidelines are posted on the website, and they say that are non-pharmacological. We do hysteroresectoscopy in abnormal IUBs when the patient wants to plan her pregnancy and in presence of risk factors for malignization, and to all women in peri and post-menopause. Second category are adenomyosis. It accounts for some 10% of cases. It's less than polyps, but we realize they are women of reproductive age who come complaining that menstruation has come on time, but it is too profuse, too heavy. Very much adenomyosis goes hand in hand with external genital chronic endometritis. It is not considered to be a precancer. Therapy could be with both hormone therapy and, in worst cases, hysterectomy comes into play. In these cases, where we try to decide upon the diagnosis, we can prescribe tranexam 3 grams per day. And where the patient, for example, refuses hormone therapy or there are counterindications, it's all reflected in the guidelines. It's frontline non-hormonal therapy. We could also use non-NSAIDs. We could suggest Mirena. In a combined pathology, suggest agonists. And if it's a nodular form, maybe operation would come into play. Myoma. I suppose in this Congress, much was said about myomas. Let me add my 2 words. 30 to 40% of women have symptoms that require therapy. It means 9 out of 10 with myoma do come to us because of AUBs. We can suggest, unless there are indications for operation, we could suggest they could get something from medication therapy, but we should remember that progestogens in phase 2 of the cycle are not effective. They're basically not used, they're not existent in any guidelines, and has to do with antifibrinolytics in oral contraceptives in 21 days. This means BMT, menstrual blood loss, goes down by some 40 to 50%. But patient's profile with myoma is clear to us. The patient may be getting a prescription for regression methods of therapy, or in submucosal myoma, we may prescribe an operation, maybe hormone therapy. It's more, Migestril is used among the drugs that are available at this time. But if a patient is against hormone therapy, if she wants to preserve her uterus, her fertility, then we can prescribe non-hormonal therapy. This is something that our guidelines say, that you could use both tranexamic acid and non-steroid NSAIDs, but they're less effective. We could, in bleedings, recommend Mirena 2 and COCs, but only for contraception only. For example, when menstrual blood loss is there, but not to decrease or prevent the new nodes, new foci, and mifepristone, I mentioned that before. As to hyperplasia, they are category 4 for organic reasons. You're all perfectly aware there are 2 categories today, without a tear and atypical hyperplasia. Hyperplasia is manifested with late period that goes into heavy bleeding. Risk of malignization depends on whether it is atypical or not. These patients, of course, need to have hysteroscopy and DNC, and later on our recommendations say it's easier for physicians to work because it's all written down. It's all down. Frontline would be local levonorgestrel. If a patient refuses, then progestogens, uninterrupted or prolonged administration. Nobody says they need oral contraceptives that our physicians are so keen on. Why am I saying so? Because when we are seeing our patients, we are actually keep seeing the wrong diagnosis, wrong prescriptions by physicians, because the patients come to seek second opinion. The guidelines say, yes, you can prescribe agonists in case where hyperplasia goes hand in hand with the myoma or endometriosis. This is a category for non-organic reasons. We should remember there could be congenital hemostasis impairment, Willebrand's disease, that should not be disregarded. 70% accounts for them. This mostly are bleeding, cyclical bleedings that with menarche, but the therapy here, what? Together with hematologist, it means that patients are prescribed either, if the diagnosis is confirmed, therapy with coagulation factors, or concentrates or packed or adjuvant antifibrinolytic therapy with tranexamic acid. And this is something preferred in cases where, on days of menstruation, instead of desmopressin, when a patient seeks a pregnancy. Well, maybe we could hormonal therapy could come into play, maybe intrauterine device with levonorgestrel. If there is an ovulatory dysfunction, this is a broad range periodic disorders when there is anovulation until chronic anovulation is there. Anovulatory dysfunction are not that widely present. Usually hyperplasia is coming into play. Manifestation is because of late period and further bleedings. It has to do with comorbidity, with obesity, excess body mass, and this is where we should recommend hormone therapy. The therapy is explained by the etiology. If hyperandrogenia, hyperprolactemia, this is one story. If a patient cannot be clearly defined with the etiology, then we prescribe progestogens to prevent hyperplasia of the endometrium. If a patient wants to be pregnant, then we need to induce ovulation. We try to normalize the rhythm of menstruations to avoid endometrial hyperplasia. Very interesting, maybe a diagnosis of exclusion, endometrial dysfunction. When we investigated the patient, we didn't find anything. Then the patient keeps asking what could be the reason for that. We say maybe local fibrinolysis is impaired, maybe disbalance of prostaglandins, maybe MMA, MMP's disbalance, maybe chronic endometritis. And there are situations where there are no clear indications for chronic endometritis by ultrasound findings. We do polybiopsy to exclude this condition. Where there is endometritis, then the patient treats her chronic endometritis. But if we cannot identify any particular reason, because test systems to detect exactly at the level of endometrium are non-existent today, then these patients are referred for long 3 to 4 day courses of intermittent courses with hemostatic non-hormonal therapy. The product of choice is usually tranexamic acid, 3 grams per day. This goes in line with the European measures, or rather European customs. In Australia or Japan, they could go for 4 to 6 grams per day. We shouldn't fear large doses because the effect is dose-dependent. Bleedings may be iatrogenic. Should we ask the patient, maybe she's on other medication? We should always warn the patient that if she gets other progestogens, for example, she may get these situations. That's why what sort of therapy, change of a drug or cessation of hormone therapy, discontinuing. If impossible, we discontinue basic therapy. If this is impossible, then symptomatic care would be a suggestion, non-hormonal symptomatic care. Lastly, unclassified reasons for AUB. Arteriovenous malformations may come into play, niche after C-section or hypertrophy of myometrium, but they are pretty rare. Which therapy is there? How much more time do you need? 1 minute, Leila Vladimirovna. Sorry, either embolization or metroplasty or symptomatic hemostatic therapy. That's why, in conclusion, may I say that the therapy of bleedings in PAM category is mostly surgical, whereas going, pharmacotherapy, and it should be done in line with the guidelines that we have today. Thank you very much for your attention. Thank you very much, dear Galina Evgenievna. This is a topic we reviewed very widely. In person by Professor Milton Monbro spoke about this topic too. Thank you very much. That's it. We're continuing our Congress, please. Professor Kuzmin. Vladimir Nikolaevich Kuzmin, professor of the Department of Reproductive Medicine and Surgery of Moscow State Medical Dental Institute named after Yevdokimov. The name of his presentation is Current Options for the Prevention of Dysbiosis During Antibiotic Therapy. Professor Kuzmin, please be on time, be succinct, and cover this topic in great detail. Thank you, Leila Vladimirovna. The problem of antibacterial therapy and certainly complications is hidden here. We have today a large number of pathogens, both in anaerobic bacteria, also in STIs, as well as in opportunistic infections. But after we have analyzed it in our hospital number 15, we see that in the last 10 years, we see changing microflora in general, and changes, for example, in different clinics. For the most part, we move away from streptococcal and staphylococcal infection. We move towards anaerobic microflora, and fungal infections come to the fore. These pathogens may impact the situation in a different way, and this gives us certain requirements for antibacterial therapy. We need to evaluate the microflora that provokes these infections. We must evaluate possible elimination with the antibacterial drug, and of course, we need to start as early as possible the antibacterial therapy, and we have to control for antibiotic resistance, which is something we need to first look into. We do see antibiotic resistance, and because of this, a state program for the strategy for prevention of antimicrobial resistance prevention, where I suggest we should prescribe antimicrobials only for good reasons, and only for groups where resistance is rising very slowly.
Because as of today, we've got a lot of pathogens resistant to antibacterial drugs administered, bringing to bear the anaerobic microflora, and the number is increasing every year. That is why modern drugs such as monolexin, which can change the situation by reducing resistance, because when there are antibiotics on the market which do not cause resistance, well, it is quite obvious then new drugs will cause less resistance as far as the existing pathogens are concerned, taking into account gram-positive and gram-negative microflora, including sexually transmitted infections. There might be a possibility of administering combination drugs, and naturally, there may be combined regimens, but any administration of such antibiotics leads to poor situations with dysbiosis. Everything depends on the pathogens and the microflora. Recently, the number of Candida increases. Also, vulvovaginitis caused by Candida is on the rise. And often, we see that they are resistant to antimycotic therapy. It should be taken into account that those strains, such as Candida, both carriers and sick patients, can be the same in terms of their characteristics. So the main trigger of the disease is not the change in the property of fungi, but change in the immunoresistance and immunoprotection of the patient. As for the process of self-purification of vagina, it is not quite effective. Thus, the fungi use antibiotics as the source of feeding. That is why broad-spectrum antibiotics can suppress lactobacilli, which are antagonists to fungus. Lactobacilli are the main protectors fighting for the adhesion to the mucus. They can produce glycogen and oxygen oxide, and this changes the entire flora. Lactobacilli produce antibiotic substances and stimulate immune response. That is why the administration of prophylactic drugs, especially when we have recurrent vulvovaginal candidosis, is possible from the onset of the disease. Such drugs, such as netamycin, that has the antibiotic property, killing candida, but also it has lactose that contributes to an increase in the number of lactobacillum. Acufusin is one of the drugs used here. Lactulose is a probiotic. Lactobacilli use them as the feeding substrate, thus increasing the number of lactobacteria. Lactobacilli normal level is restored on day 1 when this drug is administered. And I should say that lactulose doesn't stimulate the growth of anaerobic bacteria, and that means we can improve the efficacy of therapy. Candida doesn't metabolize lactulose. That means there is no candida growth. On the basis of this, we conducted a clinical trial, and women who are on antibacterial therapy usually got this particular drug, especially when they have a gynecological surgery planned, and we made a comparison with drugs when antibacterial drugs only were administered. We did the assessment on day 13 and day 30 of the use of both antibacterial and antimycotic therapy. As a result of the data obtained, you can see that patients who were on acufusin and antibacterial therapy at the same time had no changes of vaginal dysbiosis. However, patients who were on antibacterial therapy, already on day 13, 18% of women had complaints typical of dysbiosis, and on day 30, 21% of women had more complicated complaints, more severe complaints. Also, during the study, it became clear that the patients on acufusin and bacterial therapy, all women had lactobacilli. They did not change in terms of original level, but patients who were on antibacterial therapy had a reduction in the level of lactobacillus. And this was shown clearly when tests were taken, and you can see patients on acufusin and antibacterial therapy, the level of lactobacilli was normal as compared to just patients who were on antibiotics without any additional antimycotic protection. Bifidobacteria levels were assessed on day 13 and day 30, and well, bifidobacteria preservation is very important for patients who are on antibacterial therapy as compared to patients who did not use ecofuscin and were only on antibacterial therapy. Thus, during the entire observation period, not a single patient in the group of ecofuscin and antibiotic had Candida detected, but patients in the second group who were on only antibiotics, starting from day 13, there was a growth of Candida fungi, which required additional treatment. As for conclusions, the use of modern antibacterial and antimycotic therapy in combination, such as natamycin and lactulose, allows us to use it for a long time. They have a good preventive action to reduce the development of bacterial dysbiosis caused by Candida. This combination of drugs is absolutely safe and effective. In addition, I would like to say that there is a need to prevent vulvovaginitis caused by Candida, not only by having an impact on the microflora of vagina, but also on the GI tract, which can increase the chance of recurrence of vulvovaginitis. There is a need to prevent this kind of infection and thus to reduce the probability of recurrence of vulvovaginitis as a result of the long-term therapy. Adequate antibacterial therapy and the restoration of the microflora is the key to success of treatment of vulvovaginal infections. Thank you very much. Thank you, Professor Kuzmin, for this in-depth analysis. And I know that for many years you've been dealing with issues of prevention and treatment of female infection. That was a very important presentation. Dear colleagues, now I'd like to give the floor to Irina Kazachenko. The theme of the presentation is the role of hysteroscopy in women of reproductive age, prevention of synechias. She is a doctor of medical science, senior fellow of our gynecological department. Professor Kazachenko has made great progress. She's a unique specialist, a doctor, a surgeon, and she's my deputy in the simulation center, and she is a very successful instructor at the simulation center. Irina, please try to be brief and straight to the point, please. Well, good afternoon, dear colleagues, esteemed Professor Damian. Thank you for your warm introductory words. Now I have another incentive for further development. The role of hysteroscopy in women of reproductive age, prevention of synechias, is the theme of our presentation. Hysteroscopy is not just a diagnostic method and treatment of intrauterine pathology, but also it's a major stage in the reconstructive operations on reproductive organs. We can also assess previous intrauterine interventions and control the efficacy of combination therapy, especially in patients with endometrial hyperplasia and initial stages of different types of cancer. In our clinic, when we do diagnostic hysteroscopy in patients of reproductive age, we often encounter chronic endometritis, uterine myoma, adenomyosis, malformations. Well, intrauterine synechias, hysteroscopy allows us to assess and to treat niches after C-section, to do the treatment regarding foreign bodies in the uterus, and also to correct the hypoplastic processes of endometrium. Well, in a nutshell, speaking about nosologies that we encounter in patients of reproductive age as a result of hysteroscopy, well, submucous myoma is number one. Well, we know that submucous myoma is an indication for myomectomy. Well, there may be an improvement of the results in using reproductive technologies in general by 16%. There is a high frequency rate of endometrial receptivity, and here there have been a lot of studies conducted. Adenomyosis with the use of resectoscopes, with the possibility of resection of adenomyosis under the ultrasound control. Our foreign colleagues came up with the classification of cystic adenomyosis on the basis of hysteroscopic diagnosis. Naturally, adenomyosis is usually accompanied by poor fertility due to poor molecular expression of endometrium. Intrauterine septum, and there was a wonderful presentation by Zagrat Makian. Once again, I'd like to remind you that here we have a huge percentage of pregnancy loss after the septum is dissected. There is a growth in the frequency rate of live births, and because we changed the receptivity of the endometrium, hysteroscopic resection of the scar is another thing used here. Let me just remind you, dear colleagues, that the criteria for the need of isthmoplasty is pregnancy planning and clinical manifestations. The criteria for hysteroscopic incision of the scar is the myometrium scar more than 3 millimeters. What's the role of hysteroscopy in women of reproductive age? First of all, hysteroscopy to diagnose infertility. It should be the final method of diagnosis and treatment of intrauterine pathology according to our clinical guidelines. Hysteroscopy after repeat IVF failure. We do not discuss this. It's quite natural. In this case, there will be an increase in the number of pregnancies, and we can detect intrauterine pathology in 45% of cases. As for hormone therapy, that's an arguable question, but we can say that hormonal therapy reduces submucosal nodes, decreases the thickness of my endometrium, but, well, besides positive effects, there is a need to delay the operative treatment by 2 to 3 months. There are different types of energies used when hysteroscopy is performed. Again, I'm not going to go into technical details, but we must remember that our goal is not just to reduce intrauterine pathology, but to carefully treatment of endometrium. Intrauterine synechia, 90% of cases of the development of manifested intrauterine synechia are due to complications of pregnancy in the postpartum period. As for gynecological surgeries, the frequency rate of synechia detection varies depending on the type of intervention. Well, it can be up to 78%. Lysis should be done using the mechanical energy if possible, and this allows us to reduce the number of recurrences and to increase the number of pregnancies. We conducted the study together with Professor Martinov and Leila Damian. 248 patients were included in the study. There is a publication on this subject. And what is meant by prevention of intrauterine synechia? Use of different barriers, mechanical barriers, biodegradable hormonal therapy, the use of various biological means, but right now we are primarily using intrauterine gels on the basis of hyaluronic acid. Well, all the existing surgical methods to prevent synechia have their own efficacy. We've been studying such efficacy, such as gels on the basis of hyaluronic acid and the use of intrauterine injection of platelet-rich plasma. Right now, we recommend to use gels with hyaluronic acid after all intrauterine interventions. In this case, there is a reduction in the synechia formation. Right now in Russia, there is an anti-adhesion barrier, anti-adhesin. A biodegradable gel is recommended. It has the salts of hyaluronic acid and carboxymethylcellulose. Well, at the critical phase, well, the gel showed very good results. We used this gel in our experience. The indications for diagnostic hysteroscopy for patients with pregnancy loss, well, you can see the indications and contraindications here. Well, after diagnostic hysteroscopy, when the operative intervention was performed, well, we inject anti-adhesion gel, then we administer cyclic hormonal therapy for 3 menstrual cycles if needed, and we administer antibiotics together with restorative physiotherapy. Our experience of the use of gel is based on 114 patients with poor reproductive function. No complications were detected, while control ultrasound 3 months after the surgery showed that only 33% of women had intrauterine synechia out of 114. Primarily, most patients who were treated for intrauterine synechia per se. Well, the reproductive function in patients with intrauterine pathology was assessed during 1 year after the surgery. That was our follow-up period. The analysis of data showed that the restorative treatment of intrauterine pathology reduces pregnancy loss by 1.5 times, and there is an increase by 1.5 times in the number of pregnancies achieved. The results were published in Obstetrics and Gynecology journal. If you are interested, you can familiarize yourselves with the results. In conclusion, I would like to emphasize that hysteroscopy remains the gold standard in the diagnosis and treatment of intrauterine pathology. While therapy is important to optimize the conditions for implantation and preservation of pregnancy, and this is my final slide on behalf of our team and Leila Damian, I would like to invite you to our simulation and training courses on laparoscopy and hysteroscopy. Well, it will be next week, starting from June 14th, and then there will be a special course starting from September 1st. Thank you very much again. Again, we invite you to attend our course. Thank you. Thank you, dear Professor Kozachenko. I forgot to note that, well, your parents were also doctors, and we saved, well, hundreds of lives. Thank you very much. Dear colleagues, we continue our Congress. Now the floor is given to Dr. Puchkov, Konstantin Puchkov, laparoscopic myomectomy, prevention of adhesions. Professor Puchkov, the director of the Center for Clinical and Experimental Surgery, please. Dear colleagues, I would like to invite you to the operating room of the Swiss Medical Clinic. There will be an operation on uterine myoma, laparoscopic myomectomy with occlusion of the arterial bed. The node is 7.5 centimeters, and I always remind you that in order to avoid any new pathologies such as adhesions in case of laparoscopic myomectomy, several rules must be observed. First of all, lavage of the abdomen and the use of the anti-barrier gel. I use anti-adhesin, 10 milligrams, 2 syringes. Thus, we can cover the entire wound on the uterus. I invite you to the OR The first stage of myomectomy, we use the uterine manipulated Clermont-Ferrand Karl-Stotz that allows us to elevate the uterus, to rotate it left or right, and to see umbilical vessels clearly. Now you can see we use the monopolar electrode on the left. I isolate the internal iliac artery. I use soft grafts. I use the DeBakey grasp used in vascular surgery. We just squeeze this iliac artery, internal iliac artery. I use a monopolar to separate the posterior wall of the artery, separating the iliac vein from the vessel, and to prevent any damage. And we use another DeBakey grasp on the artery. This allows us bloodlessly work on the uterus to see the mucus and to do a thorough dissection, removing the node without opening the uterine cavity. At the next stage, I do the incision over the node. We open the serous opening. I take 2 clips, 10 millimeters, without electric surgery. Well, I can incise the nodes. I use a monopolar electrode. I isolate the node without opening the uterine cavity. You can see that the wound surface is absolutely dry. There is no blood here. So this method of temporary occlusion of arterial bed allows us to do this operation without any blood loss quickly and well. Now you can see suturing of the uterine wound. I usually do this by Veloc, suture 0180. It will dissolve. 6 months later, this time is needed to have the good post-operative scar. Since we are suturing when there is no bleeding, so there are no cavities between our stitches, this means that in 99% of cases the scar will heal due to the primary tension of the suture. More than half of the patients have physiological deliveries without any C-section after the removal of large myomas. As a rule, there is a need to have several layers of sutures from 2 to 5, 6, and 7. Everything depends on the depth of the wound. Sometimes people ask me how many layers there should be. Well, it depends on the situation. It depends on demand. Right now, we're going to do the suturing. So I form the last stitches using the Veloc suture. Now I'm going to have single stitches. I will be using monocryl 0. It is smooth. It allows me to capture the muscle layer. And in this case, well, I do extracorporeal knotting by single stitches. Here we can create quite a good tension for good post-operative, strong post-operative scar. In the post-operative period, there is a need to do the lavage of this area, and then we move on to morcellation of the node that we're going to remove. Right now, you can see the right ovary where the cyst is located. At the next stage, we're going to remove it. Right now, I am removing the DeBakey grasps on the left and on the right. Now you can see that there is no bleeding in this area, so this is just the dry scar. So you can see this scar from different angles. At the next stage, I will do the morcellation of the myomatic node using the Karl-Stotz morcellator, and then the introduction of anti-angiosin, usually 10 grams to syringes. During this operative intervention, we removed the right ovary cyst. It was small, 3 centimeters in diameter. So, unfortunately, the frozen section showed borderline cyst, ovarian borderline cyst, which was the contraindication to the repeat intervention. Well, usually adenectomy should be done, and that's it. That's what we did. So 14 days after the main surgery, we did this stage, and now laparoscopy will show you the operative field 2 weeks after the first surgery. There is no adhesion on the uterus and around uterus. That means that the effect of anti-adhesive gel was quite good. This is 2 weeks later after the operative intervention. So we did repeat laparoscopy to perform adenectomy because histology showed that it was borderline tumor. Well, and the tumor board decided to do this kind of procedure in volume. So right now the patient is in the Trendelenburg position. Well, you can see there are no adhesions. A very good scar is visualized, no adhesions in the post-uterine space, no effusion. I'm going to do the lavage of the abdominal cavity, and I'm going to do adenectomy at the next stage. Well, thus, this case allows us to make the following conclusions. To prevent adhesions after myomectomy, you need to follow the following rules. First of all, it should be a minimally invasive surgery, laparoscopic surgery, not an open surgery. Well, during laparoscopy, well, first and foremost, you must be sure that there is no bleeding during the intervention, and this can be done by the occlusion of the arterial bed. Also, thoroughly debulking of the operative field. We use the stereo saline so that we could prevent adhesions, and the use of anti-adhesion gel. In this case, we use anti-angiogen. We've been using it for 8 years in our clinic, and we've only had positive effects. Anti-angiogen contains hyaluronic acid and carboxymethylcellulose. The acid is the main component of the cellular matrix. Carboxymethylcellulose provides for the formation of film on the wound surface and enhances the effect of hyaluronic acid. Based on our 8-year experience of using anti-angiogen in gynecology, we can make the conclusion that it is quite effective, and I recommend you use this gel for effective use to prevent adhesions formations after myomectomy and complex forms of endometriosis. Dear colleagues, thank you. So that was the video by Dr. Konstantin Puchkov, and yes, we use this gel as well. As indicated, we should work within the framework of clinical recommendations. Well, if someone says it's a must, it's not for everyone. Don't say it's a must, but only when there is a high risk of adhesion formation. And also, you should not just use the grasp on vessels anytime, only when it is needed, only when the nodes are not favorably positioned.
There is a minor remark here. In 8 minutes of operation on this video, 16 times the word I and only 1 times we. I just, as a comrade, wish to just tell it to Konstantin Viktorovich. As to the point of this presentation, laparoscopy, very much like other methods of reconstructive operations, they are indeed of high risk for adhesion formation, and that's why we can observe all the principles of microsurgical operation. This is humidification of the tissues, proper suturing, minimal bleeding minimization, faster operation, and if any need, using different tips and tricks against adhesions. The best trick that works against all barriers belongs to the Center of Gynecology, where I have the honor to work for many years. And if you look up at 100, say, surgeons, be it this country or elsewhere, who work within the reproductive technology area, then all are observing these principles. But the word mandatory, nobody ever said that, especially in terms of occlusion of the blood vessels, and especially in part of mandatory use of one or other gels. As a whole, the presentation is good. The technique is that Professor Puchkov has is good. I should say that this presentation is useful because it also, once again, as part of this Congress, has shown that we should work, and our work should be in line with exactly restoration of the reproductive function. The main conclusion, take-home message, next time, when somebody should be using their own technologies, tips and tricks, nothing, it is a standard technology, one should try to say that in line with guidelines, this is something that should be done. Restoration, creating enabling conditions for reparative generation, both in pre-op setting, as well as intra-op, as well as in post-op setting. Then all will sound well. We cannot guarantee that 1 out of 2 patients who fell pregnant and had immediate delivery was spontaneous. Well, that's a bit risky. Maybe Dr. Puchkov, despite his good experience, maybe still young. Maybe he's so much carried away. Thank you very much. Okay, we move over to the next presentation. Tatiana Valerievna Kirsanova, MHD and thrombosis, risk management. She holds a PhD in medical science, senior fellow in the Department of Reproductive Hematology and Clinical Hemostaesiology in our center. She's a unique doctor. She's a hematologist. She prepares our patients for the operation fantastically well. God has been kind to us. I'm not saying never. I'm never saying never. We rarely, if at all, see complications because every time a good operation, first and foremost, is a good preparation, well-prepared situation, well-prepared patient. This is a prerequisite. Dear Tatiana Valerievna, please be succinct in your data. Thank you. Presenting your data. Thank you. Dear Leila Vladimirovna, thank you very much for this warm presentation. Allow me, please, to give you my presentation to menopausal hormonal therapy. We still live in a certain vacuum based upon evidence-based data, but that mass media keep putting pressure on us, some fears, some myths, and mass media do influence the minds of our patients. They come with a sort of with a bias. They say, oh, we'd never go for hormonal therapy because they're very high risks. Let's look at it. Indeed, a few words I'd like to say about prehistory. Because indeed, in late 80s, when good understanding came that since the time of menopause, this is the important risks in women's life that they come to the fore. They try to minimize them by prescribing hormonal therapy exactly. In the early 1990s, they went to Wyeth, came to FDA, trying to put the labeling to hormonal products as to some cardiac protective effect. Evidence-based medicine was just fledgling at this time, and there was an attempt to do a clinical trial to ensure whether this cardioprotection was there. 2 major clinical trials of secondary prevention and primary prevention. The first study about primary, pretty small number of women in the HERS study, and the results that were not seen in previous observational trials, they showed 3 times higher risk for venous thrombosis. Well, the study, no randomization in age, menopause, undamaged uterus, and such as MI, cabbage, balloonplasty, and others, whereas Women's Health Initiative was cut short sooner, was because the number of thrombotic complications and other risks exceeded the advantages, the benefits of therapy. All the tabloids immediately say that HRT doesn't protect women from cardiac disease in long term. Instead, it actually enhances the risk of MI and other thrombotic complications at the very first time as it starts. We somewhat forgot about COCs because this path was traveled somewhat sooner at a time when they were published and became widely produced. First cases that describe all sorts of thrombosis came to in print, especially deep vein thrombosis, arterial thrombosis, and this hormone phobia or thrombophobia. It is somewhat, it does play a certain role because we see criteria of acceptability for different contraceptive measures. They were revised several times. The most recent was done in 2015, and we should be guided by them when we prescribe contraception. Luckily, same criteria for hormonal therapy were taken for menopause, and formally they were published in 2022. In terms of the regimen, they very much remind acceptability criteria for contraception, different categories of safety, first, no limitations, and fourth, when MHT should not be used. So thrombosis, a history of thrombosis, immediately make MHT risk 4 group. Pulmonary embolism as well as deep vein thrombosis are a significant problem, but the number of cases is rising every year. It doesn't have to do so much with absolute numbers rising. Probably we're now better diagnosing them and better awareness. Maybe first clinical manifestations make us diagnose and timely identify thrombotic complication before it manifests in life-threatening. During women's life, we undergo a number of risk factors, starting with family planning and pregnancy planning and using contraception, IVF per se pregnancy, and menopausal hormonal therapy. It should be taken as an axiom when we use PHT, risk of all thrombosis goes up. At that, we should properly inform the patient first about the symptoms so that we should diagnose them as early as possible. Look how much this risk could not compare with the risk of major interventions, long air flights, or, for example, in pregnancy. It is thought that the woman who takes MHT has 2-4 times higher risk of venous thromboembolism compared to those who are not on MHT. And this compares to attributive risk in taking COCs. It is thought that in absolute figures, this risk is somewhat higher, but because of age per se, because age seems to be accumulating the risk much higher. 2019 saw the publication of a major British trial where they evaluated the risk of thrombosis in the cohort of 80,000 patients aged 40 to 79. It turned out that high risk of venous thromboembolism, VTE, was seen for all per-os MHT drugs, including COCs, and those that have estrogen only. Basically, conjugated estrogen was higher than CEE. DID had this with CEE was highest, and they had to do with a high risk for sure. What is important? BMI, which is in the criteria for the acceptability criteria in MHT, doesn't come as such an important factor. We are saying that mechanism for developing this hypercoagulation is pretty difficult, and it's hard to assess one indicator only, separately. What matters? We should look at the blood. We should look at the summary risk in every case. Well, common sense, you should quit smoking because smoking always means a much higher risk, although in criteria of acceptability it is not looked at. In terms of thrombophilia, we have heterozygous von Leiden mutation and prothrombin mutation. When Leiden mutation, when COCs are taken, enhances risk 35 times higher, and MHT makes it 15 times higher. The same goes for heterozygous prothrombin coding gene mutation. These patients are poor candidates for this. On average, what is the investigation evaluation we should do before we prescribe COCs or MHT to patients? These genes should not be tested for, but we should be fully guided by their history. If family history does have a deep vein thrombosis or PE, it does make sense to assess these polymorphism. In summary, the risks are rising. They're rising during first year, but then they go down in the whole population. Patients with a history of thrombosis, unfortunately, other drugs of hormonal therapy, we have no right because we have to seek other methods for menopausal hormonal therapy. 2020 was marked by the coronavirus pandemic. That's why this study came unnoticed, where they compared different types of hormonal therapy, including per-os, transdermal, and others, and the risk of thrombotic complications. This risk, or rather significant differences between these two types of administration of hormonal therapy, were not seen. Besides, the combination of estradiol dehydrogesterone may positively affect the coagulation system because they are activating fibrinolysis system, and there is no impact on the synthesis. It's important to take into effect progestogenic component. It's thought that the risks are maximum, and in MPA, nevertheless, well, DID and CE have optimal, MGHT, with DID has the best profile. And in this way, my summary is, risk goes up. We should bear that in mind, and we should have it in the armamentarium, have good understanding, and they should be properly prevented. Roughly speaking, any thrombosis against the backdrop of hormonal therapy doesn't mean it's a bad drug. It means that it was poorly prescribed. Thank you very much. Thank you for your attention. Tatiana Valerina, what can I say? Fantastic person. You know what I want to thank you for. Dear colleagues, those who are watching us today, we are on the last day for this Congress, and we give you key figures who would ask most relevant questions. We have many patients in high risk, many. When I see patients, one woman out of two in complications or risk of complication or thrombosis, or you name it. Not one single patient like this is not allowed into a department unless she is properly controlled by Tatiana Valerina Kirsanova, because we do not want to work in the high-risk zone. So, Tatiana Valerina Kirsanova is our Valerian. If she says the risk is too high, then we refer her to the general clinic and with the proper resuscitation and so on. Thank you. Thank you very much. Today I had an opportunity to thank you for your work. Thank you. Thank you. The presentation by Vera Nikolaevna Prilepskaya, Diagnosis and Treatment of Cervical Pathologies, Current Consensus. You do know that Vera Nikolaevna Prilepskaya she dedicated all her life. She has been working in our center, before that in Moniag. She is the president of the Association of Pathology of the Cervix in the contraception, and in general, she is a unique person who has placed it all working for the outpatient setting. Honor and glory to such patients. We were very fond of her. We very much need her. She wanted today to have presented by Maria Vladimirovna Yureva. Maria Vladimirovna Yureva holds a PhD degree in medicine. She works in the outpatient center of our clinic, in our center. Also works for the Department of OB&G and Reproductology, our first medical university of Moscow. When such a young person speaks, you want to pay more compliments. So, well, we wish you a good first performance. It's a that's a very high-rate event. Diagnosis and treatment of cervical pathologies, modern consensus. Please, keep on time. Thank you very much, Leila Vladimirovna, for this kind and warm welcome. Good day, distinguished colleagues. Today, it is my great honor to present this relevant topic, diagnosis and treatment of cervical pathology. Cervical cancer still is the leader ranking 3 in cancers of women's reproductive organs. And the International Agency for Study of Cancer, say IARC, half of all cases registered every year end in patients' death. So the relevance is there. That's why let's move over what we can say, what we can do. As annual center by Herzen says, there is a certain trend to decrease for cervical cancer, but we're probably speaking about poor underreporting and poor registration, and maybe not enough coverage with proper screening. That's why we just do not identify timely, rather than we couldn't speak that we have reached some good success or some progress. That is why. What remains pretty relevant is the problem of cervical cancer. We need to identify pre-cancer disease. We need to properly and timely diagnose and properly refer the patients for further care. So, IPVS say that by 2030, they predict growing mortality from cervical cancer by 27% in countries with low and medium income, where do not fully adopted the screening, which we'll be referring to. At that WHO strategy to eradicate cervical cancer needs to achieve 3 intermediate target indicators, such as the coverage with the vaccination against HPV, 99.0% of girls by 15, high-quality screening by 70% of women in age 35 and repeatedly at 45, and ensuring the treatment of 99.0% of women who were diagnosed with cervical disease, at that precancer lesions and invasive cancer. The end goal of this strategy to decrease indicators by 40% of the number of de novo disease of the cervix by 2050. Think of it, it will help prevent 5 million deaths that are related to cervical cancer. Everything that we do in our everyday practice are regulated by the legal framework. They're developed and approved by the Ministry of Healthcare, and every day we seek them in everything we do. Financing, amongst other things, for aid, helping patients with cancers, is done by the government budget in line with the federal projects fighting cancer diseases, which includes National Project Healthcare. It's important. That's why the state keeps reminding us about it. Cervical cancer is fully in line with the requirements to screening, highly effective screening and economically feasible. High prevalence of the disease and social relevance certainly come into play because it has to do with reproductive age. Well, it is visually accepted long pre-cancer time where we can do early diagnosis and highly effective therapy, even seeking to preserve fertility. Pretty specific and sensitive methods for tests. Well, methods are regulated by the current guidelines that were developed and approved by the Ministry of Healthcare in Russia. The most vulnerable zone, as we perfectly know, is the transition zone, junction zone of two epithelia. This is something that amplifies the most vulnerable cells. It's so important, so simple to get this material and send it to be studied cytologically so that cytologists should not skip or miss anything, because it predetermines the prognosis. It's important to avoid any mistakes on pre-analytical stage and properly, correctly gather material in line with the regulations for this. HPV, high mutagenic effect. Current studies say that carcinogenic effect and phylogenetic tree is being studied in greater detail. More and more strains of HPV may provoke cancer, cervical cancer, other than 16, 18 that we are fully aware of. So, HPV-associated oncological disease do not limit us to gynecology alone. It's not cervical cancer, vulva and vagina, anal cancer, and as of today, the center, amongst other things, we are one of the key institutions that seem to be lobbying this approach, prevention of anal cancer associated with HPV. So, HPV-associated disease are indeed a true global medical and social problem. And in whatever we do, we seek to prevent the cervical cancer and properly treat cervical intraepithelial neoplasias, SINs, which are pre-cancer, because cancer is not that specific. Sometimes it may not manifest it per se. In order to avoid progressive stages, we need to observe proper flow chart in line with client ways. You can also look them at the Ministry of Healthcare site and refer the patient for specialist oncological care into key institutions. Screening for the population at large. WHO recommend a cytological test that is recommended as the most effective to decrease mortality from cervical cancer. Liquid cytology has an advantage, such as a poor rate of inadequate smears. We can obtain material that later could be reviewed again and do further trials, including markers. A new progressive strategy is in trying the carriage of HPV. This is a more sensitive method rather than cytology. At that, it's mutually complementing as co-test and will not allow us to make fatal mistake. Colposcopy is a method of diagnosis that is done only by indication only. And thus, when we identify some changes, so the armamentarium of primary screening, it's HPV testing, and colposcopy is done only when indicated. And at that, we need to use the pre-established terminology that you see in this slide, and that is also widely available. So progressive possibilities seem to be evolving. Molecular genetic tests are done, including in our center too. And this slide shows you our first successes, including expression of microRNA genes in humans, proteoma of cervicovaginal fluid, and others. As to novel regulated documents, we should say that ACCP, seeking to maximize the prevention of the cervical cancer, minimize its harm from too much excessive tests, suggests such management strategy, and they publish their consensual guidance, which you all have access to, very much like to calculators, that will allow you properly stratify the risks of SIN3 and others in cervical changes, properly examine the patient, and refer her on QR code. This test system is available. So I'd like to say that surgical care is still the leader, most effective. Supplementarily, we could use immune modulating methods for therapy, but surgery still is relevant, is the bulk. And when we do only highly qualified specialists, this method would be highly effective. At that, the therapy should be done in medical care facilities that have the experience, especially when the thing is about women who are interested to reproduce further. And this is organ-sparing surgery such as conization, trachelectomy, amputation, and others. We should properly refer the patients. We often see neoplasms when a woman is pregnant. This experience has also been accumulated in our center, in Kolakov Center. We should also say that this is not a sentence. That is why we need to use interdisciplinary approach with a specialist team. And as of today, of course, the main method to prevent the disease is vaccination. Experience has been accumulated in administering these vaccines. We urge the patients to be vaccinated. Besides, good news is they're developing therapeutical vaccines. Should point out that the spread of cervical cancer has to do with the sexual behavior of women. So what is special about our work is we try to urge the woman to undergo screening, we uplift its sexual culture, we prevent the disease, and thus we get good results. Thank you for your attention. Wish this Congress every day success, and dear colleagues, in everything you do every day. Well, thank you. You know, I was pleasantly surprised. And some words from your presentation already referred to Vera Nikolaevna. And I think you will hear words of compliment from her too. Thank you very much. Carry on in this elegant, good presentations practical, something that is good for the center, and continue with your presentations further. Thank you. Apologies. Okay, I'll make an announcement right now. Now the floor goes to Professor Bayramova Guldana Raufovna. Cervical pathology, parallels with the past, and what can future offer us? She's in charge of the clinical work of our center in Kulakov Center. She's a fantastic doctor. She organizes well our work, and she has long been looking at cervical pathology together with Vera Nikolaevna Prilepskaya, and I'm very thankful to her for this elegant and stylish work and being loyal to the profession. Guldana Raufovna, please be succinct, be clear, and please present us just the gist of your presentation. Thank you. Thank you very much. Distinguished Leila Vladimirovna, dear colleagues, when we speak about a long-standing conversation, I would like to talk about parallels with the past and what can future offer us. I don't want to dwell upon the prevalence of the malignant cervical neoplasms. The only thing I can say is that today, as of today, still, if you look at the situation in many countries of the world, Russian Federation remains in a relatively, if we could put it this way, calm segment of the statistics in terms of mortality and look at the prevalence of malignancies that has risen by some 12%. At this time, we have documented the existence of over 450 HPV strains, and we realize that data keeps supporting this view that 80% of HPV infections indeed self-eliminate during 3 years, but about 3 to 5% of HPV infection may progress to reach the pre-cancer or cancer stage of the cervix within 7 years. So we can see somewhere also the pool of patients where the process is pretty rapid. What seems to be promising for further studies? This includes, on the one hand, HPV and high sensitivity to radiation therapy, which is very important. Secondly, whether one cell can has the presence of one strain, or there is a competition of different types of HPV for the cells. And thirdly, target impact on the enzyme activity of protein E1. I'd like to say in terms of radiation therapy, yes, indeed. It's one of the important stages for treating cervical cancer. It's interesting that it's been proven that cells of squamous cell carcinoma that are associated with HPV have shown higher sensitivity to radiation therapy. Suffice it to say that there's data that demonstrates to us that on average, recurrence-free survival in patients with cervical cancer associated with HPV, as you can see, is double compared to HPV-negative women. The other problem is lesions, and whether it causes lesions, one type, or is it caused by several types of HPV strains? Well, today
there was a microdissection with the grasp of different bioptates of cervix by using histologically verified diagnosis. It turned out that one type of HPV means one lesion that was confirmed. Another problem is the E1 protein, and I should say that E1 protein is the only oncoprotein with fermentation activity. It has the ability to bind with ITF, and thus we can use new methods for treating cervical lesions and HPV. So right now, inflammation is the marker, and the induction of the development of SIL in inflammation can maintain high titers of HPV, and by reversing this progress, we can just change the development of intraepithelial lesions development. So in order to avoid false positive results according to cytology, according to histology, of course, the timely administration of comprehensive drugs, combination drugs can reduce the negative consequences. In our practice, we encounter mixed infections and, of course, as for what the future holds us, combination drugs will provide good results. Today we have the range of combination drugs shown here. They are written into our guidelines. Let me just say a few words about the drug containing ternidazole, also nystatin, the antifungal drug, not just against the Candida albicans, but also Candida non-albicans, and they are very widespread. Also, neomycin sulfate has an impact on aerobic components, and microdosage of prednisolone, thus controlling the inflammation syndrome, anxiety, clinical manifestations, and has a very good anti-itch effect. Studies conducted here have shown that the administration of a combination drug, Dirgivan, allows us to control clinical manifestations on day 3 or on day 4 from the onset of treatment. The condition improved in 66% of women. The complete elimination was achieved in 95% of cases later. And of course, the dynamic follow-up showed the clinical efficacy in 92% of women. Another aspect I'd like to draw your attention to, and we conducted this study after the anti-inflammatory therapy conducted, the simulation of these changes when the ASCA cytological study was conducted, well, LCL, these are changes which is not the precancer, but we can see the cytogram change significantly in patients after the therapy was conducted, after tests were performed. They, well, basically had no atypical cells detected. Well, differential diagnosis between HCL and LCL, well, in case of inflammation, the true precancer was not confirmed in a certain percent of cases. DNA methylation is the most known modification, the most studied markers. Today we're talking about the most sensitive, such as FAN19A4, EMIR124-2, and you can see that in most cases, methylation tests were positive in women with cervical cancer. I should say that FAM19A4 is considered to be the most specific markers of cervical lesion, and right now not just FAM but also abnormal methylation of GIF1 gene correlated with the severity of disease, well, especially squamous cell lesions. And I should say that these are important genes, and in the future, they can become part of screening programs. Today, we're talking about different methods of screening: cytological screening, HPV testing, and of course, co-testing is extremely important today because the co-test gives us, in a high percentage of cases, high sensitivity and high specificity. In conclusion, I would like to say that as of today, especially during the last 10 years, the problem of pathology of cervix, although a lot has been done in this field, but the problem has become more relevant. We understand it perfectly well that the introduction of new ideas, early diagnosis on the basis of genetic screening, biomarkers of genes which first make contact with the etiological agent, early prophylaxis of disease, all these aspects are extremely important. And of course, new areas of research. There was a study published the role of HPV present in placebo cells. This is another interesting area that should be studied, and we must have a clear understanding regarding what is happening in pregnant women. I'd like to say that the problem hasn't been solved fully, but a lot of efforts have been made to study this problem, to make early screening, and of course, to say that early detection can prevent severe consequences and complications associated with this disease. Thank you very much. Once again, thank you, dear Professor Bayramova. You did a lot together with Professor Prilepskaya and our center in particular as part of the project of reproductive health. Today we're talking about screening for cervical cancer, which is of great importance, and liquid cytology plays an important role, HPV testing and ultrasound, and of course vaccination. Thank you very much. Now I give the floor to Professor Birgit Arabin. Adaptation 3D ultrasound postpartum to appropriate therapy models such as modern non-invasive postpartum rehabilitation. She is the representative of São Paulo University. Birgit is our friend and a very reliable friend. Dear Birgit, the floor is yours.
Who now listen. Well, my topic as a perinatologist is something which is more or less called urological problem, but we have to bridge both fields. As much as it was possible to bridge this, to reconstruct this bridge between different parts of Berlin 30 years ago, and now the trains are going, we have to bridge obstetrics and perinatal medicine with the pelvic floor disease, because many of its origin derives from that time. I have to disclose that I'm also the owner of a company producing urological pessaries, but I use the profit not for myself, but for new designs, for digital information, and for the Clara Angela Foundation, with different projects for pregnant mothers in the world. Well, up to now, the pelvic organ prolapse was defined only on clinical symptoms, as here in the NETA Atlas and the committees of different interest groups, as much as the types of incontinence. They were, well, there are four different types, but the most relevant is the stress incontinence due to increased abdominal pressure under stress. And you must also know what is urge incontinence due to involuntary contraction of the bladder muscle for later. Well, epidemiologically, it is well known that stress incontinence increases by the incidence of pregnancies, but mainly after traumatic vaginal deliveries such as forceps or vacuum. And by the age of 80, women in the United States have an 11% lifetime risk undergoing surgery, with a high risk of reoperation within a short time. So what is less known is that even during pregnancy, and it doesn't need delivery by itself, symptoms of all these pelvic floor diseases are like sexual dysfunction, stress incontinence, prolapse, and even anal incontinence increase. This is the third trimester here, and even 1 year postpartum, the incidences are very much the same like in the 3rd trimester. So we can also say that pregnancy is a window for future health in terms of the pelvic floor, and that when we have symptoms here, we know that this woman will have that postpartum, and we should better advise her directly postpartum. Well, just recently in this year, the International Continence Society and the International Urogynecological Association called IUGA, who now have their meeting soon in the Netherlands, had a joint report redefining all these pelvic floor diseases. And of course, you know, retention postpartum. You also know the oasis by endosonography, but now we have the ultrasound from the side and fistulas. But more importantly, they also referred to the pioneer of all this imaging of the pelvic floor, which is who is Hans-Peter Dietz from Australia. And he could show already 20 years ago here that 3D ultrasound here from the side transperineally performed is even more precise in visualizing the pelvic floor organs, here the urethra, than MRI, and that you have significant changes of the pelvic floor before birth and after birth. So, and it is also much more patient-friendly not to do this endosonography, but the or transvaginal, but to do it from outside. So he could also, in the following years, visualize and objectify all the clinically described types of pelvic floor disease like cystocele and rectocele and enterocele, and also could show that by incidence you discover, for instance, diverticula in the urethra. And he could also show that there are confounders in the levator co-activation that could only be objectified by this kind of ultrasound. Well, 10 years later, he also wrote a very good review in the American Journal of Obstetrics and Gynecology showing all these diseases. But the most important deviation, what he has described and what everybody now should keep in mind, is the so-called avulsion. And you see this here with the star. Avulsion means that the levator ani dissolves from the lateral pelvic wall, and then it cannot hold any longer the inner organs. And this is the most important determinator for later prolapse. Unfortunately, this is never or very rarely systematically investigated, although it happens in up to 25% of all women after vaginal delivery. And you can easily clinically investigate the pelvic floor after delivery when you know the pictures. But by this ultrasound, he evoked this awareness of the so-called avulsion. Well, women with avulsion, as I said, he did a systematically investigate a cohort, and he found that 23% of all women after vaginal delivery had this kind of avulsion. Of course, you can have various degrees, and you can have it only on one side, but even on both sides. And independent on the severity of this avulsion, you also have an enlargement of the hiatus, mainly during Valsalva, and both are the most important determinants for the severity of the disease. Well, by this kind of ultrasound, you can also see lesions much better than before by endosonography, which show some degree of oasis which you don't see routinely during birth. You see after birth the most severe degrees, but silent higher degrees you don't see, and they also predispose the woman for later anal insufficiency and incontinence, and if it's only by air. But this is, of course, better when you look, when you have some suspicion for this lesion, and then refer the woman to a perinatal a unit who are more experienced to repair it. Well, as I said, this is here an evulsion, and what Hans-Peter Dietz did is he made models so that you can train how it feels like in clinical life. And you even see, when you know this lesion, you can even see clinically that this woman has some kind of avulsion, lateral disease, and you can diagnose in all of them the ballooning when they push. What you also can see when you know this, that after certain maneuvers, not only instrumental delivery, as here in this meta-analysis, and midline episiotomy, or persistent occiput posterior position, where you should better perform a cesarean than do a forceps or a vacuum, but also fundal pressure in the second stage of labor, like Christella maneuver, is associated with an increase of risk of avulsion. But this has not yet really been reflected by many obstetricians. Teaching is very important. As I said, I attended quite some courses from ESOC in London. We have this in our this equipment in our teaching center, and we performed a meeting this year in March with Hans-Peter Dietz, where we invited patients with the most severe diseases, and he trained young obstetricians how to scan, and we also tried to find out pessaries which help the patients with a certain disease to have less pain, less symptoms. Well, it has also been shown that these biometric data are different in twin as compared to singleton pregnancies. Why is that? Because the weight of the uterus during pregnancy is already higher, and therefore also the stress incontinence can vary. It is not happening during birth because most of the time the children are smaller or born by cesarean. This is due to the heavy weight during pregnancy. And recent papers have also shown longitudinally how these findings change either in at rest or when you do pushing or Valsalva. And here you see the area of the levator hiatus. It is getting smaller in the first trimester, but going up in the second and third trimester, and then restoring. But what is not restoring is the bladder neck position, like here. That is here the line, and this line, or this line, and the motility of the bladder neck, which is higher after delivery, as shown in this picture. This can change significantly after all vaginal deliveries. So also stress incontinence postpartum is a very important sign when you don't treat it, because as shown in this paper from Scandinavia, from Menassian, it shows when you don't treat stress incontinence, then at higher age you get a combined stress and urge incontinence, which is much more difficult to treat. And remember that 60% of all women with vaginal birth have some kind of lesions. So we should treat stress incontinence as early as possible. as I showed, this is possible also to see by tomographic ultrasound imaging or TUI, the kind of lesion. And what do the guidelines say of different countries? Well, they recommend for POP, so genital prolapse and urinary incontinence, to treat them, sorry to say, with pessaries as the first choice. In France, it is even an obligation. You are not allowed to operate before you have not used a pessary. And there are very small side effects of these treatments. The most recent randomized controlled trial from this year shows that physiotherapy, which was indicated in all women after some lesions or after vaginal delivery, does not help at all, because in this paper they randomized according to this ultrasound lesions, and they compared women with avulsion with physiotherapy and no physiotherapy. So logically, in patients with this kind of avulsion, and these are many because we have not looked at it before, physiotherapy cannot help because you cannot any longer contract this muscle. So whether you train or not, it's rubbish. We make a fool out of these women, and we should better look for something else. Another randomized trial from this year showed the same. They randomized for physiotherapy, routine midwife courses, and our Q pessary. And you see the satisfaction rates was much better with a pessary, because then you can somehow elevate the prolapse, and whereas here with physiotherapy, this only works in incontinent women when there is no avulsion. We also have specialists who use transperineal ultrasound to control pessary treatment, and then you can also do pushing, but most of our gynecologists have really no idea of pessary treatment, although it's quite easy, and patients are most of the time better in indicating and feeling. So we looked at the questions we got to our company, and looked what patients were not informed by their obstetricians or gynecologists. So there were a lot of questions, and based on that, we made a checklist for them to improve their counseling. It is also important to know this 3D ultrasound to predict the success of treatment. As you see, these patients were all treated with anterior colpography. You see no difference whether you put a mesh or no mesh in the recurrence rate after the operation. But when you had an avulsion, a mesh improved somehow the time delay, or had less time, improved the prolongation after the operation. So looking for avulsion also helps to predict even the success of an operation. Well, I love very much Renee Tucker. She's the president of IUGA, and she now is organizing with her team the TOPSY randomized control trial for better life quality. And she randomizes whether self-management of women is not better than clinical-based care by specialists, so-called specialists. Well, this is my last slide and my take-home message. Why imaging in postpartum women with threatening stress incontinence and genital prolapse? Well, to complement clinical examinations, to understand the etiology of a defect, to indicate patient selection and therapy, also of self-management, to enable meaningful audits to demonstrate findings which are not even suspected, like the urethral diverticulum, to tackle underlying problems with appropriate therapies. And I also patented now a new device which I intended to treat this kind of avulsion, but it's not yet on the market and not yet certified, so I'm not allowed to sell or to show, but it will come, and to develop new devices, as I said. Digital information will have increasing value to find the new target group and the right target groups, and to involve the patients in the final goals, to help them to have not only survive a delivery, but also have a good life quality till the end of their life. Thank you.
Dear Professor Arabin, I'd like to say that you always be an innovator. I have known you for 20, maybe 25 years, and each time in obstetrics and gynecology, I see something new in your practice, including dancing and music during pregnancy. No one did it before you, although in parallel, we've been dealing with this issue, but you were the innovator in this field, and I had an article published, Tango in Pregnancy and Tango by Recipe. That was wonderful. As for this kind of examination, postpartum examination, that's quite right. Women should be examined, but sometimes it can be late. Well, what is important is to deal with risk factors before the patient is sent to the delivery room. Otherwise, the patient will be afraid of deliveries. The Filipino women sometimes have 8 to 10 children, but they have the culture of perineum, so to say, the philosophy of rehabilitation. Well, preparation of the perineum is so important, so high. Sometimes, no matter whether you have ultrasound or not, the quality of their tissue is excellent. Well, and also, it was not the subject of your presentation, but the dysplasia of the connective tissue. We know that over the last 10 years, we have conducted studies of the consistency of the connective tissue. We identified lots of risk factors. That is why bringing to bear the possible dysplasia of the connective tissue, there is also a need before pregnancy and after pregnancy to have a thorough ultrasound examination, and not just ultrasound examination, but the functional examination. Then there will be no stress incontinence and prolapse. And once again, thank you for your devices that you have developed, and thank you for everything you've done. And we will continue together achieving the best results. Thank you, Birgit, for being with us. Dear colleagues, now I would like to invite in Polichina, a professor, head of the Department of Aesthetic Gynecology and Rehabilitation of the Kolokov Center, efficacy and safety effects of modern hormonal contraception based on international experience. And I should say that speaking about the pelvic floor inconsistency, we've been working in close contact with Professor Apolichina. She is a person who keeps thoroughly monitoring the pelvic floor, the uterine mucus using new technologies such as laser and many other things. Right now, efficacy and safety effects of modern hormonal contraception based on international experience. Inna, I know that you are a wonderful presenter, but it's already too late just to present the basic information. Please.
A very good day, distinguished chair. Good day, dear colleagues. Today, indeed, I'll be speaking about evidence-based facts about efficacy and safety, a new drug in hormonal contraception that we have today. Surely, in order to create a new contraceptive, first of all, we realize that this efficacy and safety come into play. First of all, when we speak about safety, we speak about factors or side effects that have to do with estrogens and with gestogens. With estrogens, higher concentration and activity of coagulation factors. This means higher blood pressure, edema, tension and tenderness of the breast, nausea, and aesthetic problems such as plasma, such as a focal hyperpigmentation plasma that we also see in the face. For sure, gestogens carry risk too. High blood pressure, lower tolerance to glucose, depression, hirsutism, and more growth of hair in the facial hair. So the world community has been looking for better forms, better formulations that could be used in women without side effects. And where back in 1965, estetrol was discovered. This is a unique estrogen, another hydroxyl group. He first used it as a marker of a well-being of the fetus because it's synthesized in the fetal liver. And only after they studied main psychological effect, this is the effect, physiological effect, such as use it in hormonal contraception and in MHT too. And in 2021, the EU and the FDA prove it as a contraceptive. Of course, it matters its characterization because synthesized in the fetal liver during pregnancy. And today I'll be discussing the evidence-based data. First, I present this article in Contraception, published back in December 2021. You see 3 publications, a third stage trial that was involved America, Canada, Europe, including Russia. And our Kulikov Center was among those who took active part. So it's not international experience only, it's also our own experience in this country. So, contraceptive robustness, 96.6% contraceptive protection by the use of this drug. Vermus index 23%, 0.23%. This gives you Russian sites that took part in this international trial. Again, phase 3, 15 milligrams of estetrol and 3 milligrams drospirenone. It is for good reason that I give you this data. This is something that our patients' diaries that described their perception, what they felt like, and it was very well planned in terms of management, a good international clinical trial, which was, of course, placebo-controlled. I'd like to say that it was finalized by 343 patients who completed it. We followed up on these women for a year. It means that it was 13 28-day cycles. And I'd like to say that the women patients were very happy with the therapy and with contraception, and after the use was over, it was not yet approved in Russia. Only back in 2022 it was fully approved in Russia and got MA, and we began to use it in broad practice. Patients were somewhat upset what happened next. They very much liked this contraceptive. What I want to say as to efficacy of contraception, 98.6%. Only 5 cases of pregnancy in 1,500 women, 2 because patients' mistakes, they misused the product, and 3 cases of method failure. So which mechanisms ensure there's high potential in this contraceptive? First, suppression of follicular growth, control of the cycle, and predictable menstrual-like reaction. It's highly important. I'd like to say that presence of menstrual-like reaction, it's important positive psychological aspect because women understand they are not pregnant and women realize that they're young, they're still menstruating. So 97% of women had an expected menstrual-like reaction. And of course, number of days. No, it's not of planned bleeding. Very minimal. The study had to compare it to other contraceptives. Why estetrol-containing contraceptives today effectively control menstrual cycle? Why? 70% bioavailability, half time is, or full time is 26-28, and most importantly, it doesn't bind to globulin binding sexual hormones. very high level of satisfaction. Women wanted to continue using this drug. Only 3% of women said they wouldn't use this contraceptive because of intermenstrual bleeding. So as of today, there is good data, both evidence-based and our own, in Kulakov Center. Пожалуйста, берите помехи из эфира. And in the use of this contraceptive, yes, because minimal influence on the liver in metabolism, in order to evaluate hemostasis, means very high level of hematological safety. Blood pressure does not go up, and it even prevents atherosclerosis. As of today, evidence data is available. Highly unlikely that it would influence the metabolism of other drugs, so it can go hand in hand with other drugs, other medications. Estetrol-containing contraceptives are good for lipid metabolism compared to other COCs, and for 6 cycles of follow-up for these patients, we haven't seen significant change in triglycerides. Another presentation of no impact on the metabolism of lipids that was supported in phase 3 trial, minimum changes in hemostasis. This is very important because in this way we decrease the risk of all sorts of thromboembolisms, venous thromboembolism, including low limb thromboembolism, deep vein thrombosis, DVT. So this study marked there's no impact on cardiac rhythm, no changes in ESC, BMI didn't go up, and most importantly, estetrol-containing contraceptive is safe for the breasts because E4 is tissue-selective estrogen. In the breast, we have selective and partially shows anti-estrogen properties. Doesn't have cancerogen metabolites, and even is positioned today as a medication to treat breast cancer. But for this, there is another trial ongoing trial, and we need to evaluate the data and its findings. The conclusions. First, selective estrogen. It works as an agonist at the nuclear receptors of estrogen, but as an antagonist, it means it blocks membrane estrogen receptors at the level of membrane. So in conclusion, may I share with you a case study. As of today, we can see, and probably we are witnessing, the apex of contraception because it's an absolutely safe and effective drug. This patient, who literally visited us at center in Kulakov, a woman has a bad family history. As she was 18, she was operated because of ovarian resection and C-section, twins, labioplasty. Cervix was L-SIL, further LEAP biopsy, but as of 2019 she has lymphleukemia, first stage A, but in 2022 she became stage B, B-cell. So as of today she has changes both in terms of blood and poor platelets, hemoglobin is down, ferritin is down. So as of today, hematologists plan to refer her for bone marrow transplant in autumn 2023. After she was consulted by hematologists, she was referred to GES Plus, but when she was examined by us, we gave her estetrol-containing drug. Why? E4-containing drug. Exactly because I was telling you about in my presentation. Very much reliable and safe for this patient. It is highly effective COC. Secondly, it well controls the menstrual cycle. Fast recovery of fertility after cessation. Has fewer estrogen-dependent side effects compared to other COCs. Minimal impact on hemostasis, where that for this patient matters immensely. No negative impairment of lipid exchange, cardiovascular system, no impact on body mass, because women often refuse contraceptives because of gaining weight. And high level of satisfaction in patients who were taking it during the trial, and now initial practical experience when it was adopted. The drug is no estetrol-containing contraceptive, androspirinone. Thank you very much for your attention. And today I introduced only on the tops of those evidence-based data about efficacy and safety of this drug. But today, in our practical health here, we'll be gaining experience and we'll be sharing it with you at further meetings. Dear Inna Anatolievna, today you were brilliant as always. Thank you very much. Every time I'm so amazed by your energy and by so much as how much you would want to achieve. And I'm so happy that our Center of Obstetrics and Gynecology gives us opportunity to develop a lot of progression. Thank you very much. Thank you. Thank you so much, Leila Vladimirovna. Dear colleagues, we give the floor to Dr. Popov, Alexander Anatolievich Popov, professor who's in charge of the Department of Operative Gynecology and Oncogynecology and a hospital in Moscow, Research Center Moscow Region of Obstetrics and Gynecology. Then his presentation is titled 10 Years of Robotic Surgery at Moniag. Moniag is the abbreviation for this institution. He's a brilliant surgeon, and actually all his presentations that he's doing are always indeed our top cutting-edge class. And I'm personally thankful to Alexander Anatolievich, because back in 2022, when I decided I would go for robotic surgery and I would get a certificate, I wanted to see how they are doing it at Moniag, and then in hospital number 50, then in all the hospitals across the country. And once again, I could appreciate his high surgeon technique. Alexander Anatolievich, please, just the highlights. 10 years of robotic surgery at Moniag, at your institution, please. The floor goes to you, dear colleague. Leila Vladimirovna, yes, I can hear you well. I am now having my full display. Do you see my screen? Yes, make it full screen, please. Yes, it works. Thank you. Do you see it? Yes. Please be succinct. We have 2 further lectures. Yes, I'll try to be succinct and brief. First of all, I'd like to thank you for this opportunity to speak at your Congress. It became a tradition, and I'm very keen, and I love this event too. We summed up 10 years of experience of using robotic surgery at Moniag. I'd like to say that robotic surgery is going from by leaps and starts in over 1.5 million robotic surgeries were performed, 10 million, sorry, and about 7,000 consoles have been set up in the world. In Russia, sorry, my slides don't move. Sorry, I'll just have a technical glitch.
В России мы, конечно, не имеем такого.
We don't have that much experience, that many console operations, but you see every year we're adding some 44 operations, and gynecologists also want to be a pace of the time. This gives you the data up to 2022. We started back in 2012. We trained 3 groups of surgeons and 2 groups of nurses at 2 centers that are training robotic surgeons across the world in France and in Belgium, Orsi. And we were lucky with 2 proctors who visited our institution and helped us start in 2 difficult operations in cervical cancer. The Dr. Kimik operated in 2 operations in endometrial cancer. And by late March 2021, we did 1,000 robotic operations, which we sort of celebrated by our team. This gives you a number of operations in different disease names, and we'd like to highlight 3 groups on patients, model of patients, which, as we see, are good for robotic surgery. Patients with infiltrative endometriosis, you know, you are the pioneers here. This is a group with infiltrative endometriosis because with damage to endocervical, with a septum, and urogenital complications. Just for your example, I'd like to share with you the experience of treating 204 patients where we did bowel resection of the rectosigmoid colon. They were robot-assisted in 76, and 20 had a novel technology, nose that uses natural orifices, removing the specimen through anus. And as this video shows you, and then we do a real anastomosis end-to-end using intra-abdominal circular suture. We prepare proximally and distally the colon to do a circular resection, and then we close these ligations on the circular stapler, and thus we make a real anastomosis end-to-end. What are the advantages? It helps avoid the use of linear and circular stapler at the same time. And this zone where you cross of linear and circular zone, it's always hazardous in terms of anastomotic leakage. This is where we do a true end-to-end anastomosis. There's no conflict between two lines of our stapler. Of course, cosmesis plays a good role. Conventional robotic surgery, colorectal resection to the left, to the right, a woman who underwent it with nose. Post-op complications. Well, good advantage after robotic nose colorectal resections. We haven't seen anastomotic leakage at all. No hematomas of the anterior wall. We didn't see infections. Functional, impairment could be seen, and it was identical in group that did it both laparoscopically and robotically. No fistulas, stenosis, and intestinal bleeding only in laparoscopic group. The next groups of patients with a prolapse of genital organs and apical polyps, especially in post-hysterectomy. For us, this is a very good model for SCP, and this gives you intra-op characteristics of the patients who received robotic sacrovaginopexy. They could well compare. May I show you a somewhat high level of pain in post-op setting, which could be explained by the diameter of trocars. And we increased the number of trocars in the robotic group. Functional outcomes were better in the robotic group. You see that such defects as dyspareunia, constipation, urine incontinence de novo were better in the group that were in robotic-assisted surgery, and very good positive defects in patients where they had vaginal access. This has to do with the post-op complications and morbidity. You see that in the robotic group, they were significantly lower number compared to the laparoscopic, conventional laparoscopy. Well, you can't use smaller operation, but in patients with complicated prolapse, like here, where the mesh was pre-established, but then they had apical prolapse, robotic surgery helps us reoperate these patients better. And, for example, treating recurrence after sacrocolpopexy. In this case, we identified where the prosthesis was fixed at. It may be well seen on the video. Probably it was torn away from the cervix, and then we did it conventionally. We opened the artery, we attached it to the anterior, posterior after we did hysterectomy, and we used this place of fixation of the leading mesh to the promontorium, having attached it to the place instead of the older prosthesis, and we did something that would be typical for sacrocolpopexy. Or, for example, when we would treat complications that rose after the operation of total hysterectomy and sacrovaginopexy, there is erosion of the cupula of the vagina, and if it is placed laparoscopically or robotically, we suggest you should continue the same sectional approach that you used in the other. Robot gives you high precision, and we can remove. And third category, patients with morbid obesity. You know how frequently they may give rise to gynecological disease, for example, endometrial cancer, that is immediately related to excess body mass. Champion was a patient 221. Her BMI is over 70. This shows you the outcomes in terms of length of and blood lost. It's basically not different laparoscopically or to robotic access. What's important, when we looked at cardiovascular system of a surgeon who operates laparoscopically and robotically a patient with morbid obesity, all indicators, including parasympathetic nervous system, were much better in the surgeon who operated robotically, unlike his colleague. Per 1,300 operations, these are the morbidity. One wound to the iliac after in adhesions, it was removed post-op. Impingement in a woman with morbid obesity through the port, 80mm strong port. Physiological plexit of the humeral nerve hypertension when she was moved into a Trendelenburg position. One patient had very severe complication when on day 5 after uterine extirpation because of the myoma, she developed gangrene of the anterior abdominal wall, and we tried together with the surgeons of the purulent did do nephrectomy, but unfortunately on day 8 the patient died because of acute cardiac failure in presence of this, huge damaged area. And the new group is reconstructive gynecological operations where we do robotic surgery. For example, in this case where there was a difficult case of uterine vesicular fistula, after it was disconnected, we had to do the transplantation of the uterus, repositioning of the uterus. Those who did it laparoscopically or laparotomy know how difficult it is. But robotically, it's done so much simpler, faster, and in greater precision. At the end, may I highlight these 3 groups of patients that, as I said, ideally fit the model of patient who do robotic surgery, because economically it's not smart to do regular, plain, conventional operations, use a robot there. But patients with high surgical risk, where they need hysterectomy, patients in endometriosis, as well as surgery for genital prolapse, we feel are good candidates for robotic surgery. Well, thank you very much for your attention. And once again, my words of thanks when you invite me to attend this Congress. It's a great pleasure. Well, dear Alex Anatolievich, I'd like to say to everyone that you are a surgeon of top class, and that originally, someday, you used to work at our center, and both you and your very first qualification is your general surgeon. This certainly does come into play here. We traveled countries. I introduced you to Harry Ritchie, and I'm so happy that this happened, because when people have potential, this potential has to further serve your specialty and even in this country as a whole, and gives you the name and your renommee. Thank you very much. Thank you. It is my pleasure to give the floor of our Center of Obstetrics Aubergine to the immediate person who is in charge, Yulia Ponomaryova. My members of the staff also work in the surgery. They are Professors Arakelian and Martinov. Robot-assisted surgery for correction of uterine and vaginal malformations. Experience of our center. Robot-assisted surgery in operative gynecology. Yulia Ponomaryova will be the key speaker. Dear colleagues, in the last 2 decades, Da Vinci became one of the large-scale novel developments in surgery. Global statistics show every day, every year, we see annual growth of surgical interventions that are done using Da Vinci complex. Surely, and a lot of publications to discussing all sorts of aspects. The use of robotic surgery does certainly have a certain advantages and pros and target points compared to traditional approaches. HD optics, precision tools and ergonomic technique have to address most challenging situations. Significant size of the tumor, lots of and difficult anatomic site of the tumor, high BMI, recovering fertility, cosmesis, addressing adhesions, and of course therapy for DIE. When you treat DIE, deep infiltrating endometriosis, using Da Vinci system, it goes hand in hand with addressing several objectives, such as, first of all, the best system of imaging which exceeds other possibilities almost by a factor of 3. High precision of identification as part of quality exposure of infiltrate, and we do maximum to excise the pathology and leave in place her healthy tissue, especially close to the plexi, the urinary tracts, and colon. Of course, we identify the margins of the infiltrate, which may be hidden when we use traditional imaging, using filters, ICG, and others that, in point of fact, are not there in other options, traditional access, and high precision dissection. So much for your attention. I'd like to show you, if I may. Can I show you a case study? Show you a DEIE, as usual, goes hand in hand with vast adhesions in the abdominal cavity. As we enter the cavity, only fundus was available. The uterus is fixed in the loops of the small intestine and large intestine of the here is the bladder. Originally, we thought that we expose the body of the uterus in order to get some understanding about the anatomy of this individual patient. We attempted to expose the right and left adnexa. Finally, we could see at last the left ovary with endometrioid lesions, left uterine fallopian tube. We expose lay open perirectal space. We can see the ureters, right and left. We expose infiltrate, which, in point of fact, takes the left-right perirectal space. In retrocervical zone, we expose the rectum. We do work on the infiltrate. We expose the infiltrate that affects serosa and muscular uterus. And in general, the patient further on was better prepared to continue her reproductive plans. She's young. She traveled from across Russia. Several times they tried to operate on her, and unfortunately it didn't work. What are the advantages of the Da Vinci system when we do myomectomy? Well, both in literature and among our colleagues, up until time, they're still actively debating whether it makes sense to use Da Vinci, such an expensive robotic system, to treat myomas. But our experience, which includes over 300 cases when we treated the nodes, helps us in our position when we say that, and supports our view that the use of robotic-assisted surgery in treating myoma certainly does have some pros. Perfect guidance about the anatomical landmarks. You identify the planes, the structure of the tissues, and in hard-to-access spaces, we work perfectly fine. As in this case, you see, we removed 26 foci that were all across the uterus, including the cervical and other sites, and the vascular plexus. A big range of robotic handles. You can work using all the 4 instruments, such as scissors, coagulation, bullet forceps, aspiration, as well as, when needed, we could, if needed, the assistant could come into play using bullet forceps, which creates further countertraction when you manipulate the nodules. Of course, it creates optimal conditions to remove the nodes, as well as later on, in order to do anatomically correctly, plan and do work on the wound, do hysterography under different angles and in anatomically challenging zones.
Вы видите, насколько это эффективно использование шовного.
You see how well and how effectively we use this suture. In this case, we used V-lock. There is a thread that goes PDS, suturing material.
Это было связано только исключительно с тем, чтобы наиболее эффективно.
It had to do with this, that we need to most effectively address the issue of restoring the integrity of the uterus. For that matter, the operation was performed 11 months ago.
Время пациентка беременна, срок беременности.
And the woman was 6 to 7 weeks pregnant. So far, so good. The uterus looks, when we do ultrasound imaging, it looks very optimistic in the follow-up. Yet another, allow me please to stop at yet another problem, how to remove the genital prolapse. The use of robotic sacrocolpopexy up until now, SCP, is still the gold standard among all sorts of methods that we use to correct this prolapse. As the global statistics show, overall about 5% of SCPs are performed laparoscopically, which is related to vast dissection of the tissues and a lot of sutures. In this case, 3D image helps us ensure that we have we can see good and key anatomical structures very well. They are iliac vessels, pre-sacral space blood vessels, besides nerves, hypogastric nerve, and of course ureters and the bladder and the rectum are seen perfectly well. Precision dissection helps minimize the trauma, cut down on the time which we need to expose all the spaces, and we work with the mesh. It helps optimally position the mesh and besides clearly fix it when we put few sutures in. In this case, we remove the genital prolapse in a young patient. She's 35 years old. She has a history of 4 deliveries through natural physiological deliveries, but she has apical prolapse, which we correct using promontory fixation. The operation lasted 50 minutes, fully restored the anatomy of the pelvis, and it was pretty effective. And we use this anterior.
And another very important thing. This is unfortunately adhesion process. In fact, almost every pathology, every surgeon clearly understands how difficult it could be and how to perform surgeries in this category of patients. And in this case, we wanted to show the fixation in the patient with BMI 47, with already 4 previous interventions in the abdominal cavity with prolapse, relapse. And we fixed uterus stump as there was enterocelli in the medical history. So the duration of surgery was 1 hour 40 minutes, blood loss 50 milliliters, and the hospitalization duration was 3 days. With that, thank you very much for your attention.
Доктор Пономарёва Юлия Николаевна, она доктор медицинских наук.
Thank you very much. Well, Professor Pономарёва, she's very experienced surgeon, and in our center, robotic surgery is already done for 2 years. And yes, we do have dedicated surgery, and we have 5 people in the team who master the robotic technique. And we will continue, proceed, and we will implement more and more robotic surgeries. And now it's my greatest pleasure to give the floor to the team of our specialists, our surgeons from Almazov Center from St. Petersburg. And this is Dr. Komlichenko, who would be the leading speaker, who is the Doctor of Medical Science professor. He is the director of Almazov Center Clinic. And Edward, I saw his surgeries, and I visited myself St. Petersburg many times when we got the robot. And I believe that this is really great luck that we managed to start the robotic surgery in St. Petersburg and in parallel in clinic of Professor Pushkar. So together with Eduard Komlichenko, I witnessed brilliant team, absolutely brilliant team of robotic surgeons, which is Professor Musayan, who is fantastic urologist, and I believe that there are no limits for this clinic. So they accumulate a huge experience and true mastery. So I'm happy to introduce the presentation of robot-assisted surgery in the correction of the uterine and vaginal malformations in children and adolescents. And I think it's a big achievement for us that I was somehow involved into this surgery. And also I'm very grateful to Professor Kochriidze for truly massive initiative and desire to work in this area. Microphone is yours. You're welcome. Good afternoon, dear Leila Vladimirovna, dear colleagues. First of all, I would like to say a few words on how this topic appeared, how it all started, and actually to speak about the main contents of what we are doing now. In order to move on, you should put achievements, citing goals. It's very important, but I'm deeply convinced that in our profession, in obstetricians and gynecologists, we have very important mission to preserve females' health, because all the girls are born as future mothers. And in this very close, I would say, very cozy cooperation with you, Leila Vladimirovna, within many years already. And if we speak about the robots, we have been cooperating already for time, and it was a chance for us to use Da Vinci already for 12 years, and definitely when we got this opportunity, we immediately started thinking, and Professor Popov was absolutely right saying that, how to use this technology correctly in order to stick to professional options which are available here, so to work professionally, and also not to forget about the economical and technological burden which is associated to this technology. Quite a lot was said about it in all previous conferences, and today colleagues showed brilliant opportunities of the robotic system, how we can use it effectively. So I would like to say that our topic is mainly message, most important message. It's a philosophy of organ-sparing improvement, the quality of life of a female, and you know, quality of life is established from the pediatric and adolescent age, and it is specifically at this age we frequently see and face different congenital uterine and vaginal malformations. Well, they're not very frequent, and pathogenetically the consequences of Muller duct canalization normally, and the rate here in the population of about 1 to 7 by 100,000 newborn girls. 1 to 100,000 or 7 to 100,000, but mainly they are identified in the pediatric age, and these malformations, they have quite specific manifestation, clinical manifestations, and normally patients are quite challenging for the communication and for the diagnosis, because all that happens at the very early pediatric age, where psychological component or disease perception and the treatment perception is very difficult, very sensitive. So it's difficult to communicate with doctors, not very well awareness existing here, even in the medical community, about the uterine and vaginal congenital malformations. So that's why sometimes diagnosis could be very challenging due to the fact that malformations, they're not frequent. and the diagnosis itself is challenging due to the communication problems. So the background of genital malformations is also challenging. And when we perform reconstructions and plastic surgery, in 80% of the cases, we see either endometriosis, external genital one, or adhesions. Most frequently, it's a combination. It's a combination of both. So these surgeries, they also characterized by frequent rate of early and late complications. According to literature data, the complication rate would be about 50 to 60%. And in almost the same percentage, it requires secondary surgeries later on. There is another nuance because there is a rarity, scarcity of this malformation. So currently, we don't have common unified guidelines for the surgical treatment of genital malformations, and we don't have enough randomized trials to study the specificity of surgery and the outcomes, speaking about the Mullerian malformations. So why robot? Why robot? Me and Leila Vladimirovna, we got to lucky opportunity to use robot, and I knew that she is truly international expert in the diagnosis and treatment of genital defects in males, in girls and females. We started immediately talking about it, and based on the specificity of robotic system, which is known now. Well, first of all, this is great visualization. This is also ambidexterity, great range of motion, the amplitude of motion, because it's all possible degree of freedom, and also the angle of more than 90 degrees, and you can work in so-called smaller spaces, which are critical to us. So it gives lots of preferences to use robot for this specific, very precise surgeries of malformations. In our case, for 6 years, we managed to diagnose and to do surgical treatment in 10 patients. So 3 cases with Robert uterus, 4 cases with Acum syndrome, 2 more with Ahvira syndrome, and 2 more patients with uterus agenesis. So they were already adolescents, younger than 17. Well, 10 cases doesn't look very impressive, but if you compare it with the data that is presented in the modern literature, then even in the largest European or global clinics, the number of cases is singular cases, very limited. Now, a few slides very briefly from our own follow-ups. So that's patient age 17, and we performed colpopaesis with robotic assistance. But this is, well, quite trivial and probably a routine surgery in expert clinics. But robotic assistance after the uterus stage, when you create a new vagina, you can create the dome of the vagina that initially it has good stability. It has got good shape, so this is dome-like shape. After the surgery, there is less pain syndrome in these patients and a shorter period of rehabilitation. And finally, the quality of sexual life in these young females is getting better. And then it is less psychological stress due to the better availability of sexual life in a well-created new vagina. When we do the surgeries with the rudimentary uteral horn, it's important to follow the rules presented here, and altogether we managed to sum them up in our dialogues, in our practical activities. Here they are, so clear recommendations. Normally horn sometimes is bigger than the normal one, and it's difficult to identify the plane between the uterus and the horn. That creates challenges for the surgery and requires very clear intra-op navigation, and for that we use intra-op ultrasound that helps to identify the borderlines very clearly when we move along, and then it creates maximum quality for the newly created uterus. Please appreciate here a girl age 16. Here on the left you see ultrasound and MRI. So located next to the horn, and then in the center we see the visualization of the uterus, and it's very difficult. It's very difficult to identify the borderline you should move along with in order to make the incision of the residual horn and to keep as much as possible healthy tissues, and then create full-fledged organ without residual horn. So here on the right, big fragments we're removing. So this is a bloodless surgery. And at the bottom here, we see a clear uterus body and also the right and healthy right ovary. Patients with Acum syndrome, yes, we had 2 cases like this. Well, this is pretty rare follow-up. But all in all, in the description of the literature, we found 30 cases. In girls, it was 11, but our experience, 2 patients with Acum syndrome. Well, here you see some specificity of development, so that's early symptomatic, then intravitreal localization next to the round ligament, and cyst could be 1 centimeter or bigger. And this is definitely only surgical treatment, and you see how after the proper navigation and identification of cavity, we can make the incision of this formation, then suturing is done, and then the surgery is performed effectively. Next patient, aged 14, so that's very interesting case with pelvis dystopia and dysgenetic left kidney, then doubling of the uterus, functioning right uterus, and agenesia of the vagina. So here is a strategic plan for such surgery shown here. So on the left, you see uterus as a bulge, uterus on the right, it's further in the right, but what we see here, right under the arrow, that's dilated cervix. And this is the fragment of the surgery. I want to show you the final step of the surgery when we created neovagina on vagina elevator. And here I would like to emphasize positive things like those that push us together in cooperation with our colleagues in this surgery. Urologists showed us their own method of suturing to create ostia between uterus and vagina. Normally, these sutures are done by urologists when they perform radical prostatectomies, and they are very reliable, and this is very good. And then it creates new ostia between uterus and vagina, and at the same time, it allows to do the stenosis without stenosis. So this is quite interesting suturing. It's performed like this, looping, and it allows to create this surgical space. And we do the surgery in November last year, and today she has spontaneous menstruation, so menses are going okay, and ostia is functioning. Ostia between the uterus and vagina. So we put protector at the end, so then healing is done over there, and then finally we create ostia between uterus and vagina. So we can conclude that robotic surgery in the treatment of genital malformations extends the existing opportunities when we perform surgeries in such kind of patients, and completely meets the requirements of the functional surgery. As Professor Popov said before, definitely the result of robotic surgeries are much better than the same but done laparoscopically. The complication rate is a few-fold lower, and we can confirm the same. We can confirm the same when we do the surgeries for females for 12 years in our clinic. If I tell you that we had no complication, zero complication, you will probably not believe. But that's true, zero complication rate. We never saw any significant intra-op complications. Speaking about post-op complications, yes, we had a number of standard cases, mainly referring to pain syndrome or, let's say, appearance of hematoma next to trocar entry. Definitely, reconstruction should be carried in every patient as already designed as an individual strategy in each specific case. And in this case, communication and our cooperation, our discussions between Moscow and St. Petersburg School and our colleagues, all that allows us to design most optimal strategy and tactics of management and move on, effectively move on. And definitely, I'm deeply convinced that such challenging surgeries, I would say, well, these are rare surgeries and they should be carried out in clinics of reference level where these patients could be effectively accumulated, where we see them more frequently, there is bigger patient flow, and the healthcare professionals have experience communicating to them with their parents, and definitely they are mastering these type of surgeries. With that, thank you very much for your attention. Thank you very much, dear Professor Komlichenko. And it was really pleased to listen to you. Yes, I saw your surgeries and I participated together with you in many of such surgeries. And also, I would like to express gratitude to your director because he's a fantastic person. And it is very important that we are united not only by many years of friendship, but also by such fantastic alliance between surgeons of different specialties, cardiologists, gynecologists, urologists, proctologists, and your center is able to do all these things. And I'm happy that you know personally our director, Professor Sukhich, and I presented him everything, and I spoke about our secrets, and it was the same surgical room. Thank you very much for that, distinguished colleagues. And now we are doing short technical break, and you can enjoy short video, and then the room will be given to Professor Vytis.
Яйцеклетка вышла в маточную трубу. Графов фолликул трансформировался в желтое тело. Наступает лютеиновая фаза менструального цикла. Желтое тело активно синтезирует прогестерон. Под действием этого гормона слизистая оболочка матки, эндометрий, утолщается, обильнее снабжается кровью, в слизистой становится больше желез. Так прогестерон готовит эндометрий к имплантации в него оплодотворенной яйцеклетки. Именно поэтому прогестерон называют гормоном беременности. Однако тот же прогестерон – один из факторов развития миомы матки. Эта доброкачественная опухоль возникает в виде узлов в мышечном слое матки – миометрии. Активный рост узлов происходит в лютеиновую фазу менструального цикла, а также во время беременности, то есть на фоне высокого уровня прогестерона. В клетках миомы содержится большое количество рецепторов прогестерона. Стероид соединяется с ними и в таком комплексе поступает в ядро. В нем прогестерон вступает в связь с определенными участками генов и активирует синтез белков, тканевых факторов роста и цитокинов. Эти специфические белки вызывают синтез ДНК и заставляют клетки миомы делиться, а также стимулируют в опухоли ангиогенез – образование сосудов. В то же время прогестерон подавляет синтез белков апоптоза – белков, контролирующих смерть старых клеток. Старые клетки не гибнут, новые образуются, узлы миомы растут. Женщины испытывают обильные и длительные менструации, чувство боли, давление внизу живота, боли в спине, часто анемию. Назначение гинестрила – один из современных способов остановить рост миомы матки. Препарат содержит синтетический антигистоген мифепристон. В клетках миомы антигистоген связывается с рецепторами прогестерона и блокирует их. Таким образом, не дает половому гормону соединяться с собственными рецепторами. Как следствие, тормозятся эффекты, которые зависят от прогестерона. Так подавляется синтез тканевых факторов роста. Миомные узлы не растут. Кроме того, через факторы роста гинестрил тормозит в узлах миомы ангиогенез. В итоге клетки миомы недостаточно снабжаются кровью, испытывают гипоксию, нехватку кислорода. Стимулируется работа белков апоптоза. На этом фоне клетки миомы не только не делятся, но и гибнут. Миомные узлы уменьшаются в размерах. Своевременная терапия миомы матки гинестрилом позволяет избежать радикального хирургического лечения, тем самым сохранить орган и репродуктивную функцию. Препарат отличается хорошей переносимостью, не вызывает симптомов эстрогенного дефицита, депрессию, не влияет на массу тела и свертываемость крови, не снижает плотность костной ткани.
Distinguished colleagues, let's move on, and there will be a presentation of our great Canadian guest, Vita Senekas. The title of her paper is Future Trends of Gynecological Surgery, What You Need to Know. After this, there will be Professor Zuev and Professor Andreeva, and then there will be the closing ceremony. Dear Vita, the floor is yours. You're welcome.
Hello to everyone. I'd like to first of all thank Professors Suhik and Adamian for their kind invitation to present at this Congress. It's always a pleasure for me to do so. And as usual, you have very exciting, up-to-date topics. Today, I'm going to be discussing the future of surgery and are you ready for this? I have a disclosure statement. I have no consultant or financial affiliations with any pharmaceutical or medical device manufacturer, and I primarily do consultant work for governments in capacity building and delivery of healthcare, as well as medical legal work. Now, what are the considerations for surgeons? Well, we really are like technicians. The more surgeries that are performed, the better they get at it. There is personnel behind the skilled doctor, anesthesia, nurses, other technicians, administrators, and it is, of course, a multi-step process of planning, preparation, and aftercare. The best comparison that we have actually in terms of advancement is the airline industry. Here, technology is widely used in all areas. There's training and performance evaluation using simulators. You have crew and staff behind the pilot. Safety is a top priority. There's always a review of misses and, more importantly, near misses. There is a black box in the cockpit that records everything. Autopilot is regularly used in flight, but interestingly enough, auto land is rarely used, less than 1%, and pilots actually report it's too labor intensive to watch all of the dials and the fact that they like to land the plane. So when technology works, it's great, but when it doesn't, craziness occurs. Now, what are the future economics of minimally invasive surgery? It currently is a market valued at $13.7 billion. You currently have 14 million laparoscopic procedures yearly. There's an expected compound annual growth rate of 1.8%, where the market will reach 15.6 billion in 2026. And here you can see here which countries and continents actually use laparoscopic devices and how that will change over the next 10 years. No surprise that North America has a heavy component, as well as Central Eastern Europe, and of course Asia, Western Europe as well. No surprises there. If we look at the US surgical robotics market, which is currently much smaller, in 2020, it was valued at 1.1 billion, but there is a compounded annual growth rate of 16.5% expected over the next 7 years, and you can see how significantly this will increase, where gynecology actually has a significant proportion of the robotics market. And again, if you look at which continents use robotics, almost half currently is North America, a quarter is Europe, and Asia Pacific each share the same amount. And currently in 2022, the market has risen to 4.4 billion. We still have to remember that there is a proportion of the population that doesn't necessarily have access to safe, affordable surgery as well as anesthesia, and it's no surprise in the very dark portions here that these are parts of Asia and parts of Africa as well. And this was reported by the Lancet. The other thing we have to take a look at is frequency of operations in a well-resourced health system. And you can see that maternal disorders occupy a very significant proportion. If you look at non-communicable diseases, the musculoskeletal system, the hips, the knees, and transport injuries are mainly your accidents. Now, how will the delivery of surgery change? It's going to be more complex, more centralized, multidisciplinary teams. Digital technologies and robotics will enable more routine surgeries to be delivered locally. Platforms will be needed to support this. There will be a growing demand of the aging population living outside metropolitan areas, and of course, the increasing trend of day surgery with little or no overnight stays. What are the innovations to enable and to review? First of all, we have to remember that most surgical interventions are introduced without clinical data or the evaluation of the risk to patient safety. We have to develop pathways to assess this. Compulsory registration of devices and novel technologies using real-time data. We have to also remember that the one-size-fits-all approach will not work. And of course, the submission of follow-up information to a central database and a framework will be required to oversee all of this. Naturally, there will be core indicators which will have to be monitored. So you'll need access to timely, essential surgery, the specialist surgical workforce density, how many doctors are available per population, the surgical volume that's needed, the perioperative mortality, and of course, the protection against impoverishment expenditure because of the cost of the surgery. Which technologies will have the greatest impact? If we look at minimally invasive surgeries, there is the opportunity for robotic introduction and machine learning to be done. This will reduce the variation in surgical performance and invasiveness of the intervention. Skilled surgical technicians may be able to perform duties under the supervision of a surgeon. Imaging, virtual reality, and augmented reality will exist, and of course, the introduction of artificial intelligence and machine learning. Now, like the Terminator movies, we see the rise of the machine. And what we have is miniaturized, data-rich, increasingly autonomous robotics, improving efficiency and impact. Gesture-based control will allow surgeons' requirements to be automatically recognized. High-resolution imaging with holographics. And what will happen is you can see, interrogate, and explore within the body before the incision and throughout the surgical process. If we specifically look at endoscopic gynae surgery, augmented reality is a system which is important because it overlays computer graphic images and real video images in a single perception of an enhanced world around the user. Fluorescence may be used, nanorobotics may be introduced, and what you have is improved computer vision, which gives you a better understanding to visualize the intraoperative physiology. The presence of a surgical black box like that in the airplane instead of a video recording, and of course, tissue engineering. What about robotic surgery over the next 5 years? The most important thing that's happened is thousands of patents have now expired with respect to the robotic surgical machines. So this introduces an element of more development by various companies. Like the television, you can envisage a smaller size, a lower cost, more providers in the market, and of course, robotics can undertake more simple automated tasks such as suturing and biopsy. What do we expect to see with robotic surgery over the next 10 years? Like the telephone, remember the size when it came out in the 90s and the size of the phone and the smartphone now. So we expect the robot to be maybe smaller, be smarter, standardization of procedures to employ skilled but non-medical trained health professionals for defined high-volume procedures. And I submit to you that the cesarean section actually may be one of those procedures. Small levels, mediated control, may be warning the surgeon of potentially dangerous dissection movements. There will be data collection, long-term outcomes to improve training, and of course, better ergonomics, making the surgery less onerous. Now, what this is going to force us to do is to rethink the surgical profession. Do technologies extend surgical capabilities or replace? What about empathy before and after the surgery? This will more than likely ensure that the service is irreplaceable by the healthcare professional in the age of robotics and artificial intelligence. We still will deal with virtual reality, augmented reality, where we do not lose touch with reality, but it has you visualize like having X-ray vision. Live diagnostics, so for instance, the use of mass spectrometer analysis of vaporized smoke to detect malignancy in the tissue that's being vaporized. But at the end of the day, we will still have to remember that laparotomy skills will be required. Now, just a few definitions about computer intelligence where we have to be clear. Artificial intelligence is the larger umbrella of computer intelligence. It's a program that can sense, reason, act, and adapt. You have recognition of patterns, problem solving, decision making, and a translation between language and visual perception. You then have machine learning, which is a type of artificial intelligence that learns from data and patterns and that they analyze rather than prior programming. You have deeper learning, which uses algorithms to analyze different layers of data, establishing hierarchical relationships between the output of one layer and the analysis of the next. So performance improves as they are exposed to more data over time. You have improved detection of potential pathology of image-based sources, and this has an expanding clinical usage. Will the machine replace the human? The health sector is least likely to be overtaken soon, simply because of the applied expertise and crucial human interaction. However, it can help to create more sophisticated and realistic simulation training. It can use clinical data to enhance diagnostic accuracy. The robot may learn from the surgeon, and there will be that hesitancy to utilize because of accuracy, cybersecurity, lack of empathy, and technological maturity. Now, what is the future operating theater going to look like? You will have a greater integration of digital technologies. Artificial intelligence will be used to schedule request instruments, monitor the environment. Digital systems will provide guidance, show enhanced imaging. Theater space will become more flexible and dynamic, and the equipment, of course, will become smaller and lighter. What about the future surgical team? The role of the surgeon may become blurred with others in the team. The surgeon will need to be a multilingualist, understanding the new language. Remember what it was like when computers were first introduced, that we had to learn that language. Leadership, managerial skills will become more important. There'll be a key role in the handling and acquiring of tissue samples. All of these are very important. And of course, what this means is that changes to training will be required. The curriculum content will need to change and be more flexible to reflect the surgical career and innovations as they evolve. There's going to have to be knowledge incorporation of computing, engineering, data literacy, leadership, team building, and communication. We're going to have to strive to ensure and enhance humanity. The high fidelity patient-specific simulation, remote monitoring and proctoring, and of course the entry requirements to the medical schools will reflect the diverse range of skills required. Now I'm just going to spend the last couple of minutes on chatbots in clinical medicine, and this is one of the most interesting areas of all. A chatbot is a software using artificial intelligence and natural language processing to simulate human-like conversations and text. Can be male, can be female, can even mimic some well-known personality. It can be used in healthcare to provide education, promote behavioral change, and you've already come across chatbots in dealing with some business models. There's the language model, the transfer learning, and there's that very interesting ChatGPT, which launched in the late fall of 2022, which interestingly enough has successfully passed parts of medical licensing boards in the United States, as well as parts of the bar examinations for lawyers. So we have to be wary of artificial intelligence. There was an even more interesting article which came out in JAMA just 5 weeks ago, where what they did was they had a series of questions which the survey users were going to ask of either a chatbot or a healthcare physician, although they did not know who was which. And these were the questions: the risk of dying with ingestion of swallowing a toothpick, the need to see a doctor after hitting your head on a metal bar while running, you had a headlamp, headache, and a sore neck, you're going blind, following bleach being splashed in your eye, you notice a small amount of blood following defecation, 3-4 weeks of a persistent cough, our lungs being damaged, or you notice a hard lump under the skin of the penis. So these were the questions that were dealt with. And surprisingly, here are the outcomes. In terms of quality of the response, the people thought that overwhelmingly the chatbot gave a better quality response than the physician in terms of very good. The physician certainly was in the acceptable range, but the chatbot outperformed. Even more interestingly was the empathy rating, We've always thought that empathy was a limitation of artificial intelligence, and you can see here that the chatbot actually performed better than the physicians, where in fact some were noted not to be empathetic at all. So what is the take-home message going to be in getting ready for the future? It truly is unlikely that robots and other products of rapid technological development will replace humans. Instead, what we have to think about is that medical professionals using artificial intelligence will eventually replace the ones who do not. And the question that I always say is between the words must, should, and can. What must a physician know about technologies and artificial intelligence? The obligatory stuff. What should a physician know about the same subject matter, maybe more tailored to the specialty area? And what can they know, which really may not be required, but just is added stuff? It's very clear that we're going to have to learn the language to change. It's also no surprise that the younger generations will accept, adapt, and change easier. And again, you only have to reflect upon computer usage to see this. But I think the key message at the end of the day is that we're going to see a complementarity in a successful way which has never been seen or dreamed about before. So I ask you to look at this take-home message for reflection. I think the greatest thing that is happening with artificial intelligence is that regulators are beginning to look at its usage, and as usual, the law is behind the science, and there we have some catch-up to do. So I hope this gives you some food for thought, and thank you very much for listening, and enjoy the rest of the conference. Have a nice day.
Dear colleagues, we've just listened to a wonderful presentation by Professor Vita Senikas. She has been working for many years with us. She is a great organizer. Well, she is a health manager, FIGO, a COG, and other organizations. She is also a consultant of the Canadian government. I liked this presentation very much and Vita's view of this problem. She gave us food for thought, as she said. Well, of course, we'll have to introduce artificial intelligence on a broader scale, but we should always remember about some danger behind it and some training. The training here must start at the very early stage. Dear colleagues, we're about to wrap up our Congress, and we did not overrun our time, so I'm absolutely sure that our director, Professor Suhik, is watching the Congress, analyzes everything, and I'm absolutely sure that if he were here physically, he would say a few words, but unfortunately, he is on a government mission right now. There will be two more presentations. Professor Zuyev, a professor at the Department of Obstetrics and Gynecology, the Sechenov First Medical University, and Professor Elena Andreeva. And then there will be the closing ceremony. Maybe we'll wrap up even a little bit earlier than according to the schedule. Gennady Suhik, I try to do my best. Maybe you will join in for the closing ceremony and wrap up this Congress. If not, I will perform this mission on my own. Dear colleagues, Vladimir Zuyev is our next speaker. He is a wonderful OBGYN. He will be talking about the new technologies in treating of intrauterine pathology. Try to be brief and logical. Distinguished Leila Vladimirovna, good afternoon. allow me to express my gratitude for the invitation to participate in this Congress. It's always a pleasure to be with you. Since the Congress is coming to an end, I would like to touch upon new options. There were two brilliant presentations devoted to the intrauterine pathology. I will just touch upon things that were not mentioned and mostly how this relates to reproductive surgery and medicine. What's new here? Well, first of all, I will speak about the use of laser in surgery and in therapy. Why lasers? Because our department has been dealing with those issues for a long time, and there have been a lot of studies devoted to lasers. We have new technologies, we have new diagnostic methods, and that is why here we have made great progress. But I should say that the developers have done a lot here. They are winners of the Nobel Prize, Prokhorov and Bazov. I met with Alexander Prokhorov several times, and I had a conversation with him, and Mr. Skabelkin, who is the founder of the Institute of Laser Surgery. He is going to be 100 years old this year, by the way. And I'm not going to talk about all the details here. Our colleagues covered different aspects, well, mechanisms related to the development of Asherman's syndrome, fibrosis, etc. But the question is, why? Well, lasers are used in office hysteroscopy, and today we can... Sorry, you have no slides. We have no presentation, please. You don't see my slides? No, we do not see your slides. There, dear, help our professor. There, Gibladze, well, I don't... Hey. Let's go back to square one. All right. As for diagnosis of intrauterine pathology, you can see the diagnostic methods known to you. I will just talk about the spectral analysis and optical biopsy of endometrium. Number 5, what is the optical biopsy of endometrium? I know that the Kolokov Center is also using it. It is used globally. It allows us to make the differential diagnosis of normal and change the tissues to see whether there is tumor or hyperplasia, etc. Second, the registration of cellular proliferation in endometrial glands as compared to the menstrual cycles in different areas of the uterine cavity. Third, we can determine the level of tissue oxygenation. That's important for patients with habitual pregnancy loss, Asherman's syndrome, uterine infertility, because the use of the surgical laser, and primarily we use Galmium laser. That's a new device. It opens up new opportunities, and naturally the restoration of the functional condition to restore the anatomy is very important. So as for fertilized egg, we must develop the fertilized egg properly, and of course this biopsy allows us to do this. And finally, this device serves to monitor cellular changes, and the treatment becomes personalized, individualized. That's important. So where do we use laser spectroscopy to treat female infertility, habitual pregnancy loss? Well, also they're used to diagnose tumor processes, hypoplastic processes. As for the procedure per se, it is totally painless. Well, there is a device that registers the spectral information from the light diode. The light reflects from the biological organ. Within 1 minute, we can get the results. The software makes the assessment. It's a new software. It can work miracles, and we get enough information about a particular tissue. Other methods do not allow us to do this. Well, here you can see that we can use several points inside the uterus. Well, the fundus, internal os, and in the middle of the uterine cavity, and we can assess the uterus using this method. Our colleagues and practitioners often ask us what should we pay attention to when we make this diagnostic procedure. First of all, the procedure is done twice: before the cycle, before the proliferation cycle, and after, when we have the secretion phase, when the implantation window is formed and pregnancy starts. If we have the figure up to 10, the procedure should be repeated during the entire procedure. Barrier contraception should be recommended. During the procedure, the patient should not feel anything. This is a totally painless procedure. We never use tenaculum forceps. And if there is pain, well, there should be no diagnosis. Here you can see the optical part of the device, and after the procedure is done, it will be discarded. Well, oxygenation, functional condition of the endometrium while preparing for pregnancy. Well, we believe that this is a very important aspect. Also, proliferative activity of the phases of the cycle. Depending on what day we do this, we assess the morphology and the structure of endometrium and the presence of inflammation. Here you can see the assessment of oxygenation. This is the oxygenation index. In the past, we did the mathematical analysis. Now there is no need to do it because everything is done automatically. At the right-hand bottom corner, the normal oxygenation index, well, moderate hypoxia and severe hypoxia that allows us to make a decision whether this woman is going to be pregnant and how the pregnancy is going to develop. If oxygenation is 30% low, there will be no pregnancy. But if the oxygenation has dropped by 10 or 15%, theoretically pregnancy can occur, but there will be a higher risk of pregnancy loss after 15th or 16th week because the fetus will not get enough oxygen. And at the same time, we do the assessment of the morphological structure of the endometrium. There is the structural index showing, for example, the receptivity of the endometrium, to what extent, well, it corresponds to the specific phases of the cycle. Again, everything is done automatically, and there is a software for that, and it gives you the figures showing the level of proliferative activity depending on the day of the menstrual cycle. Here you can see the porphyrin index. If it's less than 1.5, it's normal. If it's more, it's the abnormal situation. Here is the atrophic endometrium monitoring. 1 or 2 visits of the patient, and we can detect atrophic endometrium, and you can see the treatment dynamics. Well, porphyrin 9 is a specific substance which is formed when bacteria break down, and you can see the tissue pulse oximetry of the endometrium. And we can assess the blood flow using the pulse oximeter. Here is the Obstetrics and Gynecology journal. There is an article published there. These are women who came to the reproductive medicine clinic when they had some problems such as pregnancy loss or infertility. So basically we managed to restore their infertility, especially women who had several cases of embryo transfer, the maximum 18, but the pregnancy rate was 68% even among such women. Here you can see the results of our study and how we worked with the obtained data. Well, parallel diagnosis of endometrial cancer. We know about the clinical meaning of that, and we got different parameters characterizing the active proliferative activity of endometrium, which allows us to use traditional methods of diagnosis. In fact, we can do the assessment and we can identify the risk group, and then we start treatment after diagnosis. And here you can see our own observational data, how oxygenation parameters change in women who had COVID-19 but were already on the IVF program or ART program. Here you can see a woman came to see us. She got COVID-19. She was quarantined for 2 weeks, locked up, and then she went to the clinic again to finish this ART program. You can see that there was a 20% drop of the parameters, such as the oxygenation level. But here you can see severe hypoxia after the coronavirus infection. You can see the level of oxygenation dropped almost to 0. So that's a borderline state, hypoxia and ischemia. And of course, in this case, pregnancy will never occur. And thus, we can draw the conclusion that the earlier we start rehabilitation measures, the faster we can restore the functional state. There was a group of women who did not just come to the clinic right away for the embryo transfer, but that was late presentation for 3 months. There was this kind of picture, the Raman light dispersion. There is the fluorescent diagnosis and Raman diagnosis. Well, Raman spectrography, and you can see that Raman can give us very good results. And here is our new test to assess the blood plasma in women with hypoplastic processes and adenocarcinoma. Here you can see that Raman dispersion of light is different, and we took some samples from this woman. There are women with polyps, and there are women with adenocarcinoma, and the control group, 3 groups, 25 women without pathology of endometrium, 41 with hyperplasia, 29 with verified adenocarcinoma. So these Raman peaks give us the following information. First of all, we do the diagnosis at the level of oscillation of intramolecular ties, and we see these Raman peaks on the graph. These peaks correspond to specific biochemical substances and the amount. For example, you can see proline D-mannose, phenyl ring fluctuations. The Raman diagnostics allows us to do the molecular assessment of intramolecular connections, and we get very precise results, like, you can have very precise information at the individual level. That means, like in this case, a normal metabolism of DNA base, also poor glucogenesis, and also poor metabolism. As a result of that, as for adenocarcinoma, it occurred in 85% of cases, and the control group adenocarcinoma was 80%. As you can see it here, so these are quite precise diagnostics, and the accuracy was more than 90%. Thus, Vladimir, I'm sorry, but you overran your time. Gallium laser is used in reproductive surgery, and thanks to this laser, we achieved unique results. It's safe. Thank you for your attention. Thank you. We've known you for a long time, and you are an innovator using lasers in intrauterine surgery. That's your main specialty, on top of being a nice scientist. Sorry, but you did not have enough time, but anyway, that was a wonderful presentation. Dear colleagues, I'd like to give the floor to Professor Andreeva. Helena Andreeva, the role of gestogens in HIT and MHT, analysis of clinical case of uterine myoma. And as soon as this presentation is over, we'll move on to the official closing ceremony of our 36th International Congress. I'm a bit tired, but nevertheless, we'll congratulate each other at the end. Professor Andreeva, you are the Deputy Director of the Center of Endocrinology, the Director of the Institute of Reproductive Medicine, a Professor of the Department of Reproductive Medicine. You have a wonderful presentation, and please try to be as brief as possible, because we've had already these issues covered at this Congress. Please. Good afternoon, dear Leila, dear colleagues. I am not going to repeat what has already been mentioned by our foreign colleagues and by our Russian speakers.
The topic of my presentation that has already been discussed many times today, because we spoke a lot about surgical intervention, but the best surgery is surgery which is not done. And if we can do something, at least something that can help us to avoid the surgery, this is very good. And it should be welcomed, strongly welcomed. Starting from 2015, we signed a number of clinical guidelines led by Professor Adamian as a chief gynecologist with the Ministry of Health. So that would be fibroids, and the last update happened in 2020. So possibly this year, by the end of the year, we will be able to present the next draft to the Ministry of Health, new guidelines dated 2023. Well, and these are fibroids. We know very well that uterine fibroids could happen at early age, early reproductive and perimenopause and later. And the most important objective of treatment is to minimize the symptoms, prevent invasiveness, facilitation of the fast recovery, and preservation of fertility is needed. We clearly understand that it could be a problem related to the infertility, it could be miscarriage or recurrent miscarriage rates. So that is why we need mini-invasive or minimally invasive methods of treatment to avoid very deep invasive procedures if possible. These methods should effectively preserve or recover fertility, reducing clinical symptoms at the same time. We fully understand that we sometimes have asymptomatic myomas, and frequently we see symptomatic one that is associated with massive menses, anemization, and reduced iron, feeling of heaviness at the bottom of the belly, so frequent urination, dyspareunia, and disorder of fertility. And the structure of the tumor could be characterized by strong heterogeneity in the same patient, which is confirmed by the growth rate of proteins, expression of proteins, and some other fragments. It could be very different in the same node. So currently we follow International Disease Classification version 10, so very soon we'll switch to version 11, but actually the coding would be the same. And speaking about the surgical conservative treatments to the management of fibroids, still be based on FIGO classification of 2018. Today we already heard that the key role belongs to progesterone and its receptors, PR, and their influencing the growth of myomas. And progesterone treatment, which was massively used in the 1970s, unfortunately leads to increased cellularity in the mitotic activity in myoma nodes. Especially it is seen in the pregnancy due to the edema, and the number of nodes is increasing mainly within first 10 weeks of gestation. Well, we have different myomas, different fibroids. It could be fibroid with sclerosis, where there are fragments of vessels and sclerotic tissue. It could be simple fibroid, which is microcirculatory flow with prevalence of precapillary and postcapillary component, and also anastomosis in between, and also proliferating fibroid, which has a lot of true vascular capillary loops, lots of newly formed neovascularization and different lesions. The objective of medical treatment is to minimize or eradication of the symptoms related to the fibroids and maximum reduction of the regression. So, and I'm just quoting the guidelines of 2020. So it is recommended to provide conservative treatment to patients with fibroids to resolve the symptoms, pain syndrome, and concomitant gynecological diseases, and the level of evidence C. And you see that the most important objective of medical treatment is elimination or liquidation of the symptoms, and we have to assess not only efficacy but also the safety of this treatment, tolerability, and cost efficiency of the treatment. At the same time, the medical treatment in patients should be assessed every 3 months, and if there is non-efficacy, then we change the treatment or move to surgery. So today, we can use drug treatment, and mainly we use both of previous nodes which were removed, and also if there is uterus, then relapse is possible. And 59% of females who had conservative myomectomy had secondary surgery, and we understand that the risk of pelvic adhesions is massively increased after the second myomectomy. Today, the very prevalent are mini-invasive surgical interventions, symbolization of the uterine arteries, but we should remember those who have not yet completed their reproductive function according to our clinical guidelines on fibroids and infertility treatment. So this procedure is contraindicated. We can use focused ultrasound ablation for thermodestruction of myomas, and there are more and more options of medical treatment for the preservation of the reproductive function and ovarial reserve. That's why we are looking towards using agonists of gonadotropin-releasing hormone. We have a pool of treatment: gazareline, rapeline acetate, buserelin, triptyline acetate, and PAMOD, and also a number of drugs produced in the Russian Federation. So we can say that we counted the number of nodes, and these are hormonal treatments which are quite limited with duration, maximum 6 months, keeping in mind adverse events and estrogen deficiency. Most frequently, they are used in the combined treatment if there is fibroids with other proliferation types, for example, adenomyosis. In the world, also, we see antagonists of GnRH, and they have good clinical evidence-based data in adenomyosis and fibroids, but unfortunately, they are not yet registered in the Russian Federation. So according to our clinical guidelines, we can use NSAIDs and tranexamic acid to minimize the abundance of the menses, but it cannot influence pathogenetic reason that should be mainly focused on minimization of the risk with fibroids. As I said before, progestogens and progesterone in Perros mode can reduce the clinical symptoms of pathogenic menses in the cyclic regimen starting from day 14. The efficacy is 20%. In 21 regimen, the efficacy could be 30 to 50%. But progestogen do not provide influence to the stabilization or reduction of my fibroid nodes. They could be used only for the prevention of hyperplastic processes, which are frequently coincided with fibroid nodes, and they should not be used in submucosal localization. So there are many recent publications showing that as progesterone is involved into the pathogenesis of disease, so the use of progestogen for fibroid treatment is like continuous adding oil into the fire, which makes the treatment non-effective. In our clinical guidelines for the treatment fibroids, we can use levonorgestrel, Mirena, intrauterine device, although the indications for fibroid are officially absent, so we can use it only for the minimization of the massiveness of menses and increased thickness of endometrium as a prevention of hyperplastic concomitant processes. Also, we cannot use this system in the submucosal localization of the nodes and also in myomas with the intraepitel growth. Separate story for the option to use COX for treatment of massive menses. In the short-term perspective, they could be used for the improvement of severe menstrual bleeds related to fibroids, but at the same time, they do not influence the uterine size or minimization of fibroid size. If you use COX, it's recommended to have precise monitoring of the uterus and its size. Here you see the publication about the use selective modulators of estrogen receptors. Raloxifene is not registered, but we have tamoxifen. These are most frequent options for fibroids, but yet it is not quite prevalent option, unlike selective modulators of progesterone receptors. Selective modulators of progesterone receptors could suppress late maturation of follicles, block LH release, and provide direct anti-proliferative effect to endometrium, besides other effects that depends on the drug and the dose. At the same time, with the treatment with the progesterone receptor selective modulator, we don't have hypoestrogenic situation and we don't see the bone mass loss. We clearly understand that these treatments open new opportunities. We can effectively use them for resolution of symptoms. We can prepare the patient for the surgery and restore the level of ferritin in one specific patient. Also, we can prevent relapses post-op in patients with a high risk and also prevent further fibroids if there is high genetic predisposition. These options open new horizons for the medical treatment of fibroid, both for minimization of the symptoms and eradication about the need of surgery. So today we have two options in the market, which is mifepristone and ulipristal, and both can be used effectively. Ulipristal is less used currently because it is sort of a loss of efficacy in the market, and yet there is no rehabilitation of that, and The other one, mifepristone, is first the agonist of modulator of progesterone receptors, is used for more than 25 years and actually presented in the market, including the Russian production. So you see here that there is tissue-specific effect on progesterone receptors. Also, there is a complete profile of agonist or antagonist progesterone receptors, and also we see mixed options, agonists and antagonists. We know for sure that in 10 to 12% of the females, the use of progesterone receptor modulators provide thickening of endometrium up to 16 millimeters. At the same time, we do not see any atypia, and we know that for sure in the recent years. So indications to the surgery is not indicated, and also extension of secreting things also not here, and very different thickening of stroma and non-homogeneous stroma, which is going in a menstrual-like reaction. And today, you see terminated 12-week courses of the selective modulator of progesterone receptors when the interval with treatment-free as a long-term medical treatment of myoma, of fibroids. And the results of the first long-term studies showed and proved that more than one cycle could maximize clear advantages from the point of bleed control and reduction of fibroids volume, and correspondingly we can use 3 months break and then we can repeat all these cycles. Mifepristone, I remind you, this is synthetic non-steroid selective modulator of progesterone receptors, mainly with antagonistic activity towards progesterone receptors, so actively used in different doses, frequently presented, and mostly it is used as a dose of 50 milligram within 3 months for the treatment of uterus myoma. And here on the side you can appreciate very different meta-analysis, Cochrane reviews for the last few weeks with different doses. And with mifepristone, we can reduce the volume of nodes and myoma itself, fibroid itself. When we compare the efficacy of selective modulators of mifepristone in the dose of 50 milligram, ulipristal acetate and agonists could make effective combination in patients with fibroids within 3 months. And then it was concluded that mifepristone is more actively transforms proliferating fibroid into the simple one and has the most preferable safety profile. You can adjust the dose. Agonists, they reduce the size if there is combination with adenomyosis, and the use of agonists of GnRH could give us some side effects versus ulipristal, and they are less preferable. And mifepristone requires examination in order to administer safely. That is why more and more frequently our specialists pay attention to mifepristone in the dose 50. There are multiple trials. Clinical trials and real-world trials prove that the efficacy of treatment is up to 86%, and this is the data of the Russian study that absolutely coincides with pivotal international trials. And then we can prove that we have definitely highly effective and safe treatment. And expression of progesterone receptor gene and mononucleus in peripheral blood could be the marker, and it has negative correlation with the success of further treatments. Currently, we know, and we should understand, how our drugs could influence ovarial reserve in those patients where reproductive function is not yet completed. So here you see one of the publications in Bashkortostan, where the authors say that mifepristone has no negative influence to the ovarial reserve of the patients, and correspondingly could be welcomed in the female with non-yet completed reproduction function. And in the medical treatment group, we see very many indications, and we don't see big differences in AMH within 3, 6, 9, or 12 months. So it's not getting higher or lower, so that's baseline level, which is sustainable. So mifepristone has no negative effect to the ovarial reserve, which is advantage, and it is a method of choice for fibroid treatments among young females with not yet completed reproductive potential. And please remember that Today, we can assess potential marker prognosis of the efficacy for the females, for the patients with hormonal treatment, because we see, we can measure the level of mRNH, nuclear receptors of glucocorticoids in mononuclears, and this test is available. And if we see increased expression, that possibly we see non-responder. Even in any very good treatment. That is why the intensity control of menses is very important for the mifepristone, because finally we can restore the hemoglobin level and improve the general condition, functional status of the patient. That is extremely important, especially if we speak about preconception preparation. So the use of gynestril give us positive effect not only for the reduction of node size and uterus size, but it is also associated with minimization of benign features by the end of 3 months treatment. And if we see deficiency of progesterone, mainly these are diffuse forms, and also anti-relapse treatment of fibroids, where gynestril is indicated. After surgical interventions in patients with high genetic predisposition to fibroid formation, so after the surgery, we can safely administer at least 3 months duration gynestril course to prevent the relapse of the nodes and for further implementation of the reproductive function. With that, I thank you very much for your attention. Distinguished colleagues, dear friends, I would like to thank Professor Andreeva for brilliant presentation. And she is fantastic endocrinologist and gynecologist. She's a student of mine. She's a professor, and She knows very well most important vulnerable issues in gynecological endocrinology and non-surgical methods. Well, dear friends and colleagues, I'm happy and excited to finish our Congress timely. So we have been working intensively for 4 days. Please show my slides. And this is official closing ceremony of the Congress. And this is official data on how we were working, how many connections and participants, and what were our results. So I appreciate slides with statistics. Dear colleagues, June 6 to 9, from early morning to late evening, from 8 a.m. to 8 p.m., almost daily, we had International Congress of New Technologies in gynecology, diagnosis and treatment of gynecological diseases. So this Congress was carried out by the Center of Obstetrics and Gynecology. So this is already 36th Congress, but in fact, this is 52nd International Congress. Our Obstetrics and Gynecology Center, named after Kulakov, took this mission many, many years ago in the design of very many new methods in carrying out educational awareness, influence, and plus international contacts. It is due to the fact that we have such fantastic center, we have huge international audience, we have a very large scale, famous names from all over the world. I'm extremely happy that we have this great opportunity, not only study ourselves the very new methods, innovative approaches, methods of treatment, but also to share, to interact, to discuss, which is very valuable, to share the contacts we already gained. We had broadcast within these 4 days, from June 6 to June 9, the largest, very well-equipped and technological digital sites. And we have been in this RIA Novosti site. Day one of the Congress started. To me, it was like a big festival, like a big day. But in fact, it all started at a very high level. Our Congress was launched by the director of Obstetrics and Gynecology Center, our leading center academician, Gennady Sukhich. And then he gave the floor to the minister, and there was a welcoming of the minister, and that was very deep and very comprehensive. I know that Ministry of Health has great attitude to our center, with big reputation, with big respect, but the words that were said about our role in obstetrics and gynecology, in the design of new methods, in the training, in the training and education of the regions, carrying out these huge, large-scale activities all over regions of Russia, especially in the recent years, is very important, because we have now different options. We have a big school of chief specialists of the region. So that was very pleased to hear from the minister, and our best compliments to the ministry. Also, we were welcomed by the lead of Roszdravnadzor, Alla Samoylova. Also, very nice words were said, the words of appreciation, and it's all very important to us because Alla, as you probably know, she is obstetrician and gynecologist herself by her background education, as well as Dr. Murashka, Minister Murashka. They participated in our congresses, and they truly know how significant it is to design new technologies, how important and influential are the congresses that are organized and carried out by our center. And I hope in the near future we will have another opportunity when from the one side, from the ORs of our center, we have been doing surgeries in online and broadcasting them inside the site, and several surgeries were shown on the same screen. So that's very strong educational program. And I'm extremely happy that today our center is not just the obstetrics and gynecology center. This is center of perinatology. This is center with the Ministry of Health, and this is a center of also fundamental studies, fundamental medicine center, where at the highest level we can carry out genetic studies, immunological studies, where we have most important, very novel methods which are available in other countries, and also some methods that are designed truly by us. That is why we are on the cutting edge in this science, due to the fact that we work all a lot, quite a lot, and I'm very grateful to my students, and also I'm very grateful to the director of our center, academician Sukhikh, Gennady Sukhikh, and I'm absolutely sincere, because he brought to our surgical science that I love lots of novel and fundamental technologies. And we never thought about stem cells. We never thought about these very new methods of the recovery, reparative regeneration. So all that was available for us 30 years ago. In our center, we had fantastic studies of congenital immunity that all the world now is looking at. So currently, our obstetrics and gynecology center, as Gennady is saying, so that's a huge line moving forward. Well, I had a hard understanding. I hardly understand what it is, but I believe that this is a line that carries all possible technologies, all brain of obstetrics and gynecology, surgery, etc., etc. So, distinguished colleagues, our scientific program consisted of 7 plenary sessions. 7 plenary sessions. These plenary sessions were devoted to the complex approach in the diagnosis and treatment of endometriosis, adenomyosis, and new opportunities of technologies in gynecological surgery. Comprehensive new approaches to the treatment of very different gynecological diseases. Also, new technologies in the diagnosis and treatment, then oncoprevention, which is important as well. Also, relevant issues of gynecology from the position of technology, as well as the rehabilitation, diagnosis, and different approaches using MRI and other many new methods in our specialty. Our center gained a very new robot. That is why one of the plenary sessions was completely devoted to the robot-assisted surgeries. We invited to our Congress leading specialists, stars, international stars in this area, starting from the godfathers of robotic surgery, and then those who are continuing this development, and they are actively developing this specialty. I'm very proud that the keynote lecture was made by Asya Stepanyan, because she graduated our center. She's a student of our center, and she's a great intellectual, and the presentation she made, well, I don't know, because I'm here already for 4 days, but I believe that was really fabulous. That was fantastic. It was fantastic orchestration of all modern knowledge, and I'm very grateful to Asya for making this fantastic and setting up the stage. So we had 3 days of SIM Center on hysteroscopy and laparoscopy and robotic technique, with the broadcast of the surgeries from different countries. Unfortunately, our Congress was carried out in online regimen, but, well, here in online we do have some beauty, because at the moment we were followed by 3,380 participants, and totally, all in all, we had about 20,000 connections and 20,000 participants. We also carried out the School of Experts. There were direct broadcasts, plus the competition of young scientists. And now I will speak in more detail about it. So, the most important business case of our Congress is the participation of colleagues, experts from all countries, 14 countries shown here, and our distinguished guests from international countries. Please appreciate, the biggest delegation was from the United States of America. Here you see all the participants, and this is exactly at this very turbulent moment when many congresses and events are cancelled. And you know, there is a special situation, and we are for more than 2 years already with COVID and consequences of COVID, and we have to carry out congresses online. So all in all, 18 colleagues from United States, 3 from Israel, 5 from Spain, 5 from Japan, 6 from Germany, 5 from France, 11 from Italy, and 3 from Belgium, and all in all, 100 presentations, 60 international colleagues, 40 Russian colleagues, and 27 from them is center of from our staff. If we just mention that, it means nothing. In each column here, you see great people of our planet. They established methods. I'm not naming them all the time because some of them could be offended if I miss someone. So these are godfathers of robotic surgery, also studies about endometriosis, endoscopic surgery. So only if you name such people, these great names, Jacques Camus, Arnaud Vattiers, Mario Malzoni, Dr. Magrino, Professor Magrino, Professor Maresco, Professor Bettocchi, Professor Bigazzi, Professor Jacques Camus, then fantastic experts who helped and who carried out our simulation sites, Armando Romeo, Professor Kongings, Lucia, Bettocchi. So all of them, each name here at our Congress, these are not just our friends.
Как в основе, так и сегодня.
In the basis and also in the current modern gynecology. So our colleagues who are here from America, from other countries, in the direction of geneticists, this is team of Dr. Treffer, Dr. Morin, then geneticists who actually established very new assays and technologies, and they have greatest attitude to the studies we carry out in our country and in our center. And Professor Vidal, who actually transferred immunology to the machine learning, and he himself offered joint projects with our center. Distinguished colleagues, our Congress showed that we carry out not only live surgeries, not only broadcasts, not only training with surgery and new technologies, but we are also the trendsetters in the novel technologies, in the diagnosis, in fundamental medicine. And I'm not afraid to say, and I'm proud to say, that it's a pity, really it's a great pity, because you know, when I started gynecology and obstetrics many years ago, so there were no special trials in genetics and immunology like now. But even at that time, 30 years ago, we were also quite ahead. We were in the front line and we were at the cutting edge. Distinguished colleagues, I want to show our fantastic staff. Please appreciate those who participated, region, mainly St. Petersburg, Rostov-on-Don, Kazan, and many other sites, and I'm speaking about the speakers now. Moscow was actively presented. Please appreciate, largest center of Moscow, largest centers participated in our Congress. And I'm really amazed by the results of this conference. I'm thrilled, and I can show more and more pictures like this, and you know very well all these things. And Professor Maresco is here on the first slide. Maresco, who is creator of robot. Maresco and in Strasbourg, he's a key person in the new robots. We not only appreciated new robotic surgeries, but also we heard from him, and he shared with us his valuable knowledge, what could happen next. He looked into the future together with us, and he's always having a great attitude to our country and to our center, very friendly, highest loyalty, and he's offering great cooperative projects to us. Dear colleagues, we managed to do impossible. We managed to make the broadcast of very unique as well as standard surgeries from the ORs of Italy, Dubai, America, India, Japan, And I want to say that our Congress really succeeded, demonstrated greatest power of our science. Otherwise, all these speakers would never be with us, not even in the recordings, but mainly in the live connections. And I have to emphasize the role of our national scientists. Please appreciate every presentation, one better than the other. And they're all in the list. So these are professors from our center, almost all of them. Professor Krечетова, the group of geneticists from Professor Trofimov, Professor Kuznetsova, also Professor Smetnik, Professor Uvarova, Professor of my department, Professor Andrei Kazachenko, Rakelan, and very young MD, PhD, Dr. Popryduhin. So we have to work like this. We should make it possible. Like in the family, we have seniors, and then their children, their grandchildren, and even great-grandchildren. And no one is quitting this family. Everybody want to be here. Everybody want to share his or her knowledge, be trained, be aware about novel, innovative options. Well, it happens. Well, of course, I'm very much excited. I'm changing the pages, and I forget to show it to you. Please appreciate. Look at these fantastic speakers, and these fantastic professors who were very kind to carry out their mission. And I would like to say a few words about the competition of the young scientists. The competition of the young scientists was also very successful. We paid attention of young scientists, not from the position of what they achieved, but so they were from very different regions, but we had the bar very high, so it should be younger than 30 years, younger than 30. And here we appreciated the participation of our youngest colleagues, junior colleagues, and some of them designed new surgical methods, new approaches in surgery, and the others managed to carry out unique studies in fundamental science. And later on, I come back to them and speak about it in detail. So totally, according to the intermediate statistics, we had 3,814 participants, almost 4,000, from 29 countries, 449 cities, 85 entities of the Russian Federation, 3,370 participants, 105 speakers, 331 young scientists. Distinguished colleagues, please appreciate this geography. Please appreciate the statistics. This is our big country. This is our great partnership. So we carried out fantastic educational project. According to these statistics, at the moment, we had minimum 1,800 connections, and the total number of participations by now is already more than 18,000 connections. And we had huge number of responses, and we have received feedback. And like a dessert, I want to tell you who is the winner of our Congress. We have selected the winners. There is prize 1, prize 2, and prize 3. And in each one there are 2 directions, purely surgical, according to new technologies. And then the fact that these young scientists, at their very young age, from 23, then up to 30 maximum, managed to do. So the first place, the laureate, the first laureate, and we discuss it all together with our center, is given to Tatiana Sukhareva from Moscow, age 30. The title of your work is Improving of Diagnosis and Surgical Treatment of Patients with the Scars on the Uterus Defect after Cesarean. And Irene Grigoryan, age 26, Reproductive Health and Addiction to Psychoactive Substances, Modern Technologies in Diagnostics and Treatment. We fully understand that, like whole world, we are in the demographic phase. So we have a huge problem with demographics now, but we also understand that 50% are in the hands of the young females. And it all depends on their behavior, on the epigenetics of how they eat, what they do, whether they go in for sports, and how intellectual they are, or maybe they have some bad habits. And it appeared to be that the whole world now is very much concerned on the fact that lots of psychoactive substances are disseminated around. So that was the task, and task was completed excellently. So this work will be published very soon. And she designed not only the tests, but also the questionnaire, and she identified the pathways we can go and identify proper risk factors and ways of addiction and ways of early diagnosis. The laureates of the second laureates, Ksenia Lukyanova, age 30, from Yekaterinburg, genetic predictors of pelvic floor dysfunction development after delivery. Genetic predictors, so it's very well to know in advance who has different chances, risks mainly of prolapses or incontinence or other challenges. So mainly that's about adult females. But this work from Yekaterinburg is really fantastic, and we paid attention to that, and she's just 30. And Laura Pivazyan, age 24, Moscow. Modern technologies of PGTA in infertile females. Who and when? She carried out and published meta-analysis of 19 clinical trials with huge statistic power. And these are the laureates, second laureates. The third laureates, Anastasia Shumekina, age 23, Novosibirsk, clinical and morphological justification of cervical cancer relapses treatment. Well, cervical cancer is getting younger and younger, and we have to say no to this disease because we need to implement screenings, fluid cytology, HPV testing, ultrasound of pelvis, and also anti-HPV vaccination. And then we will never have severe cases of cervical cancer where we are fighting for their reproductive function, and we are fighting with very severe surgical and other injunctive interventions. Also, the third laureate is Oleg Ivanov, aged 25, from St. Petersburg. Also fantastic work. Modern suturing material and influence of coagulation energy on the suturing material. So we believed that it really deserved the publication. We believe that these works, these projects should be disseminated. So they should be published in the central journal, and it would be our possible journal, and we will give them this bonus. These works have to sound loudly at our Congress Mother and Child in autumn, and maybe these very young and very talented students would be able to invited to go to the International Congress. Well, such colleagues, such young scientists should be very close to our heart, to give them more opportunities, to make them excited, to invest into surgery, to invest into science. And the one who moves manages the roads, and our future belongs to our children. So, dear colleagues, I don't know what else I can say. Well, usually our director finalizes the Congress, and normally I ask him to do it, and definitely at the end we have the words of gratitude. I said from the very beginning, many thanks to the Center of Obstetrics and Gynecology, and first of all to our director, Gennady Sukhych, who actually supported us during all the Congress, listening to our presentations. And I don't know what his position is, but I'm sure that we deserve the best assessment. So my feeling that it was at the highest possible level. I'm also very grateful to Ekaterina Yerodskaya, who for many years, during 50 Congresses is supporting me very actively, because it's a very challenging task. And also I'm very grateful to Ася Stepanyan, who is very distant America, so very tender and intelligent hand was supporting us, and she was tracking us, and she was very helpful in the communication with international specialists. Also, I'm very grateful for the technical support. It's extremely important, and the technical support is RIA Novosti. And I'm very proud. I'm very proud by our country, by our opportunities. So no second of drop, no second of drop. Although there were 29 countries and a very capricious connection. So everything was at the highest possible level. And also our Center of Obstetrics and Gynecology also demonstrated the best technological solutions and equipment. And Dr. Kazankov and Dr. Demyanenko supported us very actively. Also, I'm very grateful to Salamovo and Knyazeva Media Expo. I am very grateful to my grandson, Eduard Osipov, who for many congresses, specifically carries out here his birthday, because his birthday on June 6th, he always stays here. And before the Congress, he is supporting, because he's very fluent with several languages. He's supporting with the communication with our international colleagues, and also he is providing local help during the Congress directly. And at the very end, I can tell you that this is a great happiness that we have our country, that we have fantastic, intelligent, spiritual, and educational and scientific potential. And it all supported us during these 4 days. And before that, for many weeks, for many years, we were supported by Olga Koleva and Roman Mironov. With that, I would like to announce our next Congress, which is Mother and Child, Congress number 14, that is scheduled for 27-29 September 2023. Mother and Child 16th Congress in St. Petersburg, which is about to be carried out in June, 29-30 of June in St. Petersburg. And I dare announcing our future Congress, our next Congress, International Congress on Reproductive Medicine and Surgery, which is scheduled for winter. It would be 18th Winter Congress and 53rd International Congress, which is carried out by our center, Congress on Reproductive Medicine. And if possible, we would be praying, we would be happy, and we hope to be blessed that this Congress would be carried out from 16 to 19 January 2024. So, distinguished colleagues, I believe that I tried to do my best, and hopefully I completed my mission. I wish you all the best in all these very turbulent times. Well, COVID is still here. COVID is still persisting. Also, we have many other challenges, as you probably know, and you can fully understand what I'm talking about. It's not simple, it's challenging, but we are doctors, we are healthcare professionals, we have to be progressive, we have to be positive, we have to support each other, and we need to be very patriotic. I wish you happiness, love, well-being. Dear ladies, please take care of your men, of your homes, your children. Take care of our country. I wish you all the best. I kiss you, yours, Leila Adamian. Thank you.